Καλημέρα στη δεύτερη μέρα του συνεδρίου. Νομίζω πως μπορούμε να αρχίσουμε ελληνικά και φυσικά όταν συνδεθεί ο κύριος Σούβη νομίζω πως θα είναι καλά οι παρουσιάσεις να γίνονται στα αγγλικά. Έχω την χαρά και την τιμή να έχω τους συμπρόεδρους μου, τον κύριο Τάγκα και τον Σταμάτη Δεμόπουλο, την ψυχή του προγράμματος καρδιακής ανεπάρκειας στον Άσιο, ο οποίος θα μας απευθύνει ένα σύντομο χαιρετισμό. Σταμάτη.
Ευχαριστώ πολύ. Γιάννη, καλημέρα. Αιχμή του δώρατος στην επεμβατική καρδιολογία, οι προχωρημένες, οι εξελιγμένες διακαθετηριακές βαλβιδικές θεραπείες, στις οποίες, Γιάννη, πρωτοπορεί το νοσοκομείο μας, με ηθήνοντα νου τον πρόεδρο του συνεδρίου, τον διευθυντή του αιμοδυναμικού διαργαστηρίου, τον Γιάννη τον Ιακώβου, τον οποίον ευχαριστώ ιδιαίτερα για την τιμητική πρόσκληση, αλλά πιο πολύ θέλω να τον συγχαρώ για το εξαιρετικά εκπαιδευτικό πρόγραμμα που έχει συντάξει. Εμείς, οι καρδιολόγοι της καρδιακής ανεπάρκειας, ιδιαίτερα της προχωρημένης, με πολύ μεγάλη ευχαρίστηση δεχθήκαμε τις διακαθετηριακές επιδιορθώσεις της μητροειδούς βαλβίδας στην καρδιακή ανεπάρκεια, ευελπιστώντας ότι θα γυρίσει το ρολόι του χρόνου πίσω, παγώνοντας και βελτιώνοντας το λειτουργικό στάδιο του ασθενούς, δίνοντας έτσι πολύτιμο χρόνο στους ασθενείς μας, ιδιαίτερα σε ένα περιβάλλον χαμηλής προσφοράς οργάνων, πολύτιμο χρόνο για την ανέβρεση του πολυπόθητου μοσιαίματος, αλλά και στην καλύτερη εκδοχή, βγάζοντας το βελτιωμένο ασθενή από τη λίστα μεταμοσχεύσεων. Όλα αυτά βεβαίως με την προϋπόθεση ότι με πολύ προσεκτικά κριτήρια επιλέγονται οι ασθενείς για τις διακαθετηριακές βαλβιδικές θεραπείες, ενώ παράλληλα δεν θα πρέπει να χάνουμε πολύτιμο χρόνο για την εφαρμογή προχωρημένων θεραπείων στην καρδιακή ανεπάρκεια. Το τραπέζι που ακολουθεί με τις διακαθετηριακές επεμβάσεις στην τριγλόχυνα βαλβίδα, είτε αυτές αφορούν στην πρωτοπαθή, είτε κυρίως στη δεύτεροπαθή ανεπάρκεια της τριγλόχυνος, μας ενθαρρύνει, διότι μας δίνει διέξοδο στην αντιμετώπιση της ανεπάρκειας της τριγλόχυνος, ιδιαίτερα σε μεγαλύτερες ηλικίες, που πριν από λιγότερο, Γιάννη, από 10 χρόνια, σηκώναμε τα χέρια όταν η φαρμακευτική αγωγή έφτανε στα όρια της ή όταν το χειρουργείο θεωρείται πολύ υψηλού κινδύνου. Θεωρώ, τελειώνοντας, ότι τις επόμενες 2 ώρες, 1,5-2 ώρες, θα δοθεί ιδιαίτερη έμφαση στις διακαθητηριακές βαλβιδικές θεραπείες των κολποκυλιακών βαλβίδων, ιδιαίτερη έμφαση στη λειτουργικότητα της δεξιάς κύλιας, που είναι παράγοντας εκ των όνου κάνευ για την επιτυχία των διακαθητηριακών βαλβιδικών θεραπείων. Καλό λοιπόν πρωινό.
Ωραία. Ευχαριστούμε πάρα πολύ, Σταμάτη. Νομίζω πως θα είναι μια πολύ ενδιαφέρουσα μέρα. Θα έχουμε ένα τραπέζι από, νομίζω, τους καλύτερους στο χώρο στην Ελλάδα. Θα μας μιλήσει ο Ηλίας ο Νινιός για το Imaging στις επεμβάσεις στην τριγλόχυνα, ο Μιχάλης ο Χρυσοχέρης, ο οποίος είναι διαδικτυακά, ο Κώστας ο Σπάριας, που βρίσκεται εδώ με φυσική παρουσία για την επιλογή των ασθενών, για τη διαδυναμική αντικατάσταση της τριγλόχυνας βαλβίδας, για μελλοντικές κατευθύνσεις. Θα έχουμε 2 live in a box, ένα από το διαβαλκανικό, θα είναι ο Βλάσης ο Νινιός online και ένα από το Νάσιο, και σε συνέχεια αυτά που είπε ο κύριος Αδαμόπουλος. Το MTR μπορεί να χρησιμοποιηθεί ως bridge to transplantation και θα το παρουσιάσει η συνάδελφος η Μαρία Χατζητοφή. Πριν αρχίσουμε τη σημερινή μέρα, καλά να τελειώσουμε με τη χθεσινή, και μας έχει μείνει κάτι πολύ ενδιαφέρον. Έχουμε μια pre-recorded ομιλία από την Ροξάνα Μεράν, που είναι ο President-elect του American College of Cardiology, και είναι σχετικά με το Smart Trial Updates, οπότε για να αφιερωθούμε στην σημερινή μέρα πρέπει να τελειώσουμε τη χθεσινή. Οπότε θα ακούσουμε τώρα την κυρία Μεράν.
Kalimera, Kalispera. Roxana Moran here, recording this talk for my dear colleagues in my second home, Athens, Greece, the SMART trial, the 2025 updates. These are my disclosures. I was one of the co-principal investigators of the SMART trial that is sponsored by Medtronic. Very, very important to begin with is, why did we design the SMART trial? No other trial has ever looked at the small annulus between 2 existing valve systems that are being used. So we're just inconsequentially just choosing valve sizes and what fits, and not knowing if one is better than the other. And in fact, it's very, very important that in the small annulus that is much more prevalent in women, aortic stenosis is different in men versus women. There's no question that the outcomes with SAVR has a higher mortality. There's much important outcomes that have been shown with TAVI to be better. So, and we're going to see a lot more patients with small annulus with women. And could it be that it's the small annulus that is making these, having these negative results, because our surgical colleagues are not doing root enlargement surgery, because it's extremely it's a very, very complex procedure. The pathology of aortic stenosis in women is also different. There's actually more fibrosis than calcification. The remodeling is different. It's less adverse remodeling, more reverse remodeling and functional improvement. And these women are mostly older and with very, very high levels of symptoms as well as high-risk features. So the idea that we would focus on the small annulus in hopes to actually have answers for women was a real one, but also for men who happen to have a small annulus. What is a small annulus? Well, it's defined as the annulus area less than or equal to 430 millimeters squared. It's about 30 to 40% of aortic stenosis patients, more common in Asian patients, and a higher risk of AV gradients, being higher increased gradients after TAVR or SAVR. So that PPM, the patient prosthesis mismatch that is associated with worse long-term outcome, is much more prevalent in small annulus. So the idea that we would go after and actually come up with a characteristic that would enroll many more women, about 90% women, was this SMART trial. a self-expanding versus balloon expandable TAVR in patients with aortic stenosis who would have equipoise to receive either a balloon expandable or a self-expanding stent, being randomized 1-to-1. Dr. Howie Herman was the principal investigator, and myself and Didier Cheche were the co-PIs together delivering these primary outcomes at the ACC 2024 and published simultaneously in the New England Journal of Medicine. This was a global site participations, 83 sites in 13 countries. You see the countries here. Unfortunately, Greece is not here for unclear reasons. We have to absolutely have you all there. But self-expanding versus balloon expandable, severe symptomatic aortic stenosis, small annulus, equipoise to receive either a balloon expandable or a self-expanding valve, randomized, planned 5-year follow-up with these two co-primary endpoints. The first being a non-inferiority endpoint for the composite of mortality, disabling stroke, or heart failure hospitalizations out to 12 months, with the second co-primary endpoint being bioprosthetic valve dysfunction through 12 months. And that's a very, very important endpoint because that is what patients feel when the gradients go up. So the valve characteristics are here. You understand that the Evolute Pro or Pro Plus FX is a supraannular valve with the ranges between 17, 18 to 30 millimeters. Valve sizes 23, 26, 29, 34. A nitinol frame, porcine tissue, recapturable with tissue sealing skirt to reduce PVL. The competing valve would be the balloon expandable valve, which would be the Sapien 3 Ultra. Intraannular, most of the patients were Sapien 3 Ultra, with the annulus range of 16 to 28 millimeters, with the valve sizes being different, as you see, 20, 23, 26, 29, a cobalt chromium frame, a bovine tissue, and not recapturable with an outer skirt to reduce PVL. The two co-primary endpoints were met. We found and reached non-inferiority for the mortality, disabling stroke, heart failure, rehospitalization, composite clinical outcome, as you see here, and found clear-cut powered superiority for the self-expanding valve of the Evolute valve compared to the balloon expandable Sapien valve in terms of bioprosthetic valve dysfunction. This was a composite endpoint that was powered. We also had powered endpoints for HSVD and non-structural valvular disease, which was defined as a mean gradient greater than 20 millimeters for HSVD, and for the non-structural valve dysfunction, severe PPM according to the VARC-3 or moderate total AR. And we met that. The hypothesis tested the mean, these were secondary endpoint, hypothesis tested and powered for superiority. We reached superiority for the mean gradient being lower in the self-expanding valve, the EOA being higher at 12 months for the self-expanding valve, and of course the BVD in women, very important, being reached. This was a powered endpoint, as well as the moderate to severe PPM, all of them in favor of the self-expanding valve over the balloon expandable valve. These were all powered for superiority, and they were met. Importantly, the quality of life was also improved at 12 months with a difference of 7.2% better improvement in the patients with a self-expanding valve versus the balloon expandable valve. We also did this work with a very good evaluation, myself and Didier Cheche, first authoring this data in women only. And we found similar results, slightly lower clinical outcomes for women, but still not meeting statistical significance, really being normal, and the p-value being perfectly fine, no difference at all, but a very important reduction in bioprosthetic valve dysfunction through 12 months in favor of self-expanding valves in women. Also, we looked at alternative bioprosthetic valve dysfunction definitions, all of them meeting the superiority for the self-expanding valve. We also looked at this as the use of balloon expandable valve versus self-expanding, found it to be a multivariate predictor of bioprosthetic valve dysfunction, and it was consistent throughout the range of annulus areas in the trial. This is really, really important. No matter what size, in the small annulus, the balloon expandable valve did worse compared to the self-expanding valve for bioprosthetic valve dysfunction. We also found an important difference that has been submitted and will be presented in New York, was presented in the New York Valves by our team, many colleagues who have put large numbers of trials and looked at bioprosthetic valve dysfunction and its association with a 5-year worst clinical outcome. We do not have those 5-year data from SMART yet, but so far there doesn't seem to be a difference in the clinical outcomes. We also know that it is important that it takes time for adverse hemodynamics to come to affect clinical outcomes. You see the severe patient prosthesis patient mismatch taking a long time before you start to see the effect on the clinical outcomes as well as the gradients. And so we have 2-year data with excellent follow-up, and we don't show a difference between the clinical outcomes as yet between these two valve systems. Bioprosthetic valve dysfunction, though, still remains in favor. You see all of the data looks very, very similar, no difference at all in any of these parameters, but prosthetic valve thrombosis through 2 years, CEC adjudicated, seems to be numerically lower with the Evolut valve compared to the SAPIEN. Bioprosthetic valve dysfunction through 2 years remains superior for the self-expanding Evolut valve compared to the SAPIEN valve at 2 years, as does the EOA, mean gradient, and DVI numbers being better, all in favor of the Evolut valve. The total AR also looking at, as you see, very, very interesting and similar out to 3 years. So out to 2 years. So the take-home messages is that this randomized SMART trial compared the Evolut self-expanding and the SAPIEN balloon expandable TAVR valves in 716 patients, 87% being women with a small aortic annulus. At 2 years follow-up, we saw no differences in the composite clinical outcome of death, disabling stroke, or heart failure rehospitalizations. So we met the non-inferiority, but we haven't shown a clinical benefit as yet up to 2 years. But very, very important hemodynamic measures continue to demonstrate the superiority of the Evolut platform over SAPIEN platform for bioprosthetic valve dysfunction, superior at 1 year, superior at 2 years. And the very, very important comparison that will happen through 5 years will give us the answer if there is going to be an important association with this outcome and long-term follow-up. Thank you so much for your attention. Ευχαριστώ πάρα πολύ.
Σωστά. Όπως θα περίμενε κανείς, από μια ομιλία της Ροξάνα, πολύ περιεκτική, πάρα πολύ διδακτική. Κώστα, έχεις τη μεγαλύτερη εμπειρία από TAVI στην Ελλάδα και είσαι φυσικά ο πρώτος ο οποίος τοποθέτησε μια αορτική βαλβίδα. Έχει αλλάξει η πρακτική σου με τη Smart Trial? Έχουμε μια απόδειξη ότι οι βαλβίδες αυτές είναι παρόμοιες κλινικά, αλλά ξέρουμε ότι η αιμοδυναμικά είναι καλύτερα. Δηλαδή, ξέρουμε ότι σε μια γυναίκα με μικρό αορτικό δακτύλιο, η οποία δεν έχει στεφανία νόσο και είναι νεαρή, είναι 70 ετών, με βάση αυτό θα βάλεις πιο εύκολα μια self-expanding platform ή θα προχωρήσει σε μια annular, γι' αυτό συνήθως που κάνουμε σε μια balloon expandable βαλβίδα για να έχεις πρόσβαση στεφανία εκεί?
Γιάννη, είναι ένας από τους παράγοντες που λαμβάνω υπόψη. Ένας από τους παράγοντες. Όπως ξέρεις, οι ανατομίες είναι πολύ διαφορετικές και υπάρχουν αναπερίπτωση πολλά πράγματα που πρέπει να σκεφτείς. Μέσα σε όλο αυτό το αλγόριθμο, ένα από αυτά που σκέφτομαι είναι και το μέγεθος της βαλβίδας. Νομίζω ότι η διαφορά των δύο, δεν έδειξε τέτοια slides η Ροξάνα, αλλά είναι το μέγεθος. Δηλαδή, αν έδειχνε τα μέσα μεγέθη της διαμέτρους των βαλβίδων που χρησιμοποιήθηκαν στο ένα ή στο άλλο, είναι 2 με 3 χιλιοστά μεγαλύτερη πάντοτε η Evolut από την balloon expandable. Οπότε είναι λογικό να βλέπεις αυτά τα αποτελέσματα που βλέπεις. Νομίζω αυτό που πρέπει να κρατήσουμε είναι ότι δεν υπάρχει καμία διαφορά στα κλινικά αποτελέσματα και επίσης αυτό που πρέπει να κρατήσουμε είναι ότι δεν ήρθε ποτέ κάποιος ασθενής να σου πει «Γιατρέ, έχω mean gradient 15 ή 20 αντί να έχω 5». Όμως σίγουρα αν δεν υπάρχουν άλλα πράγματα μέσα στον αλγόριθμο που να σε σμπρώχνουν προς την balloon expandable, όταν έχεις ένα μικρό δακτύλιο, συμφωνώ ότι θα το λάβω υπόψη μου και θα πάω προς τα εκεί.
Πάντως, από καιρό σε καιρό βλέπουμε σε μικρές Edwards, βλέπουμε halt, βλέπουμε αυξημένα gradient και όταν κάνεις 4D CT μπορεί να δεις θρόμβο. Το βλέπουμε τουλάχιστον στην πρακτική μας. Σου έχει τύχει, έχεις δει?
Η αλήθεια είναι ότι ναι. Σε 20 και σε 23, σε αυτά τα δύο μεγέθη, ναι. Το βλέπουμε. Συνήθως όμως καθαρίζει. Με συντρόμου για ένα διάστημα συνήθως καθαρίζει. Αυτό όμως που πρέπει να πω είναι ότι με την Sapien 3 και με την Sapien Ultra, όταν βγήκανε, έκαναν μια μεγάλη διαφορά στην παραβαλβιδική. Δηλαδή ξαφνικά με αυτές τις βαλβίδες και με τα skirts εξαφανιστήκαν οι παραβαλβιδικές. Και υπήρχε μια τάση τα πρώτα χρόνια να μην τις ανοίγουμε πάρα πολύ. Να μην βάζουμε full volumes, να πηγαίνουμε τους όγκους, επειδή δεν είχαμε παραβαλβιδική. Επομένως, νομίζω όλες αυτές οι μελέτες που βλέπουμε τώρα αντικατοπτρίζουν αυτό το πράγμα.
Ίσως να είναι και κάποιο τεχνικό θέμα. Ναι.
Ότι δεν βάζαμε full volumes. Ναι. Ενώ τώρα μία μελέτη που βγήκε πρόσφατα στο Vancouver έδειξε ότι ακόμα και με το nominal volume πρέπει να κάνεις μεταδιαστολή. Γιατί κάνει πάντοτε recoil και δίνεις μεγαλύτερη διάμετρο στις balloon expandable με τον ίδιο όγκο μεταδιαστολή πάντοτε.
Οπότε κάνεις δηλαδή σε όλες τις balloon expandable τώρα με τα διαστολή.
Ναι. Το έκανα και πριν από αυτή τη μελέτη. Τα τελευταία 2-3 χρόνια το κάνω σχεδόν πάντα.
Ναι, σωστό αυτό. Αυτή είναι μια πρακτική όντως και εμείς έχουμε αλλάξει αυτή την τακτική τα τελευταία 1-2 χρόνια με τα διαστολή ρουτίνας. Ακόμα και αν φαίνονται όλα καλά
μόνο στις balloon expandable ή και στις
balloon expandable.
Στις self-expandable. Στη self-expanding,
όχι υποχρεωτικά. Κύριε, στο self-expanding νομίζω ότι ισχύει ο απλός κανόνας ότι αν αποφύγεις την προδιαστολή, μάλλον θα χρειαστεί να κάνεις μεταδιαστολή. Ναι. Αλλά αν κάνεις μια ισχυρή προδιαστολή, συνήθως το αποφεύγεις. Νομίζω ότι κάπως με βάση την αξιονική αυτό μπορεί να το προβλέψει στις self-expanding, γιατί καταλαβαίνεις περίπου την κεντρικότητα και το ελλειπτοειδές σήμα.
Παρότι αν κάνετε προδιαστολή στην balloon expandable, πάλι θα κάνετε μεταδιαστολή.
Ναι, πάντα. Δηλαδή με το ίδιο μπαλόνι δεν το αφαιρείς, το ξαναβάζεις λίγο, το ανεβάζεις στο αορτικό τόξο και το ξανακατεβάζουμε πάλι.
Αυτό είναι πάρα πολύ ενδιαφέρον. Κύριος Λοντιάδης.
Ένα λάθος που κάνουμε νομίζω είναι ότι δεν πρέπει να μετράμε μόνο το gradient. Για παράδειγμα, εγώ είδα χθες μια δικιά μου ασθενή 2 χρόνια μετά με μια Evolut και είχε 28 peak gradient. Αλλά όταν έκανα την εξίσου συνεχείας και μου πήρε 2 λεπτά, είχε ένα στόμα 1,9. Επομένως, θέλω να πω, δεν είναι μόνο το mean gradient ή το peak gradient που μετράμε, θα πρέπει να κάνουμε όλη τη δουλειά. Προφανώς, την ώρα που βάζουμε τη βαλβίδα είναι πολύ πιο δύσκολο, αλλά όταν διαχρονικά παρακολουθούμε τους ασθενείς, θα πρέπει να βλέπουμε το AVA ή το AVA index και όχι μόνο μια τιμή του gradient.
Ο κύριος Κουτσογιάννης, ένα σχόλιο για το θέμα.
Ναι. Ναι, ευχαριστώ. Νομίζω ότι οι balloon expandable βαλβίδες μοιάζουν με τις παλιές καλές χειρουργικές βαλβίδες που βάζανε οι χειρουργοί τόσα χρόνια και δουλεύουν περίπου τα ίδια gradient. Με την Evolut πάμε να πετύχουμε κάτι καλύτερο. Δεν ξέρω αν αυτό όμως θα εκφραστεί σε κλινικά αποτελέσματα στο μέλλον.
Εντάξει, ευχαριστώ, Νικό. Ωραία, νομίζω μπορούμε να συνεχίσουμε το επόμενο τραπέζι. Ο Γιώργος, ο Τάγκας, ο Βαγγέλης Λοντιάδης. Ο Σταμάτη μπορεί να έρθει. Ναι. Ο κύριος Κουτσογιάννης και η κυρία Μπουζιούτα μπορεί να έρθουν. Και ο Ηλίας, ο Νινιός. Ναι.
Bit more to the English language this year, this day. Because yesterday some people that were online were wondering why is the slides in English, but most are speaking in Greek. So we'll try to do that. Dr. Xavi is online, connected or not yet? Anyhow, let's start about with imaging for tricuspid interventions. Dr. Nyos, welcome.
English, not Greek?
As you wish.
Okay. Αγγλικά. Okay. Dear friends, thank you very much, Yanni Yakovou, for inviting me in the wonderful meeting. My presentation is about the tips and tricks for the tricuspid valve imaging. And I will give you 5 plus 5 best tips and tricks for interprocedural imaging in TEER. And first of all, transgastric imaging is the key to the successful peri-procedural guiding for edge-to-air repair for the tricuspid valve. It's important to understand the anatomy, and when we aim, okay, here, okay. If we want to put the device between the anterior and the septal leaflet, then our primary plane is at 60 degrees and the secondary plane is 60 plus 90. If we aim for septal and posterior leaflet, then primary plane is 80 to 90 and secondary plane is plus 90 degrees. And again, here is the transgastric view, and here is the RV inflow, outflow. You see 65 and 155 for the anteroseptal leaflets, but if we go for the posterior and septal, then, sorry, I have to go back. Then our primary plane is at 90 and the secondary on 180. Another suggestion is to use a single view for difficult grasping. If we have bad imaging or if we can't align our echo to the device, then we can choose a nice view to have both leaflets in and to have a symmetrical device, and then work on that view and perform also the grasping on that view. But transgastric view is very important for understanding the anatomy and measuring the gap between the leaflets. It's very important to check for perpendicularity, to check for leaflet insertion. Again, it's very important to assess the tissue that we have grasped from both leaflets. Again, another patient here. And sometimes we can see that bow tie or papillon sign in the transgastric view. It's a proof that we have grasped enough tissue of both leaflets, and that's a safe grasp. We know that the tricuspid valve has a very dense subvalvular apparatus, and it's important to avoid the cords. It's a good practice to go to the chordal-free zone when possible, so that we can be sure that we don't disrupt the function of the valve or we don't induce a further regurgitation with our device. That's an example here. You see the cords, and we have to avoid the cords and go direct between the anterior and septal leaflet where there are no cords at all. And we have a very nice result. And of course, be gentle and careful. Is a tricuspid valve, a very gentle structure, a very delicate structure, more delicate than the mitral valve, and we have to be very careful. In summary, the first 5 tricks and tips are to understand the orientation angles, to use a single view if necessary for grasping, to check the leaflet insertion in the transgastric view, to avoid the chordal insertion zones, and to be gentle and careful. But another good idea would be to use the mid-esophageal MPR. As you can see, if we have a nice mid-esophageal view, then we can take a 4D data set and perform a flexi, a slice in the GE, and we can assess for perpendicularity and also perform the grasping. You can see here both leaflets and the device, and they put also a second device using exclusively the mid-esophageal view without bending to the transgastric one. But we can also, if we have a nice transgastric view, use the transgastric MPR, even for grasping, and go only transgastric. As you can see here, both leaflets and the device is open, and here we can go for the grasping. We check for perpendicularity, and we perform the grasping. As you can see, we record the grasping here, and we avoid, once again, the bending between the transgastric and the mid-esophageal view. That's time-saving, and of course, we can avoid some problems with esophagus, and we have a very nice result. Okay. If necessary, we can also perform an angle reset. Normally, we take the primary plane and then we put plus 90 degrees on the secondary plane, the biplane or multi-D, but sometimes it can be less or can be more, and it depends on, I think, the location of the device. It's important to show both leaflets and, of course, to have symmetrical, wide open our device. Another good practice is to record the grasping, to record 10 or more cardiac cycles, and then to review the grasping to be sure that we have enough tissue of both leaflets so that we can avoid or reduce the possibility for single leaflet detachment. And finally, the last tip is to use, if necessary, peri-procedural, the transthoracic echo, because it can add to the information of the grasping or help us assess the final result. In summary, we can use the mid-esophageal MPR, we can use the transgastric MPR, we can perform an angle reset if necessary, we can record the grasping, and additionally, we can use also peri-procedural, the transthoracic echo. Thank you very much.
All right, great. And let us complement this one by going online to Dr. Chrysocheri, who talked to us about the tricuspid regurgitation-related edge-to-edge repair. tips and tricks for successful treatments. Μιχάλη, καλημέρα.
Καλημέρα σας, με ακούτε?
Μια χαρά. Just share your screen and get started.
Okay. Λοιπόν, καλημέρα σας και ευχαριστώ θερμά για την τιμητική πρόσκληση τον κύριο Ιακώβου και την οργανωτική ομάδα του Ωνασίου. Εκ μέρους της ομάδας Καρδιάς στο Νοσοκομείο Υγεία θα αναφερθούμε στα επόμενα λεπτά μετά την καταπληκτική αυτή παρουσίαση που είδαμε νωρίτερα από τον Ηλία στην επεμβατική επικόνηση για επιτυχή edge-to-edge repair στην τριγλόχυνα. Όπως γνωρίζουμε πάρα πολύ καλά, ο σκοπός της edge-to-edge repair στην τριγλόχυνα είναι η μόνη συμπλησίαση μεταξύ septal και anterior ή septal και posterior, αναλόγως που βρίσκεται το μέγιστο jet ανεπάρκειας, με ένα ή περισσότερα devices και να επιτύχουμε μια επιτυχία απομείωση της ανεπάρκειας. Τα βασικά devices που έχουμε και πρέπει να τα γνωρίζουμε καλά, όχι μόνο τα devices σαν υπερογραφιστές, αλλά και όλα τα procedural steps, είναι το XTW, το Gen 4 της Mitral του Triclip και το Pascal Ace για την τριγλόχυνα. Πολύ συντομία για τα δεδομένα που έδειξαν ασφάλεια και αποτελεσματικότητα στην απομείωση της ανεπάρκειας της τριγλόχυνας από τη μελέτη Triluminate, η οποία έδειξε ουσιαστικά επιτυχές αποτέλεσμα κυρίως από την βελτίωση των συμπτωμάτων των ασθενών, και αυτή η βελτίωση είχε σχέση όσο μεγαλύτερη την απομείωση της ανεπάρκειας, τόσο μεγαλύτερη είναι και η βελτίωση των συμπτωμάτων των ασθενών. Αυτό βέβαια καταδεικνύει πόσο σημαντικό είναι σε επεμβάσεις αυτές να έχουμε το βέλτιστο δυνατό αποτέλεσμα. Στην TriClasp επίσης, μελέτη που είναι ένα μητρό ουσιαστικά σε πραγματικούς ασθενείς, βλέπουμε επίσης την ασφάλεια της μεθόδου edge-to-edge repair με το Pascal στην τριγλόχυνα, με πολύ καλή απομείωση της ανεπάρκειας, και αυτό είναι κάτι που βλέπουμε και στις δύο συσκευές, περίπου 85% μείωση σε moderate or less και περίπου 50% μείωση σε mild or less ανεπάρκειας τριγλόχυνα σε καλά επιλεγμένους βέβαια ασθενείς. Με πολύ καλά αποτελέσματα σε ό,τι αφορά το reverse remodeling της δεξιάς κοιλίας και στα κλινικά αποτελέσματα των ασθενών. Θα δούμε και νεότερα δεδομένα, φαντάζομαι, το καλοκαίρι με τα νέα guidelines για το edge-to-edge repair και το indication στην τριγλόχυνα. Αλλά ας περάσουμε λίγο στα επεμβατικά και είδαμε πάρα πολύ νωρίτερα τις λεπτομέρειες που πρέπει να κοιτάξουμε, αλλά πρέπει να έχουμε στο νου στην αιτιολογία της ανεπάρκειας. Το μήκος των γλοχινών και την κινητικότητα αυτών έχει πάρα πολύ μεγάλη σημασία. Αυτό τον αριθμό των γλοχινών επίσης, τα χάσματα σύγκλησης, το location που βρίσκονται τα προβλήματα αυτά και αν υπάρχουν καλώδια. Και με αυτά πρέπει να κάνουμε ένα πλάνο πώς θα προχωρήσουμε να φτιάξουμε τη βαλβίδα αυτή. Και γνωρίζουμε ότι μπορούμε να ανταποκριθούμε σε ασθενείς που έχουν λειτουργική ανεπάρκεια, ventricular functional, atrial functional, πρωτοπαθείς αλλά και καλωδιακές ανεπάρκειες τριγλόχυνας. Αλλά το πιο σημαντικό για μένα είναι αυτό, να εστιάσουμε και να έχουμε στο νου μας αυτόν τον πίνακα, ο οποίος έχει βγει μετά από πολύ μεγάλη εμπειρία και ταλαιπωρία ενδεχομένως πολλών συναδέλφων, όπου έχουμε την κατάταξη των ασθενών σε favorable ανατομία, όταν έχουμε μικρά χάσματα σύγκλησης κάτω από 7 χιλιοστά, anteroseptal κατά κύριο λόγο θέση. Συγγνώμη, I'm talking in Greek, I apologize. I apologize for this. Let me convert to English. So if we have a favorable anatomy, being that we have small septal-lateral gaps, anteroseptal jet location, confined prolapse or flail or trileaflet morphology, feasible anatomy, if we have gaps that are a bit bigger, extending maybe to the posterior septal area, non-trileaflet anatomies, and cables that are not impacting significantly the mobility of the valve leaflets, and unfavorable anatomy on the right side of the screen when we have very difficult characteristics. And we have these scores that we can predict our efficacy and success with edge-to-edge repair. So we have to keep them in mind, especially in the era of transcatheter tricuspid valve replacement, that we go into these procedures understanding what our goals will be in terms of TR reduction, how successful can we be, and with that we can do our procedural strategy. It's very important to understand the number of leaflets and commissures, because that will impact our position of the devices, and the more complex the valve becomes, with more septal, more commissures, more scallops, the more complicated the procedure can become and more difficult to achieve an optimal TR reduction. It's very important also to have the patients being optimally volume managed, especially for tricuspid edge-to-edge repair. We know that affects the coaptation gaps significantly, so we de-risk these patients, we optimize them before we do these procedures to have the best possible chance of a good result. Let's look at a patient with a severe atrial functional TR. Here, again, we go through the algorithm of understanding the tricuspid location, the regurgitant jet location, the leaflet length, and again, the transgastric view is a critical view to understand number of leaflets and location of the TR jet, and with that to guide our procedure. 3D can also help us very much to understand. Here we have a very nice tri-leaflet valve. And with this, we can also, with biplane, we can understand the length of the leaflets nicely, so we can have a good design of the procedure before we start. In this particular case, we opted for single device in the posterior septal area, and with this clocking, with this orientation. Again, NPR is a very handy and very useful tool throughout the procedure for edge-to-edge repair, because it helps us understand our position, trajectory, and at the same time looking at the short axis view of the valve, understand where our commissures are, and it's a very critical view that we employ very often. The workhorse view obviously is the biplane imaging, as we saw before, with positioning of our device in the major jet that we have, and with that, usually we do independent clasping of the leaflets. In particular here with this Pascal Ace, we went for the lateral leaflet, the posterior leaflet first, and then for the septal leaflet. And with that, we did this is our initial assessment. Assessing it's very important to understand how much leaflets we have inside. We usually go for transgastric views. We open the device to see if the leaflets go all the way into the center of the device. If not, we can optimize. In particular here, we optimize the lateral leaflet first, and then we did optimization of the septal leaflet to ensure the maximal leaflet insertion in our intended position. Again, we close the device occasionally in transgastric view to see how the leaflets are approximating. And if we're not happy with the leaflet insertion, we optimize again to ensure that we have the best possible result with our first device. And this is our initial device with one device in the posterior septal area as intended, with a very good TR reduction. Moving on to a more complicated ventricular functional TR. Here is a very wide jet across the coaptation zone. Just looking at it, there's also a pacemaker wire in the posterior septal area. We understand that we need to understand very carefully this valve and the coaptation gaps that we're going to have to bridge. So we scan the valve from anteroseptal to posterior septal in all possible planes to see in this view the leaflet length, the coaptation gaps, and have a very good understanding of the valve. In addition, we do MPRs as well, as we saw before, to understand how we're going to engage our leaflets in the intended areas of approximation. And here, again, in biplane modality, we engage the leaflets in an independent fashion. First the lateral, then the septal, optimizing the result, assessing in transgastric views that we have a good leaflet insertion, and after releasing this device, positioning for a second device as we initially intended in a more central area to achieve a better TR reduction. Again, independent clasping of the leaflets, and it's very important to highlight the dropping of the clasp, because that is the single most important way of understanding that we have adequate leaflet insertion. We can do it in other ways as well, scanning, MPR, everything else. But if we have a good documentation, as Elias mentioned before, that's a key parameter for us. And also, it's important to understand what we'll accept as a good result. And this is indeed a very good result. There's some residual TR in the posterior septal area, but we're not going to go after that. There's a pacemaker wire. So we have to understand that this is where this procedure ends with a very good result, decreasing torrential to mild to moderate residual TR. And here's another case of a ventricular FTR. Again, a patient who we will have to assess in the same systematic manner as we saw before. Again, this is a very important view. This is one of the first views I like to see, is a 3D midesophageal view, because it gives us a nice overview of the whole valve, and we understand where the coaptation gaps are, where we need to manage this device. This valve has coaptation gaps in anteroseptal and posterior septal area, and there is also a gap between anterior and posterior. So this is a very difficult valve to treat, and we'll have to time it very carefully. This transgastric short axis is very important for us as well, because what we can see here is cords and some restriction in the mobility of the septal leaflet. So this tells us that when we try to engage the septal leaflet, we may have some difficulty in engaging it. So it's very important to have these things in mind when we plan these procedures. Again, a very wide jet of regurgitation from all across the coaptation zone. And again, we consider this to be a feasible anatomy with an intermediate glide score of 3 to 6, with a moderate probability of getting a good result. And with this type of the procedural planning, one device anteroseptal, one device posterior septal with this type of orientation, and with this type of clocking. We're not going to go through the procedure, but this is essentially what we eventually did. Positioning the first device posterior septal, we tried anteroseptal initially, but we didn't have a very good result, so we went directly posterior septal in the major color that we could see, and we positioned one device in this posterior septal area with this type of clocking and orientation, and then put a second device then anteroseptal in this particular area with a very good result. This is the two devices positioned in place with some moderate residual TR between the devices, but a very acceptable, very good result for this very difficult and challenging anatomy. The key important thing is to consider 4D intracardiac echo. It's not very widely available yet, but it's a modality that can really help us in patients who have difficult imaging, and it can really facilitate our procedural flow. In this particular modality, we do a 3D image of the tricuspid, and we do MPR essentially, where we analyze the valve in this commissural view and this long axis view with the septal and lateral leaflets, and this area, the septal is here, lateral is here. And with this view, you can actually see very nicely the engagement of the leaflets on the device, and the closing of the device leaflet of the device here. And this is positioning a second device next to the first one, again engaging the leaflets, the septal, the lateral, seeing it in a very crisp imaging that sometimes can be very difficult with transesophageal echo. And this is our final result. And obviously, we need to understand that there's patients who are very difficult anatomies like this with pacemaker wires or rheumatic heart disease that we have to consider them for other interventions. In summary, the basics for a successful tricuspid TEER rely on good understanding of the anatomy, have a procedural plan in advance in terms of location of devices, the orientation, the numbers that we anticipate of the device that we're going to implant. We need to optimize the volume status of the patients, utilize MPR for position, trajectory, and avoidance of commissures. Sometimes we try to grasp leaflets, but we understand afterwards that we're trying to go into commissures, so that's why we cannot grasp the leaflets. We always need to document the leaflet grasping. It's a very critical point of the procedure. And optimize carefully, optimize wisely. If we don't have a good leaflet insertion, absolutely we can optimize with these devices and have the best possible result. And again, it's very important to understand what to accept as a good result at the end of these procedures. And again, moderate in some of these patients may be an acceptable result and can lead to a symptomatic improvement. And with that, I'd like to thank you for your attention.
Great. That was a terrific talk. I think let's go ahead to the third talk of this entity, and then we're going to have a bit of a panel discussion. Unless there's a pressing question about the imaging, let's invite the chief, the director of heart valve therapies at IEA Hospital, a major clinical center in the entire Southeast Europe, Dr. Kostas Parias, to talk to us about tricuspid transcatheter valve replacement, and where we are, where we're going, and then we're going to put all this modality, the imaging and the clip and the valve together in some type of a discussion, try to get some sense out of the situation with the help of our CHF expert, Dr. Adamopoulos. Go ahead, Costa.
Καλημέρα. Thank you, Giorgos, and thanks Dr. Iakovou and the heart team of Onassis for the invitation. And after the TEER procedures, we go to the TTVR procedure that we recently have available over the last year now. It's commercially available. And it's for, I would say, the difficult cases, or the cases we don't expect to have a good result with TEER. So tricuspid regurgitation is a very frequent problem. This is data, epidemiological data from the US, and you see it's the second most frequent valvular disease after mitral regurgitation. But what is interesting is that proportion of patients with significant tricuspid regurgitation treated is the smallest compared of any other valvular disease. But I guess this is going to change with availability of TEER and valves. So we have seen earlier Michael talking about the success of TEER, and the success of TEER is not great. From all these studies and registries that we have available today, what is considered good result is mild or less. And this mild or less, we only achieve it in 50%. I would say the best in all these studies. So TEER, even when we select the patients to do this procedure, gives you a perfect result in 50% of the cases. Only if you accept moderate residual TR as an acceptable result, then this 50% goes to 80% or 85%. And we know very well that moderate TR is something that we can debate a lot, what is moderate. So given this weakness of this therapy that is very low risk and helps a lot of patients, it's understandable that something else is needed for many patients. Why? Because even mild or moderate TR is associated with worse prognosis. So this is something we cannot always see. And we have all these complex anatomies that we discussed earlier, large gap sizes, when we have TRZ that coming from everywhere, from all the commissures, when we have multiple leaflets, more than 3, very dilated annuli, when we have a very dilated right atrium or right ventricle, huge errors, tethered leaflets, or when we have a pacemaker or defibrillator leads. We use these scores like the GLIDE score to somehow predict how successful TEER will be. So we can get an idea taking all these anatomical characteristics and features if we are going to be successful. But we know from studies that from the patients we screen for TEER, we immediately reject approximately 30% of them. So from those we screen, 30% are out immediately. And then from those we are performing TEER today, 30%, as we discussed, is not having a good result. So if we add these numbers, then approximately 50% of the patients we check for interventional therapy for tricuspid valve are not good, are not suitable, are not very good candidates for TEER. And these exactly are the patients we have to think the solution of transcatheter valve. And why is that? Usually surgeons prefer repair than replacement. Why in tricuspid valve we should go for replacement, not repair? But here, replacement is not the same, because replacement doesn't require a cardiopulmonary bypass, it's not associated with massive volume shifts, and it doesn't cause any right ventricular ischemia. So it happens in a very simplistic way, not very invasive and interventional. So this is the valve we are using today. It comes in 4 sizes. The Evoque, it has 9 anchors or hooks, and the diameter of the valve is 29, the inner diameter, the usable millimeters. And the catheter we use, the delivery system, is 28 French. It's based, the release of this valve on a TRISCEND 2 trial. It was a 2-to-1 randomization of patients with severe and symptomatic tricuspid regurgitation that were not considered appropriate for surgery to Evoque versus optimal medical therapy. and they were followed up for 1 year. At least these are the results we have available. As you see, elderly patients, high-risk patients, STS scores close to 10%. Almost all had atrial fibrillation. A lot of them had ascites and signs of severe right ventricular failure, and approximately 1/3 or more of them already had a pacemaker, indicating that these were patients more likely to fail TEER. And they all had severe, mostly secondary regurgitation. And these are the procedural characteristics in this study. You see that 95% of patients were implanted at the end. The device time was 1 hour. Percutaneous access was in 100% of them. Conversion to surgery, 1.2%. Length of hospital stay between 2 and 6 days. The average was 3, and discharged home most of them. The study was positive, as we know. It was a composite endpoint, hierarchical endpoint of all these endpoints, the hard ones and the softer ones. The hard ones, all-cause mortality, heart transplant, or heart failure hospitalization, and the softer ones, quality of life assessment measurements. What is certain is that the tricuspid regurgitation was eliminated, completely eliminated in 99%, and not in 50% like we've seen with TEER. And you see there was some improvement also in the patients on medical therapy, but very little. And if we see the hard endpoints, all-cause mortality, we'll see that the numerical difference was in favor at 1 year of EVOQUE, something that we didn't see in TRILUMINATE. The numerical, there was no numerical difference in favor of ECLIP. And the same for hospitalization. Again, not statistically significant, none of them, but numerically, again, in favor of the valve. And then we had this 18 units improvement in the quality of life that was the largest we've seen in these trials. I think in TRILUMINATE was 11 or 12 units. And if we see the safety outcomes, which is very important, cardiovascular mortality at 30 days was 3%. So this procedure is 3%. 2%, if I remember well, is in TRILUMINATE. And then we see severe bleeding, although we go from the venous side was very high, 10%, and the new pacemaker at 1 month was 25%. So 1 in 4 patients in this study with EVOQUE needed a pacemaker within the first month, and then another 4% the rest of the year. So let's see some cases that we have done over this year with valve replacement. The first and probably most impressive case was this 91-year-old lady that despite her age was fully mentally and physically functional. She suffers from carcinoid on chemotherapy for years now and stable, but with cardiac and abdominal involvement. And over the past 6 months was in the hospital every 15 days for IV diuretics and ascites draining up to 6 liters. So life was intolerable for her, and this is her tricuspid valve. You see there's no tricuspid valve. It's a huge hole there. So it's understandable that this lady was in real trouble. So this case, it's extreme and it's unfavorable, clearly anatomy for TEER, so nobody will think of TEER. But not only for TEER, we checked for cardioband, we checked for EVOQUE, we checked for tric valve. The anatomy was so huge that she was rejected from all this therapy. So then we checked for compassionate use of other experimental valves, and we came across the Lux valve. The Lux valve can be very big, as you can see, up to 75 millimeters of annuli and bottom of the right atrium. And this is the valve. And so this patient was checked and accepted for this procedure. And I don't know why this doesn't play. Yes, it plays. So the difference is we come from the jugular vein, and this is a big sheath, short sheath. as you can see. This is how we set up the hybrid room. So we go from the head, so everything changes where the screens are and how we work. And here is the capsule, the delivery system of this valve. Initially, we have a wire, but then the wire is withdrawn, is pulled out, and then we go just with the capsule, and we gradually release the valve. Initially, this pad that goes into the IV septum, and then these two hooks that they expand and they go like a tri-clip or a Pascal behind the lateral leaflets. These are the two anchoring points, and the third is this pad that extends into the ventricle. I'll show you. And then the valve is released and it works. And then you see this catheter there that is advanced. And then through that, we advance this small anchor hook. You see it very tiny. 3 hooks is like the micra pacemaker, sort of. And this goes through a fabric that covers all that surface of that pad. So these are the 3 anchoring points, the 2 hooks and this one that goes into the interventricular septum. And with this final result, 0 tricuspid regurgitation, and it's amazing that it's now 4 months, I think, since we did this procedure. This lady never came back to hospital, is at home without any IV diuretics, that requiring before stable body weight and doing very well. And this is how this valve appears on fluoroscopy. So this is for huge anatomies with huge gaps like the one I've shown to you. Finally, just one more case of a VOC valve. This is a young lady with myositis and dilated cardiomyopathy related to myositis, immunosuppressed, on double therapy, as you can see. She had mitral regurgitation, functional years ago, that was treated with 2 Pascals successfully. She had an improvement, but then the tricuspid regurgitation that was already present there at that time, it was getting worse. It was symptomatic, but it was not acceptable for TEER because we will see that we wouldn't have a good result. So we were waiting for the availability of a valve. These are the coronaries and the 2 Pascals. Both of them, I think, are P10s, white Pascals. And this is the tricuspid regurgitation with a defibrillator lead that certainly is involved because it impinges, as you'll see, the posterior, the septal leaflet. You can see it here, and you see color on either side. So very wide vena contracta, and apparently this wouldn't be a good result in this young lady if we were going with TEER. But she was accepted with a VOC. The anatomy was acceptable, and we went for the 48 millimeter valve. This is the valve, and this is how it's crimped into its capsule. The most important part for the interventional cardiologist of this procedure is to get the safari wire at the apex of the right ventricle using an Agilis, and you have to do that correctly to have a successful procedure. And this is how the capsule comes. It's bented, flexed into the right ventricle, and then everything is easy for the interventional cardiologist because there are minute movements from now on. You have to attain coaxiality, which is very essential for all the procedures in the atrioventricular valves. And to the location, you have to be in the central, anterior, posterior, septal, lateral. We use MPR here very much, I would say exclusively. And then we start releasing the valve, first the 9 hooks. We go to 45 degrees, 90 degrees, and then flipping of the hooks. And at all these stages, we have to check that the leaflets are moving freely above and below or are captured in the hooks. Here you see how it's 90 degrees, and then they're flipped. And you have to adjust the height or the depth of the valve at each of these stages. This is the ventricular expansion, and this is close to releasing the valve. This is the atrial expansion. At all these stages, NPR, checking that everything is in place, because if two hooks are not well positioned, then the valve may migrate. So we have to check and make corrections on the position of the valve, on the trajectory of the valve, and you can do that to the very last moment. And then the valve is released, and you see how it pushes the electrode away, the thick defibrillator electrode away, and we have a very good result, as you can see. So when we use a valve in the tricuspid position, we eliminate the tricuspid regurgitation. I think this is the message. And I have two final images for 6-month follow-up. You see the transthoracic echo, very good function of the valve, and the patient is doing well. But a word of caution. Just a few days ago, we had this publication, the first year of commercial use in the USA, and there were 150 reports of adverse event, yellow cards to the FDA, and this is the MAUD database, and this was released recently. Nobody knows exactly the denominator of these 150 reports, but the best guess is approximately 1,000 to 1,200 patients done within this year. And what were these reports? As you can see down, 44% were high degree AV block and bradycardias. Second was device malposition migration. Third was thrombosis, and then cardiac tamponade. And if we just go back to the TRISCEND, there we had in the first year 30% pacemakers. And if we go to see this report, the MAUD report, which is very important, we had 70 patients reported with bradycardia and high degree AV block. 2 died of them, and 65 required pacemaker. 24% during the procedure, 37% within the first 2 days, and 36% from 3 days to 3 months. So 1/3 of the pacemaker was after the first 3 days. So this is quite alarming. And then 33 patients had device malposition, migration, embolization. 6 of them died. 75%, most of them during the procedure, but 14% within the first 2 days and 7% within 3 months. And then 20 had HAM or HALT, thrombus and leaflet thickening, and 16 of them with hemodynamic and clinical sequel, and more of 50% of them happened within the first month, and treatment included thrombolysis, transcatheter valve-in-valve, and surgery, as you can see. Finally, cardiac tamponade and venous injury and bleeding, the vascular complication, were reported in 8 patients for each of these complications, and resulted in 4 deaths and 2 deaths. So bleeding complication with this valve can be very severe, and we have to be careful. So with this quite alarming report, we have to be careful, and we have to understand that TTVR is not TAVI. It requires a lot of experience and very good patient selection. And from the data we have today, TTVR is not as safe as doing TEER. I think we should realize and appreciate that. And the trade-off is efficacy, of course, versus safety. Thank you.
Well, thank you. Thank you. Well, let's go to the discussion now. It's going to be led by Dr. Adamopoulos, because all these 3 modalities are in heart failure patients. So how do we make sense of, aside from bringing the patients a day or 2 earlier, IV diuretics, bring the volume down acutely to have a good result, maybe give a little milrinone. How do we prepare the patient? How do we select the patient from your point of view, Stamati, for something like that? Because a lot of tricuspid disease is secondary to other things. And perhaps that's why there's a little bit of a mixed bag in the response. Because if it's not the primary problem, you know, maybe the prognosis is also may be limited. We have the panelists here, as well as perhaps, before we go to whoever is in the room, may I ask, is someone online like to make a comment? So the fact that we don't see you, this means that we don't forget you. If anybody online was to make a comment, please go ahead, or at any point, please jump in and offer your comment in case the discussion is evolving here.
So, Costa, stay here. 3 excellent talks from extremely knowledgeable cardiologists in the field. Since Costas, the pioneer, is on the podium, I would like to share with us your experience in 2-3 aspects, Costas. First of all, with the transcatheter replacement, sometimes we've got an abrupt increase in the afterload of the right ventricle. I'm sure that you evaluate the right ventricular function before the valve replacement. How often do you use inotropes during the procedure and immediately after, or even intra-aortic balloon pump? That's my first question.
Yes, that's something that is concerning, and we always check. And actually, severe RV dysfunction is an exclusion for TTVR. So if we have severe TEER RV dysfunction and we must treat the patient, we'll go for TEER. But usually, if you have severe RV dysfunction, probably any therapy is futile, and you have to think twice before you proceed. So from Edwards, patients with severe RV dysfunction are excluded. But we had, I think our number 8 or number 9 were a patient with moderate dysfunction, that the procedure was excellent, and then the patient developed low output syndrome from the following day, and we tried many things like milrinone, hemodialysis, a lot of things. So it's something that it first came to us after doing a few cases, and after that case, we always pre-treat patients, even if they have good RV function with milrinone, and we start milrinone at the time of the procedure. We haven't seen that problem again, but like I said, you have to formally assess RV function before proceeding with this procedure.
Costa, can I make a question?
Yes.
So regarding this VOG malapposition cases, so it's quite alarming, as you said. You think it's something that has to do with the loading conditions that may evolve during time? So maybe the volume status of these patients has changed over the follow-up?
Yannis, I think this was related to the initial probably enthusiasm in the States of having commercially available a valve and starting using it in all the difficult scenarios indiscriminately because it's just available. So this is how I see this report, the Martyr report. I think it's an overreaction and of overuse of this therapy at this first year, because we didn't see that in the study, in the Tricent. The migration was close to 0, 1% or something like that. I think it has to do with training, it has to do with proctoring, it has to do with the patient selection. In our experience, small experience, all the procedures technically went perfect. We never had a problem of wrong positioning, malpositioning, or migration of the valve. But as you saw, it can happen. It means it's a different animal than other.
Yes, and your approach regarding the diuretics, is it the same as the TEER? So do you still keep them on the same, or do you de-escalate?
We want the patients to be like eulemic with TTVR with Evoke. We don't want them to be like completely dry. Because if they're completely dry and they have a small annulus, then you implant you may change the size of the Evoke. So compared to the screening. So on the table, you may find a perimeter of the annulus that is much smaller, and then you have to go to a smaller valve. But if these patients are like put a few kilograms after the therapy and the annulus dilates, then that valve might be small. So that's why we don't do this fluid intervention that we do in TEER with Evoke.
Costa, in this report, in 1 year report, why did we have embolization events? Because most of the patients, more than 90%, are on AF, so they are treated with anticoagulants, and probably the rest of them should be treated with anticoagulants, probably. Why did
you mean thrombus?
Yes.
Okay. Yeah. Well, it's, as we know, the right heart, it's a low flow area of the heart, so it's not like the left side. So there is a higher probably tendency. And like you said, despite the fact that all patients are on NOAC because of atrial fibrillation, we see that. We have one case that we saw that after 6 months. And we started, she was on NOAC, and then we changed that to syndrome, and we saw a resolution, not complete, but satisfactory resolution with clinical improvement. I guess it's similar to TAVI. It can happen on the tricuspid side, but at a higher, let's say, incidence. So we have to be careful and think about it.
My last comment is related to the pacemaker need. Because I realized that within 3 months, 36 of the patients required pacemaker. How useful would be the remote monitoring? Because we have conduction disturbances not very early, but we have late as well. Either with existing electrical leads that might be jailed by the Evoke, or non-existing electrical leads. So remote monitoring might be useful to avoid some of the bradycardia events?
Certainly. This is the main, I would say, the main issue with Evoke, because from the TRISCENT, 1/3 of the patients needed a new pacemaker. And another 1/3 already had a pacemaker from before. So we should be very clear with our patients before Evoke that it's very likely that they will need a pacemaker. And then it comes the challenge of what type of pacemaker you're going to implant, because you have a valve there. So the ideal will be to go with a Micra type pacemaker through the Evoke that can be done by experienced people carefully. Or you can go from sinus pacing. You should avoid to go through the Evoke. It will be the last resort to go with a wire through the Evoke, because you may impede one of the leaflets of Evoke. So I think the message here is that when we do this procedure, because we have late conduction abnormalities, we should keep the patients much longer than the TRISCENT study in the hospital, at least 5 days, I would say, or 6 days. Because most of this need was within the first 6 days. But again, if you remember, 1/3 were between 3 days and 3 months. So yeah, we have to be careful. But we've never seen a problem with existing wires or leads in our experience. We always check before the procedure, after the procedure, pre-discharge at 1 month.
Great presentation. During the procedure, in the preparation of a pacemaker with Evoke, there's a lot of panic at least whenever it happens, there is a lot of panic because you cannot keep the wire in the ventricle. So you have to find a way to place the temporary pacemaker after the device is there. So we have had, I think, one case that it took us 3 minutes to put a pacemaker and ended up in having adverse events. So in preparation of the procedure, we thought about a couple of things. I want to know your input. We talk about the SAVI wire, having a SAVI wire that can pace, you can do the procedure. The SAVI wire, you know, it's like the Safari, but you can pace also. Or having a pacemaker waiting from the other axis in the superior vena cava, ready to be pushed in. Or we talked about Isuprel during the case. What is your approach in the preparation? For example, a patient that already has a first-degree AV block, for example, or a bundle branch block, and you expect during the procedure, there is a very high chance it will happen. What would you think as a preparation for the procedure to do?
Initially, we were very naive to this problem in our first few cases. But then we realized we had one case that had a transient block just after release of the valve. And now what we're doing is we're just connecting the Safari with crocodile connectors with a pacemaker. So we pace through the Safari, we deploy the valve. So acutely, if there's complete heart block after release of the valve or during the procedure, we pace through the Safari. And then in our planning, if we need to keep pacing after releasing the valve, we'll probably go from the left ventricle, like you said, with a SAVI wire, clear the right side from everything we had, and probably go with a temporary wire from a jugular vein till we find a solution, a permanent solution.
Does the Safari pace with a coating, or you have to clean the coating?
You have to clean just a tiny part of the coating at the back.
Dr. Thanassopoulos, Giorgos?
I do it. I want to see, you know, the cover go away and it shines, so I put the crocodile there.
Sorry, Kostas, to torture you, but you've got the greatest experience
here. No problem,
so,
no problem.
Giorgos?
Well, Kostas, once again, thank you so much for the pivotal contribution on this topic. Well, I will take the opportunity to ask you about the what you're feeling about the message of the new pathophysiology for atrial TEER and the relevance of this pathophysiology for these evolving interventions apart from the TEER.
Atrial functional MR and atrial functional TEER are very interesting pathophysiologies. I would say they're mostly related to atrial fibrillation. This is where we see it mostly. And we see small ventricles and huge atria. Sometimes they're very, very impressive. You may have a right atria or a left atria that is huge, like head, and then a tiny ventricle. Certainly, you can get away, you can remove regurgitation in both cases with all the techniques we have. You have to make sure that it's proportional MR or TR before you remove it. So it's significant for the size of the ventricle. And then I think technically, these cases are best treated with TEER. TEER is, I would say, easier in those cases, especially using the Pascal P10 with the spacer. I think we have a very good success with this device in atrial functional MR or TR. Another option would be to go with cardioband on the tricuspid side to cinch the annulus with one device or the other. Cardioband is available, not used very much, but I think it's a very good option to just reduce the annulus with a transcatheter option, because this leaves the road ahead clean for future interventions. So you achieve annuloplasty, which I think in cases that we have large atria is a good thing to do. And then for like ablation or maze procedure or atrial plication surgically to go to treat the problem, I think it's very difficult to remove the atrial fibrillation. Once the atria are huge, there is no treatment for this. You can do it at earlier stages, and then if you're successful, the patient will see the difference. And then if you can remove the tricuspid regurgitation or mitral regurgitation, in these cases with a clip, why to go for surgery? Just for the plication or for an unsuccessful maze procedure? These are not founded, are not proved, so you take a huge surgical risk just for an additional secondary procedure that is not proved and is not going to work.
Can I make a comment?
A quick question.
Yes.
Costa, congratulations. How do you manage diuretics after edge-to-edge or after replacement? Because you have to let the ventricle do the remodeling.
That's very important, very, very important. Our practice is to change nothing. So we keep exactly the same drug regimen that we're having before the procedure, after the procedure, and we let the patient tell us if we need to change something. So as you know, the first 6 months are critical for scarring of the devices, either the clips or the valve. So if you change the volume status of the patient, for example, if we've seen cases that when the right ventricle dilates, we have a relapsing TR because the device is pulled away. So we keep everything the same, no change in the diuretics, no reduction in the diuretics, and the most critical thing is the body weight. We ask the patients to check the body weight every morning. If the body weight remains stable, we keep the same therapy. If we see that with the same therapy, they lose weight, that is a sign to reduce the diuretics. And we can do it more freely after the 6 months.
A small comment about the previous question. I think it's a huge topic nowadays in patients with tricuspid or mitral regurgitation and atrial fibrillation. It's very difficult to tell which is the chicken, which is the egg. And we have in our program a lot of cardiologists who want to do the ablation first and then the clip or the tricuspid or mitral valve replacement. Because if the ablation is successful, there is significant remodeling on the atria and on the annular sides. But of course, if it is unsuccessful, there's a problem. But there's vice versa. I think there is a study that they did clip first and then ablation versus first ablation then clip, and it proved that the clip first has better outcomes. But there is still a lot of attendings that they send the patient first for the ablation, and if it is successful, then it makes either the tricuspid, the mitral goes away, or the annulus is much smaller, so they can put a smaller device.
I agree, but we have two procedures. One procedure is successful in 50% of the cases, the ablation, probably 25% in the long term, and then you have the other procedure, the clipping, that in the mitral valve is successful in 98% of the cases, and in the tricuspid valve is in 80-something% of the cases. So why to go first with a procedure that is successful in the long term in only 25% of the cases? That's my
Because you can save a second procedure. Because if the ablation works, then you don't need to deal with the mitral.
Yeah, that's like for a few months, and 6 months later we'll need it. It's just a matter of timing. Exactly. In my view, it's a matter of timing. I guess it's very difficult to understand. Is the AFib producing the dilation, or is the dilation producing the AFib? You have to also take into account the chronicity of events and what's the time frame. I think it's a rough question. The way to ask it is to turf it back to electrophysiologists and say, if you're sure it's going to be successful, go ahead. So at least I have the burden to tell you and the patient that they have a good reasons to believe they're going to be successful, because if you do it and it's unsuccessful, that's not very rewarding for anyone.
But with such a large atrium, the possibilities of success are quite low. Thank you very much, Kostas. We have to congratulate Kostas. Before we go, George, and I'm going to hand you over the continuation of the session, I would like to ask just one question, may I, to Elias?
Ilya, we have the live in box anyhow, so please join us up here.
Come on. Vlasis, probably.
It's okay, but Vlasis is online. But Elias is going to be right there for the...
It's a family matter anyway.
Yes.
Elias,
so, go ahead.
Elias, I'm not familiar actually with this particular field, but I realized that 3D eyes, which is quite costly anyway, might be a valuable complement, potential alternative to transesophageal. Yes. I realize that it reduces the procedural time, does not require general anesthesia. What do you think about 3D eyes?
Yes, absolutely. I think it's very, very important. It's the next day, and it will enable a lot of cases that nowadays cannot be done because of the bad imaging or a lot of artifacts because of valves in the left side or other problems with the imaging. But also, it could avoid the general anesthesia also. It's a very important thing. In some cases, it could be complementary to the TOE. We can use both and change between TOE and eyes.
Yeah.
But of course, there is the cost. It's
a cost, yeah. And, you know, quite frankly, it's also the complexity where the images go. There's so many screens. One is upwards, the other is kind of upside down to one another. So it adds definitely a little bit of a complexity on, you know, disconnect one to put the other. So don't imagine that you look at all of them at the same time. But it clearly can help because one of the limitations came up everywhere is you got to have a good images. If you don't have a good images, you're not going to accomplish much. So that's the problem. Let's go to live in box. Dr. Niños.
Hello, can you see me? Can you hear me?
Oh, very well, yes. Ilya, join us here to explain some of the imaging and join us in the panel, please. Yes, go right ahead. Vlasis, start playing.
So I've been following your amazing discussion, really highlighting the aspects, and I hope that this recorded live case of TTVR will also show some of the aspects that you've been discussing. So 85-year-old female patient, severe tricuspid regurgitation, obviously significantly symptomatic, had 3 recent hospitalizations due to decompensated heart failure. You can see some of the comorbidities. That's a typical triluminate patient. So atrial fibrillation, female, some renal dysfunction. You can see the right heart catheterization. We perform this in every patient to have an idea of the pulmonary circulation, the pulmonary vascular resistance. So some moderate pulmonary hypertension, but the wedge pressure is not really elevated. Transpulmonary gradient is only 10. And you can see elevated right-sided pressures. The mean is 13 and the V-wave is up to 24, but with good cardiac index and not a very high PVR. Euroscore is also borderline high. So this is the TE. You can see there's an atrial component that was discussed earlier on the mitral. You know, it looks like a prolapse, but it's not a prolapse. There's this whiff of central MR, and this is the tricuspid. As Elias and Michalis had highlighted, we scan the valve in this RVO view, the commissural view from posterior to anterior, from the free edge to the anterior, and we can see the quality of the leaflets. So it's a good case because you have this you have good leaflet length and mobility. There is some dilatation of the annulus, but really not a lot. So the leaflet to annulus ratio, which in my humble opinion actually works very well, is favorable here. And what was very interesting in this case, we didn't have a transgastric view. I mean, I tried when I screened the patient, Elias tried during the procedure, but we had a very good mid-esophageal view, and we implemented NPR on the screening process. You can see it's a true tri-leaflet valve with a septal, anterior and posterior, small posterior leaflet. So actually it's quite favorable anatomy. with, as you can see, a central jet of severe, maybe massive tricuspid regurgitation. And this is the NPR in a close view. You can see on the top right the transgastric equivalent of the short axis view, and then you have on the bottom left the RVO view, the commissural, and the long axis view, the grasping view on the bottom right. And this is how it looks on the bicommissural view, so significant mitral regurgitation. So let's have a look at the live in a box. You can see the insertion of the guide catheter through the groin. You can see on the top left the echo images, the fluoro on the top right, and the table, and also some of the hemodynamics. So clip delivery system goes through. This is a tri-clip case, so clip delivery system goes through. It gets inserted on the stabilizer. And then once we get in a straggling position by monitoring, as you can see on the echo, we're going to flex down towards the tricuspid valve. We also use some of the L knob on the guide to get it away from the septum. And then flexion is pretty straightforward in these cases. There's nothing really spectacular about it. Once you have good orientation on the echo, it's quite easy to actually get down towards the tricuspid valve. You can see it only takes a few seconds. So a tricuspid TEER case actually is a little bit easier, at least in the first stage, because you don't have the transeptal puncture. Once your clip is in position, you can get your views right and get your orientation right. So we give a couple of minutes for the echo to settle. In our department is, as you mentioned earlier, a family business. So I'm really grateful for my cousin who is among you, who has taken a lot of bullying over these years in order to get the pictures very fast. But actually, I'm very grateful to him. And so what we did in this case is once we got our trajectory right, and you can see on the echo image on the right side, you have the long axis trajectory parallel to the septum, so we avoid any septal hugging. Perhaps I can show with the pointer here. This is the, I don't know if you can see my pointer. It's the long axis here. And then it's a matter of getting above the collar to get in the region of interest that is significant, and then opening the arms of the clip and getting the perpendicularity right. I'm just going to go a little bit faster here. Testing the grippers on the right side. And then getting the NPR view. So you can see on the NPR view, actually, we had a very good quality NPR view, and you can see we have a transgastric equivalent on the top right, the long axis on the bottom right, and of course the commissural view on the bottom left. And we were actually able to use this in live to grasp. So this is the gripper that is already on top of the lateral leaflet, and we swing septally. We also use the fluoro to make sure that we don't rotate, but in this particular case, we can also see the short axis. So you have all in one. And now we go up and the septal leaflet is in position. And once we drop the gripper, we correct the rotation of the system, and then we lock and we close. And we try to do that first time if possible. We don't like to open and close on the tricuspid leaflets. They're thin leaflets, so by doing as less as possible, you avoid injury. So now you can see we have a convincing grasping on the leaflets. And at the same time, you can see them both on the long axis view as well as the transgastric equivalent, like the short axis view, the bow tie sign that Ilias was referring to earlier on. This is actually very nice when you can get a good NPR view to do that in real time. Actually, it saves time. It saves a lot of effort from the echo to go to the stomach and backwards. To orientation, and you can actually have, I mean, the resolution of the equipment we have today is amazing. And now you can see we've already had some reduction on the tricuspid regurgitation. Most of the anterior jet has gone, and we always check Of course, the leaflet insertion, we do all the regular checks, make sure we're happy, recording the grasping and reviewing. And you can see, and this is now a release of the clip to make sure that, I'm just going to run it a little bit faster. All the steps.
Yeah, good idea.
Yeah. And so this is deployment of the first clip. You can see it stayed in position on the fluoro. And now second clip goes in. We want to put that a little bit more posterior to the first one. Again, similar steps like flexing down towards the tricuspid valve. We know that on the fluoro, that means that it'll have to be lower compared to the anterior clip. The posterior clip, again, we follow the same steps, trajectory and perpendicularity. You can see now we are on top of the anatomy. Again, we're setting the MPR views, making sure that we get all our axes right. The leaflets, the arms are open on top of the long axis view. And we're setting up our short axis view as well. So we have all in one. That's pretty straightforward. We can check our perpendicularity in the top right here. So you don't have to move to the transgastric view to do that. Actually, we didn't have a transgastric view on this patient. And once we're happy, we close the clip and then we dive into the ventricle. You can see it very gently by monitoring the relationship on fluoro. Fluoro actually helps a lot when you put the second device. Then we open under the leaflets. Just under the leaflets, you can see the leaflets are already in position on the MPR. We're ready to grasp, so it shouldn't take that long now, going up, making sure that both leaflets are going in. And hopefully you will see the grasping in a minute. We need to make sure that both leaflets are in position. I think we dropped the lateral gripper here. We're moving a little bit more towards the septum. We prefer to go independent grasping on the tricuspid valve. It's a bigger anatomy, and you do this way, you do the optimization of the leaflets at the same time. So grippers are down, locking the clip and closing very carefully, all in MPR view. MPR actually, it was key in the success of this case. You can see also on the fluoro that the two leaflets are parallel to each other. So there's no relative rotation. And then we assess the result, and you can see it's a very nice result. We took care of the posterior jet as well. Both clips are adjacent to each other in the anteroseptal rotation, very close to each other, no gaps in between, no color in between. And, you know, after checking all this is the deployment of the devices, and this is the final result. You can see the fluoro of these devices. And of course, hemostasis with a figure of 8. We don't use any ProGlide because it's expensive. So this is the final outcome. You can see there is some regurgitation, but clearly there is a reduction of 2+ or more in this from baseline to the final result. This is the baseline. It's always nice to go back to the baseline because, you know, sometimes we need to get rid of these little whiffs of color, but, you know, you need to have things into perspective. And what is interesting also is looking at the hemodynamics. Is this the right atrial pressure before? The V wave was 23, patient on sedation with a mean pressure of RA pressure of 10, went down to 8, mean pressure of 5.
Great. That was a terrific.
Thank you so much.
Thank you. That was a terrific imaging and hemodynamic result, and very well explained. I'd like to have Dr. Leontiadis come up to the podium to get ready for present his live inbox, okay, and at the same time make any comment, offer any comment regarding this first case.
Okay. Now the last case is from our hospital, Dr. Hadji Tofi, on a patient mitral clip.
Yes.
A mitral bridge patient, a candidate for heart transplant who underwent mitral edge-to-edge repair. Maria.
Πάτησε το κουμπάκι.
Okay. Thank you very much for the invitation. Good morning. So I'm going to show a case from our hospital, from the Onasios Hospital. It's about a young female, 32 years old. She has a dilative cardiomyopathy with an LVEF for 30%. As you see, she has all the optimal heart failure medication. And although she has all of this, she has dyspnea in mild to mild exercise and recurrent cardiac decompensations. We screened her in the coronary angiography. She has no stenosis. Of course, she's 32 years old. We did perform a right heart catheterization, where she has a pulmonary hypertension from 47 millimeter Hg. In the echo, we saw a severe MR. As you are seeing in the images, we have here in the mitral valve a tenting from both leaflets with recurrent severe MR with a pizza zone. And as you can see in this slide, the MR is going through the whole valve. Afterwards, we performed a transesophageal echocardiogram in order to see how the leaflets are, what the anatomy is, and if she's suitable for perhaps a TEER. As we are seeing here, we have both leaflets are large enough in order to perform TEER at an M-TEER, and as you see, she has two jets, if we can see that, and it's one in one medial and one in the lateral side. A few words about the MR classification. We have the first classification, it's the quantitative with mild, moderate, and severe, and we have the Carpenter's classification, that's a morphology classification. In this case, we are talking about a Carpenter 3B, that's the tenting from the leaflets with a restricted closure during systole. It's a functional MR, we can say. Here from the guidelines about how we quantitative can make the classification from the MR. As you can see, I would tell only a few of that. We need a vena contractor width from above 8 millimeters if we are talking about a biplane, a ROA from above 0.4 millimeters, and we have a dilated left ventricle, a dilated left atrium, and a holosystolic jet. Also from the guidelines, we have a workflow. We at first try to have an optimal medical treatment, and if it doesn't work and the patient is although has symptoms, then we are then it is suggested that we perform a TEER. As we can see here, it's a 1B classification that valve surgery or intervention should be recommended if the patient has a severe MR and remains symptomatic, although the medication is optimal. Also, I would like to say a little bit about the mitral bridge study that also tells us that they studied about 119 patients with a severe MR who were listed for transplantation or before a heart transplantation could be done. And as we see, the primary composite endpoint was achieved by 63.5% of the patients. The composite endpoint was that the patient could undergo a heart transplantation successfully. Patients that were too bad for a heart transplantation could enter the list with the TEER, and some of the patients, 23%, it's not small amount of patients, could be delisted because they were clinical, because of their clinical improvement. Taking all of this in consideration, we decided, the heart valve team of our hospital decided for our patient to undergo a mitral transcatheter edge-to-edge repair in order as a bridge to transplantation. In this patient, we did a mitral clip, and I will go through the video and say a little bit about the procedural steps. Of course, the patient was intubated. At start, we perform, although we have the screening TOE, we perform a screening TOE on the table in order to see in order to see again the leaflets and the jets, the optimal views. And the whole team, the interventionalists and the echocardiographer, and the anesthesiologist, the whole team of the operation discusses the goal of this procedure and what we want to do. In this patient, we decided to go with a medial clip and see how much MR is left and do more work through. We go from the vena, from the femoral vein under echo guidance in order to avoid a dissection, as you can see here. And after that, we go with the catheter. And afterwards, we go with a catheter to the right atrium, and we insert the needle for the transeptal punction. Everything, of course, is done under echo guidance because it's very important to have the optimal height for the puncture, as we need about 4 centimeters from the mitral valve ring. And, of course, the puncture should be done in the fossa ovalis. I'm going a little bit here where the puncture is taken through. You will see here the fluoroscopy and here a little about data about our hemodynamics. Here you see the catheter and the needle. This is here, and you see the tenting of the fossa ovalis. And we are doing our measures, everything under echo guidance. I'm moving in a little bit quickly in the puncture moment. Here you see the tenting. We do it always in biplane so that we have both views and know how much distance we have from the aorta. So in here, he goes through. So here's a moment. You see the tenting and how the tenting was released. We are, the catheter is in the left atrium now. And then we are going with the wire to the pulmonary vein for stability. You see it here, we are seeing the catheter and the wire is coming out. It's very important to see that it doesn't go to the LAA. That's why we are doing it always under echo guidance. So, and afterwards we are preparing the guide, the mitral clip guide, in order to go above.
We can go a bit faster because we're in the break time already.
Okay. Here's the moment where the guide goes through the septum. Here it goes through. You see the tenting and the tenting release. And here comes the clip, who is outside. Then under echo guidance, we are guiding the clip on the mitral valve. And under 3D, we are performing where the orientation of the clip, how it's going under the valve, and then we are diving into the left ventricle after we decided the correct position of it. Under the valve, we are performing also 3D in order to see here, in order to see where the clip is, if we are everyone is happy for the position. And afterwards, I'm going a little bit faster. That was too fast. Here. Yes, we see here how the leaflets are in the clip, and the clip closes under echo guidance. Here, you see the leaflets in the clip. So we are performing afterwards our controls. If everyone is happy with the result, we had a residual 1 to 2 MR before the guide was released. We decided to let the clip in this position and do the afterwards control in order to decide if we are doing a second clip. That's the post the result. We had a left MR of 1 to 2. As you see, the MR comes from this area. We have their indentation, and we decided to leave this MR for the patient. That's also the transthoracal echo from the patient, where we see that the MR is 1 to 2, and we hope that we helped the we help the patient, and that the follow-up is going to be better, and that we have made time for her for the heart transplantation.
Okay, thank you very much, Maria. We know when we perform edge-to-edge for mitral, we go for a 0 or 1+, but in this patient, who is a candidate for heart transplant, we were very happy with the actual result, because her destination, her therapy is going to be heart transplant. Thank you very much. So anybody, any questions from the panel?
Dr. Adamopoulos, tell us a little bit about the timing of transplant and how did it go in your system?
Thank you, George. This is actually my comment. This is a very important procedure for us because, as you very nicely pointed out, 1/4 of this particular mitral bridge registry delisted. But on the other hand, our advanced heart failure patients are in a very delicate hemodynamic and prognostic balance. So we need to proceed with these sort of procedures to stabilize or even to improve the clinical status of our patients. On the other hand, we don't have to lose time in this sensitive category of patients to offer them the advanced therapies like mechanical security support or heart transplantation. So it's a very delicate balance, and of course, we have to select patients fulfilling the co-opt criteria.
Dr. Bouziouta?
Yes, I would like excellent presentation. Thank you all for the kind invitation. I would like to make a comment on this patient, since we follow up her for the last 16 years. Actually, her deterioration was in CPET, and she couldn't tolerate all the 4 bigs, the drugs that we give in heart failure. So 3 weeks after the procedure, she's doing well, and she's taking all her medications. And we hope that after 2 months, she could perform a nice cardiopulmonary exercise test, so we could make decisions for her. As for your comment, and the comment of Dr. Adamopoulos, for the patients that they may delay their listing for advanced heart failure patients, well, the point is that we have to select the patients that can be responders, be very close to them, because those patients are dynamic and may change their profiles. In concluding, I would like to share you our experience with our first mitral clip patient when we couldn't perform in our hospital 7 years earlier. And he was one of the candidates of this registry, and Dr. Sparias kindly helped us. He was transplanted a month ago, listed after all these years, not for deterioration of heart failure symptoms, but due to electrical storm. So it is of highly importance to, as Dr. Leodiadis mentioned, to change a little bit of their route if this is possible.
That's great. That was a long bridge, several years. Great, definitely worth. Any final comments? And anybody on the online, or the panelists online, please speak up. We don't see you, so I can't from here. So I'm not sure if you have a comment. Please go ahead and speak. Final comment from here, Dr. Adamopoulos.
Or Nikos, maybe. Nico, would you like to make some comments? Okay. No, my final comment is that we experienced a great session, actually, a great educational. I would like to thank all the speakers sharing with us their great experience. Thank you very much.
Excellent. We get a 10-minute break, and we will have the next session here about mitral valve interventions, presiding Dr. Athanasopoulos, who's already here, so don't be late online.
μπορούμε να ξεκινήσουμε την επόμενη συνεδρία. Έχουμε μία μικρή καθυστέρηση 20 λεπτών που θα προσπαθήσουμε, κύριε Ιακώβου, να μην την επεκτείνουμε καταρχήν και εν δυνάμει να την καλύψουμε. So the new session is coming with hot topics in mitral valve interventions. I have the pleasure to co-chair the session with Dr. Hisoheris and Dr. Savi from Israel. It's also a pleasure to have him with us despite these circumstances. The first topic will be given by Dr. Vlasis Ninos, with his excellent contribution overall. Patient selection for mitral valve interventions. Dr. Ninos.
Thank you, Mr. Chairman. It's a great pleasure to deliver this speak. And I will focus on the TEER because I saw that the following lectures are on the TEER. And the patient selection will focus on two attributes, two aspects. First is the selection of the pathophysiology nature of these patients, the stage of their disease, and concentrate on some of the evidence, and then some anatomical selection criteria, of course. So the duel over the previous years, since 2018 and up to the last year, has been between the COAPT and the mitral FR population. And this divergence, this strikingly different results, the neutral result on the mitral FR and the strongly positive result on the COAPT, led to lots of hypotheses, including the proportion versus disproportion RMR hypothesis led by Paul Graeber in his paper. And, you know, this way we try to explain, you know, which would be the ideal patient. And, you know, largely the very strong positive outcomes of COAPT trial actually led us to shape the guidelines that this population with an ejection fraction between 20 and 50%, with severe disproportionate MR led by the criteria of the study, would be the ones to benefit, and everybody else wouldn't benefit. But of course, that is not the whole story. We were all hoping that the reshape will be the tiebreaker. Indeed, this largely Greek study, and many of the contributors are in the room, Dr. Spargios, Dr. Chrysoheris, my cousin Elias, we led to a 505 patients cohort, and that gave a different population. So these were patients with moderate to severe mitral regurgitation in ERO of 0.23 versus 0.40 of the COAPT and 0.31 of the mitral FR. But what was significant is this population had smaller ventricles, and I will allude to that in a minute. And we saw that it was a massively positive result with the number needed to treat for 5 and a median follow-up of 18 months. And this was largely led by reduction of the hospitalization and, of course, improvement of the quality of life of the patients. Marginally, the all-cause mortality was lost by 2 deaths or 3 deaths. We knew that the study was underpowered. This population was low risk. The control group was low risk, about half the risk of the population of the COAPT. But these endpoints have been massively reduced, as you can see from the p-values, and this was a positive study as published in the New England Journal of Medicine. Look at this population. So clearly Reshape has got the lower degree of mitral regurgitation, but the left ventricular volumes of the Reshape are same, almost similar size to the COAPT. So this is a proportionate MR, not disproportionate, but the ventricles are not that dilated compared to the mitral FR population. So possibly these patients are not in the end stage disease. That creates a new hypothesis about who to select for application of TEER therapy, patients with secondary MR, proportionate, not very dilated LVs, but we shouldn't perhaps wait until the mitral regurgitation becomes that severe, risking this way for the patients to get to the end stage of the disease, because we all know that the time course between moderate to severe and severe mitral regurgitation is largely unpredictable. A few patients during this course, which may be a few weeks, a few months, or a couple of years, may end up in an irreversible damage, and then it might be too late or futile, like the mitral FR population. So these are the graphs that shows the reshape HF2 is proportionate versus coapt, but definitely the volumes are lower. Now, what about the anatomic selection criteria? Clearly, a central mitral regurgitation with no calcium, no coaptation gaps, good enough leaflet, like a leaflet length above 10 millimeters, no calcium, relatively focal versus a restricted anatomy with short posterior leaflet, calcium, small mitral valve area, presence of a ring, or even too extended damage on the mitral valve, like a Barlow's disease, are the two ends of the spectrum. So we know that this patient can be treated very, very reliably. The Expand G4 and our personal experience, which is now published, showed that these patients should achieve +1 or less residual MR in over 98% of the patients. This is the green light versus the red light. So this is the calcific restricted mitral valve with a short or even absent posterior leaflet. And these patients have got higher chances of having stenosis or inadequate reduction or even SLD. Clearly, this is the red light population and we should steer away. Perhaps this is the population that should be treated with TMVR. And the yellow light is something in between with borderline areas, borderline length posterior leaflet, tending heights, or multiple jets, commissural jets, and large widths of prolapse. These patients can be treated. The Expand G4 showed reasonable results, but we have to be careful. If you put a device in the middle of the valve and have not a good enough reduction, then these patients will not do well, and then you're left with a device in the middle to treat later on, and that is another additional problem. So the key clinical messages is the new evidence of reshape, and it's really, I'm really curious to see the new guidelines will incorporate the reshape data. They should, in my opinion, reinforces that the MR is a therapeutic target, not a bystander, validates the early and proactive intervention, and actually broadens our treatment scope beyond the coap patient. So in my humble opinion, we no longer need to debate whether treating MR helps, but we need to focus on who we are missing. Thank you very much for your attention, and I'm open to questions.
Thank you, Dr. Nignos. It was a very pragmatic introduction of this topic. Other comments?
Congratulations, Vlas. It's a beautiful overview. Indeed, what we need to consider is who we are missing and which patients actually tend to even go for surgery still in these days for just functional MR. That we could, we need to discuss and explain to the patients that there is an alternative option that's significantly safer and very effective.
I agree, and I don't want to sound too polarized in that, but you know, if you wait long enough for the patient to get to an end-stage situation, then the therapy is futile. Early intervention helps. Early intervention means better outcomes because these patients will have less dilated annuli, less gaps, less stenting, and then putting one device in the middle will actually do the trick, and you'll have a wonderful result. And we've seen that this is meaningful. It's actually prognostically meaningful. Whereas surgery right now is not even supported by the guidelines unless there's a concomitant revascularization. So I really see if there is no argument in that.
Very good. Okay, any comment from Dr. Savi? Dr. Savi?
Good morning, and thank you very much for inviting me. Excellent presentation, Vlasis. And I think it is important to emphasize also your point of early intervention. And it's very important also to limit the time for allowing medical therapy to kick in. I remember that you waited years for up titration of the medical therapy of heart failure population, but we know now that we should wait for 3 to 4 months from the diagnosis of heart failure until up titration of the medical therapy, and then reassess the patient. Patients with severe MR who are still symptomatic should go for early TEER and not waiting for additional time, because then the patient deteriorates, and as Vlas said, this therapy might be futile. Another important topic is the ability to uptitrate titrate the medical therapy after TEER. We know that TEER also allows us to increase the dosage of heart failure medications and get better outcomes. So this is another point that should be discussed with the heart failure physicians to allow patients to get the best medical therapy after treated with TEER.
Vlasis, I will take the opportunity to make a comment concerning the severity of mitral regurgitation, the functional MR, is not always what is considered to be at rest. Usually there is a dynamic component. And this is a very, very prevalent phenomenon on functional MR, and probably the data from the ReShape-2 justifying the necessity not to be restricted to the very high severity of MR, but also we should take into account the less impressive severity, which probability-wise implies dynamicity. And moreover, I'm concerned about the restriction of the anatomy of the LV for the end-diastolic volume. In MR, the key component for the outcome concerning the functionality of the LV is the end-systolic volume. And we should be aware that the end-systolic volume is the most important component to justify what is the underlying contractility reserve of the LV. So which are the relevant data from the ReShape-2? Have you any comment about it?
I mean, these are excellent points and show the versatility of the disease process and the unpredictability. Also, the fact that loading conditions and afterload situations can alter the phenotype. Let's not forget that exercise testing, also exercise echocardiography, has been validated in some of these patient subsets and actually can give additional information. Unfortunately, ReShape doesn't have a dissection of the echo data yet, so we don't know specific subgroup of patients and analysis, and whether we may come up with some conclusions for specific volume subsets like LV volume. But what is very clear in this is a low risk population with relatively small LVs, quad-like, and less burden of mitral regurgitation, at least on presentation of this and assessment and recruitment of this population. And we still saw significant benefit. So clearly, there is a lot to learn from this. And I don't know what your opinion is in the room, but I think the guidelines should incorporate this population. It's a randomized study with positive outcomes, and I think we should expand the treatment for this population.
Okay, thank you. Any comments for the audience? Dr. Koustogiannis.
Thank you, Dr. Minos.
Button.
Do you think that we are moving from the degree of the MR to the degree of the reverse remodeling viability to set some cutoff points of left ventricle to reject some patients or to accept some other patients? Or you have some cutoff points of the left ventricle to accept some patients?
Well, that's a very good question. I don't think we have good enough data to support remodeling following TEER. There is some data on the quad that there is some degree of remodeling, but generally TEER is not considered as a remodeling method. I mean, there are other devices that are being evaluated as we speak for LV remodeling, like the Carillon device and the Empower trial, and also the IQSINS device with the CoreSINS trial that they both run in Greece and other countries. But the problem is that there is a clear signal that if you exceed a left ventricular end-diastolic volume around 200 mils, for example, give or take a little bit, and if you go to 250, which is the quad, then there is a zone there that beyond that you may not get benefit. I mean, you don't probably harm the patient, and I think we should individualize. We've all done patients with LVs above LV diastolic dimensions around 7.8 or even 8 centimeters. Patient felt better, but clearly prognostic benefit is not there, at least with the data that we have. And I think we should be, the message, I think it's clear, treat these patients earlier. Don't wait too long, because if they dilate, they may not come back.
Okay, Dr. Pavlidis.
Yeah, just a comment on following the Dr. Athanasopoulos' comment. Well, based on the reshaped heart failure, as a general rule, we cannot really recommend, and it is not recommended that people with moderate MR and heart failure should be treated. So yes, as you have elaborated already, we have to be very careful in selecting these people, the patients. Regarding the end systolic diameter, you're correct, George. In a recent review, actually, by Eric Nishimura, who was the main author for the valvular guidelines in the US, he suggested that the end systolic diameter should be 45 and above so they dropped it even less than 50 that used to be. So it's really, until we have the analysis of the reshaped heart failure echo data and combine this with the co-opt, we don't really have a real, I mean, the experience of the individual center is very important in selecting these people. But as a general rule, we cannot really recommend, at least it's not recommended to treat these people with moderate MR and heart failure. That's at least, I don't know what, Vlasis, do you think about as a general rule? Because if this thing goes out, every moderate MR would be treated. And that would
I
not be a
totally
good
agree.
idea.
That's why I totally agree. And, that's why I said that we need to wait and see if this is adjudicated and incorporated in the upcoming guidelines. I think the message is softer, is that, if you have a patient with an ERO of 20, 25, you say, okay, patient has got moderate MR, not yet ready or appropriate to treat with TEER. Let's review the patient earlier. Don't wait another year before you review, because by that time, patient might have decompensated. The time course is unpredictable, and we've all had these experiences. Patients go in with decompensated heart failure, they get into renal trouble, pulmonary edema, and sometimes then it becomes futile. So watchful waiting is something that should be implemented, but actually be implemented, and also optimize medical therapy in the meantime, if possible.
Yeah, one of the major problems remains the fact that we don't really know what is the optimal medical therapy, and what is the time waiting before you say, okay, I've done everything I can, and then I reassess. That's something in the new guidelines should probably be considered.
Well, it's a very interesting topic, because we have to take into account also the underlying substrate, the mechanism. It's a different mechanism if you have a dilated atrium with dilated annulus comparison to a dysfunctioning papillary muscle due to an extensive inferior MI. So it's a very complicated underlying pathophysiology. Anyway.
One last comment from an echocardiographic standpoint. I think focusing on the ERO as a single number to assess MR severity may be inadequate. We need to try and also incorporate regurgitant fraction in our thought process, because I think that's important as well.
Okay. Perfect. So thank you so much. And we have to proceed to the next presentation, which will be pre-recorded. It will be given by Julia Grapsa from this other side of the Atlantic. Tips and tricks for mitral transcatheter edge-to-edge repair, anatomy and imaging. We are ready.
Thank you so much for the invitation to be a part of the Advanced Valve Therapies 2025. And today I'm going to talk about the tips and tricks for mitral transcatheter edge repair, anatomy and imaging. And my name is Julia Grapsa, and due to the difference of time, this lecture is recorded from Brigham and Women's Hospital. So, and I Once again, I would like to express my gratitude to Dr. Iakovo and Neonastis Cardiothoracic Surgical Center for the invitation. As we know, the guidance for transcatheter intervention is distributed in pre-procedural, which is important for patient selection, intra-procedural and post-procedural. And in brief, it has to do with the anatomy, the assessment of scallops and commissures, because mitral valve can be complex. Also, if appropriate, to classify the valve according to the Carpentier classification, to identify, to select between clefts and indentation, and then we need to know about our surroundings, such as LV dimensions and left atrium, and also any left atrial appendage, spontaneous epicontrast, and of course we proceed to the Doppler measurements. As we know, the mitral valve is rather complex. Yes, it has two primary leaflets, the anterior and posterior, but as you will see, it's separated into the anterolateral commissure, the posteromedial commissure, the anterior leaflet, posterior leaflet, and they have 3 scallops each. And we usually aim to give the surgical view to the interventionalist with the help of imaging. And also, you will see that there is important this intercommissural diameter, which affects the diameter of the mitral annulus, but also the height. And it's important to understand the remodeling of the mitral annulus depending on the pathology of mitral regurgitation. When I say use your all senses when you visualize the mitral valve, because it's important to understand that we have the scallops, the mitral annulus, and it's important to give the precise location of the involved leaflets. Very commonly, we see A2P2 involvement, and this is where, for example, the clip is quite more easier than if we have A3P3 or A1P1. And then it's important to describe the presence of an extent of calcifications, if any, because that poses a challenge in the anatomy for edge-to-edge repair, and then to separate if we have any dentation versus real cleft, which would be a contraindication actually to a mitral edge-to-edge repair. And as we know, the Carpentier classification, that type 1 is when we have poor leaflet coaptation, such as dilate annulus from atrial fibrillation or restrictive cardiomyopathy. Then frequently we see now that we do edge-to-edge repair in type 2, when we see, for example, like a Barlow's or papillary rupture, and a lot of our patients are type 3B, which is ischemic heart disease, the functional mitral regurgitation, and of course sometimes dilate cardiomyopathy. Starting from the basics, and of course the first step, even when the patient is on the table, we need to do an anatomic assessment of the mitral valve. And we start from the mid-esophageal between 0 and 20 degrees, that we have the 4-chamber view, and then we see A2P2, and then we proceed to this commissural view, that 60 to 80 degrees, and then of course we have 90 degrees that we see a whole extent of the anterior leaflet. And of course, the last one is the 120 degrees to 135 degrees that we usually see A2P2. Depending on the pathology, this is a very easy view in order to be our guide for clipping. And then, of course, we alternate between 3D and MPR. Here, this is the surgical view that we see the scallops A1, A2, and 3, and then posterior scallops. So we always position the aortic valve on the top, and we need to be fast, and of course select usually multiple cycles in order to have a good frame rate on the left. As you can see here, it's 18 Hertz. It's important to understand the limitations for when we assess mitral regurgitation, because when we have multiple jets, and especially an eccentric jet, then the accurate assessment is rather challenging. And many times we will use the 3D vena contracta with multiplanar reconstruction, which seems that it has a great sensitivity and specificity to assess the severity of mitral regurgitation. Remember that here we have the 3D vena contracta needs to be more than 40 millimeters per mercury, and it depends a lot whether the regurgitation is primary or secondary, for example, when we have functional mitral regurgitation. But we need to take into consideration that the orifice, while it's circular in primary mitral regurgitation, is non-circular, and it's many times elongate across the mitral coaptation line in secondary mitral regurgitation. Then we usually assess the pulmonary being systolic reversal. However, with many times patients will have atrial fibrillation and elevate left atrial pressure, and it creates blunting. So I have not really seen that we have real flow reversal, with only very few cases that the patient is in sinus. Most times that we see blunting, and usually we use it when we have, for example, the mitral regurgitation that is borderline, and we want to confirm that, of course, it's severe with the systolic reversal from the pulmonary venous flow. And of course, if we have the continuous wave Doppler that's quite dense or dagger shaped, then it's we understand that the mitral regurgitation is pretty severe. It's important also to understand the left atrium, the involvement, and of course, we never forget the right heart, because the pulmonary pressures will be elevated when we have chronic mitral regurgitation, and of course, the left atrium will be dilated in patients with chronic AF, for example, all these patients with chronic remodeling of the left ventricle. So this is important to understand the pathology and also the process of having a chronic mitral regurgitation. When it comes to edge-to-edge repair, first, a very important step is the transeptal puncture and the guide catheter insertion, and then the positioning of the guide catheter and the delivery system. Then a very important role as the leaflet grasping, the leaflet insertion assessment and the clip closure, and then the deployment and assessment of the device post-procedural. So, as we said, step one is the transeptal puncture and then the catheter insertion. When we assess patients before on the table for mitral edge-to-edge repair, it's important to understand the suitability for edge-to-edge repair, which is an ideal anatomy here with a flail cap less than 10 millimeters, with a mitral area for more than 4 and no calcification. While actually, if we have mitral calcification and then complex anatomy, then the patient may benefit more for a mitral valve replacement rather than repair. This is a patient that I want to show you how we are performing the transesophageal echo on the table, and immediately we assess the patient, because we need to assess again the right heart, the anatomy and etiology of the mitral valve, the mitral regurgitation, and of course the left atrial appendage. And here it's important to understand about few qualities of the good transeptal puncture. We help the interventionalist in order to go to the posterior superior aspect of the fossa ovalis, and when we have degenerative mitral regurgitation, more than 4 centimeters above the mitral annulus is ideal, while 3 to 4 centimeters we use for functional mitral regurgitation. And here is a great central illustration from JACC interventions from this review paper from Mohammed Al-Kulif in 2006, that you will see practically the qualities of 3D transesophageal echo that helps us guide the transeptal puncture. And it visualized the real anatomical aspect of the interatrial septum, and then we measure directly 3.5 to 4 centimeters or more than 4 when we have degenerative mitral regurgitation. So here we start. We actually, here we have already done the transeptal puncture, and we assess in order not to cause any trauma to the left atrial appendage, and then we guide the system insertion into close to the mitral valve. Here is, you will see that the system has been inserted, and then we guide, rotate the edge-to-edge repair device. And then it's important to use the aortic valve as a guide. So we have we use the LVOT view, and then with X-plane we use the commissural view, and many times we will alternate between the 3D and MPR in order to position the clip. Many times we will go between 12 and 6 o'clock, and this will affect of course, if we have an A2P2 prolapse, then we will see that this clip is perpendicular to the mitral coaptation line and to be ideal in order to have an excellent outcome. Here is how we optimize the leaflets, either separately or together, and we do stage leaflet capture in order to, and we are making sure that we will see both of our leaflets at the perfection of from all sides. So if we have any doubt, then sometimes the intervention may want to use ice in order to see better the leaflets, or of course alternating views between mid-esophageal and then going to 3D and then multiplanar reconstruction, the MPR. Now then we deploy the implant and then we adjust it in order to have the best possible outcome, and of course not to create any significant stenosis after the implantation of the edge-to-edge repair device. Now, we are looking importantly the flow assessment, so we definitely make sure that there is no iatrogenic stenosis. This is a mitral clip insertion that gives a mean gradient of 3, and this we don't want it to be more than 5. And also we use transesophageal echo for the positioning, and if it needs repositioning, in order to have, as I said, the best possible outcome. And then we have an algorithm that I will show you on how to assess the clip and of course the regurgitation post-device deployment. Here is an example of to the extreme that this is a patient that they inserted actually 3 different clips, and then they did also a plug. You can see the clips and the plug that of course here you would expect that the gradient across the mitral valve would be significantly high. This is a very comprehensive algorithm that was published in the Journal of American Society of Echo, that you will see how to assess residual and mitral regurgitation after percutaneous mitral valve repair or replacement, and I would advise you to have a look. So, but however, we need to remember the traditional parameters such as effective orifice area or regurgitant volume. If we have more than 2 jets, we need to use our eyes and all actually measurements in order to provide an accurate assessment. So sometimes when there are complex jets, and especially around the device, these parameters may not be that accurate to assess mitral regurgitation. As a take-home message, after we separate actually all the steps, pre-procedural, to have an excellent assessment of the patient, and of course choose the right device for each patient, intra-procedural and then post-procedural, it's important to keep in mind the value of heart team for optimal selection of patients. The post-procedural mitral regurgitation should be graded using an integrative approach, and it's important it's to be similar to the pre-procedural echocardiographic baseline assessment. It may sound repetitive, but using the same protocol will save you actually from mistakes. And of course, the post-procedural assessment is challenging. However, a good echocardiographer will actually give a precise information about the nature of the jets, or the residual jets, and the severity. And of course, hemodynamics are an important step in the guidance of further management of this patient. With that, I would like to thank you so much for your attention.
It was a very didactic and pragmatic contribution to the topic. I believe that
it was a great presentation, a beautiful overview. Really, it's always helpful to remind us the procedural steps and how to obtain optimal imaging. And most importantly, assessment afterwards, which is always a difficult thing to do, to assess residual MR, and we have to really be very detailed in our analysis. Especially nowadays that we try to decrease MR as possible with one device as possible. We often try to reposition, optimize to get the maximum benefit with the first device before we consider a second device.
I believe also that it's a different task, apart from the quantification of the MR, concerning the organic versus functional MR. In the organic MR, we have to be sure that we have accomplished the anatomic reformation, restructure, whereas in the functional MR, quite often it is the different mechanism which might evolve during the procedure. And at the end of the day also, we should be aware that we need pressures of the LA. The final judgment, especially in the functional MR, because quite often, I'm sure that you have this experience, quite often with the anesthesia, during the intervention and before the final outcome, the amount of color is misleading. So we have to be aware of the pressures themselves in the LA.
Exactly, and it's not only echocardiography that will guide us in terms of success of the procedure, but also hemodynamics. And sometimes I've been in cases that if the hemodynamics don't improve, you really have to wonder whether your strategy, the position you put the device, or what's wrong. So, and maybe reposition a different way to improve your hemodynamics. Even though color might look better, if hemodynamics persist, then you have to sort of go back to that.
Okay, and comment from the audience. Okay. So we have to proceed for the live in a box from Dr. Sparias. Combined TR in mitral and tricuspid.
That in practice, what we heard from the previous speakers, with the patient that we did both procedures simultaneously. So a 76-year-old female, obese, very symptomatic. She had a sternotomy and aortic aneurysm graft a few years ago with normal coronaries. And now she's having multiple hospitalizations for congestive heart failure requiring IV diuretics in the past few months. She has significant functional MR and TR. And the LVEF is 44%. The RV is dilated with impaired systolic function, and she also has pulmonary hypertension. Comorbidities mainly is paroxysmal atrial fibrillation, some chronic renal dysfunction, COPD, and hyperthyroidism. BNP, as you would expect in a patient like this, is elevated, and is a patient, high-risk patient for surgical intervention. She is on full optimal medical therapy, as you can see here. Nothing is missing. Her chest X-ray. She has RBBB, and even to the last day, AF was in and out all the time. And this is the transthoracic echocardiogram showing the FMR, severe FMR. You see the tethering of the leaflets, even in the transthoracic. And you see it's a wide jet of MR from everywhere. And one would expect that this case might require multiple clips to have a good result, because the vena contractor is wide. And here you see a 3D of the valve from above. No obvious indentations or clefts, and the live 3D with color, and the MVQ analysis showing that it's FMR, the retraction below, and simultaneously you see this massive tricuspid agitation, also very wide jet, severe TR from everywhere. And this is the transgastric. You see it's a tri-leaflet valve, some gap in the middle, and the color is mainly anteroseptal, in the anteroseptal commissure and in the center. So this is our patient, and with that, let's move to the recorded case. Let's go to double, so we save some time. Michael is also here. You can see Michael is there with the transthoracic and the protection from the X-ray. Me, Dr. Katsianos,
Dr. Nicolaou, our anesthesiologist. This is transeptal puncture. We always do that with a safe sept. We're coming with a Pascal device, so this is the guide catheter of the Pascal. You see the Pascal is coming out in the left atrium, which is not very dilated. There's not a lot of space in the front of us, as you can see, but we managed to close the device to the default position, and now we are bending the device down. It captures the Coumadin reeds here, you see, the space is very tight, but with some maneuvers like going posterior and more farther flexing, we're below the Coumadin reeds, and now we're towards the mitral valve, laterally in the mitral valve, and then we do all the trajectories, which are essential. We have to check the lateral medial position and trajectory, the septal lateral in the X-plane view. This is the Live 3D for clocking of the device. We have to be perpendicular to the area we're going to capture, which is just the middle of the device. That was the strategy. This is a P10 device, it's a wide device, and we thought that we might be able at least try to see what the result we have with one device in the middle. You see how we corrected perpendicularity. This is a simultaneous clasping. So both clasps are falling down, the device closes, a bit rotated clockwise, as you can see. So we open the device, again we release the leaflets, we counterclock rotate, and then we'll try again. We don't want to distort the valve, so we're coming up as we can get, and we go for a separate clasping. I think this is the posterior. Here you'll see the posterior falling, yes, the posterior. The anterior is already inside. And look here, we have a very good result with just one device in the middle. But I don't know why we decided this is not good. And now you'll see another 5 or 6 minutes here. We decided we didn't like it, and we go for something better. And now you'll see we are setting that result again multiple times, because in our effort to improve it, actually, we're not getting such great results. And this is the beauty of this device, of the Pascal device. You can open and close it as many times as you want. It's very automatic. It doesn't damage the leaflets. So you have the luxury to try to get the optimal result with one device. So this is also acceptable, as you can see, very mild. But I guess, again, Michael says, oh, I don't like the orientation.
I don't
so
offhand why.
So we open it again, as you can see, although the leaflets are well in, and we have almost nothing. So I don't know why we decided not to leave it here. We do the measurements like we like it, but then for some reason, again, I think now we started wondering if the posterior leaflet is slipped out a little bit. So we open the device and we optimize the posterior, as you can see. Remember, the posterior is the tethered one mainly, so there is a lot of force there. So we close the device, we measure how much we have in and out.
Optimize posterior, thank you.
Optimizing the posterior. Again. So at one stage, actually, we closed the device and the posterior went out. So it's coming. So it's not that it was our, we were weird to try this. We had some indications, and that the posterior was like very tethered there. Here we're also rotated, so we don't like this. So we open again. And here you also see the hemodynamics. This is FMR, so usually the pressures in FMR, the LA are low. It's not like the DMR when you have V waves that are approaching the systolic pressure of the left ventricle, like 60 or more. But in the FMR, it's very important to get the mean left atrial pressure and to make sure that the mean LA pressure is falling down, is dropping after you position your implant. So here again, you'll see these multiple attempts, and this is something that you can only do with this device, not worrying about causing an injury on the leaflets, because it's nitinol and it's spring-like, it's closing. So here, I don't know if we decided to accept this, because that is some time ago, this procedure. I guess no, again. So because it was rotated, so we counterclock again, posterior independently, closing the device. And I guess this time we're not very happy with the color, because we had better color at the beginning. So we'll open the device again. So like I said, in FMR, George, we don't expect huge changes in the pressure, at least the V waves. Now we will rotate it counterclock, so we go clockwise. So you see we had a very good result in our first clasping, but we decided we can get it better. And you see now that the procedure becomes, but here you can appreciate how much better the posterior leaflet was clasped. And then the posterior leaflet was out. So again, so when you see these cases, that's why you want to be sure that you have leaflet insertion is 100% good, and you're 100% convinced that it's good before you release the device. So I guess this is our final. So we ended up with one P10 in the middle and with almost nothing of residual, but not. So even that, for some reason, we're not happy. So another clasping. So I guess this was because we were not very happy with the anterior leaflet, how much anterior leaflet we had inside. And I think this is the final. So you see the myocardial, the leaflet bridge, it's very symmetric. So the valve is not distorted. There's very little residual color. And now we release the device. So here is the release, which is very simple. The release with this device, it's just 1-2 steps, and it never fails. So this is our final result. And who would expect to have this result with just one device? But I think our persistence and perseverance with this device to get the maximum, it was granted with success. So same guide catheter, we turn our attention towards the tricuspid valve. Here is an ACE. We use the ACE always for the tricuspid valve, or almost always. So this is coming down. We use the LAO view to avoid the septum, to flex it down to the valve. And then you see the biplane here, midesophageal. We also want here to have the trajectories and the positioning of our device in the anterior, posterior, and in the septal lateral. We want to be in the center and the trajectory to be correct. Here you see that our device is very deep. So our device is almost within the valve. So to correct this, we should gain height, and we do that by counterclocking the guide catheter and then clocking the steerable. And you see how we'll do this, and we'll go higher. And we need to be higher to open the device so it doesn't entangle into the leaflets, because we need to open the device and check the clasps to see which is which. So we do this maneuver now, I believe, to gain height. And also, we check the right atrial pressure all the time, continuously. This is the gain height maneuver I was telling you earlier. You see how we moved now higher into the right atrium, and now we're going to open the device. So the device is open, we check the clasp, this is the standard procedure, we should know which is which, and this is a transgastric, so we go into anteroseptal commissure, and we need to be, the clocking, to be like 2 o'clock to 8 o'clock, to be perpendicular to the commissure, to the coaptation line. And once we find this clocking, then we close the device and we cross the valve, splitting the collar, always targeting the area where the collar is coming from. You see now we moved more centrally in the valve, so the lateral paddle is into the commissure, the anteposterior commissure, so it's impossible to capture something there, so we have to rotate counterclockwise, which we did. We're in the center of the collar, and then we do separately, first for the lateral leaflet, for clasping of the lateral leaflet, that you'll see it here. So you see the lateral, the clasp has fallen, and the lateral leaflet is inside. So now we have to clock the device, the guide catheter, to approach the septal leaflet, and we always check that our this movement doesn't rotate the implant clock or counterclockwise. And then we go higher. You see how tethered is the septal leaflet. So you have to scoop it from below and go up to make sure. And you have to time your movement with systole when the leaflet goes away from the septum. And so we did that. I don't know, we missed the final result. So this is again how we scoop the septal leaflet. So you'll see here how we finished with one device in the intended position and with a very significant reduction of the collar. And this is how the procedure ended. You saw the timing of the movement up to get it. And this is the final result, a very good result with one device in the anteroseptal position. Thank you very much. Oh.
Well, it was a wonderful presentation, providing us all the necessity to reevaluate properly the positioning of the device, and this is a great advantage of this specific one.
And this is the 1-year follow-up, if we can reconnect, because this is how you see the P transthoracic, the P10 on the mitral side, and the ACE on the tricuspid side. And this is the result in the mitral valve. Almost nothing. And this is the result in the tricuspid valve, very good. And if you notice here, there is also some moderate aortic regurgitation that we may have to take care in the future. Here.
I've counted 10 times, 10 or 11 times you've done it.
True.
10 or 11.
Yes.
Okay. Any comment?
One question. So we often see combined mitral and tricuspid regurgitation. And we know that in about 30 to 35% of the cases, the TR improves after mitral intervention. Question is, when do you choose to perform a combined procedure, and when you treat only the mitral first and then follow up the patient?
That's a very good question. We have this dilemma every day, as you have in your clinical practice. I think as we're getting more experience and as we're having better devices, advanced generations, more user-friendly, we tend to do simultaneous procedures in patients that have significant problems in both valves. But I think the main reason, the main factor that led us to go simultaneous is first the duration of the mitral valve procedure. So if that is straightforward, simple, and successful, and second is the imaging of the tricuspid side. If you have good imaging of the tricuspid side, then this is like inviting you with significant TR to also treat it at the same time. But we know from literature that only approximately 25 to 30% of patients with significant tricuspid regurgitation get some improvement after you only treat the mitral side. So the question is, can you wait for 1 in 3 or 1 in 4 patients to get this improvement, and the other 3/4 will come back with problem? It's a very difficult question to answer, and I think if you have the patient on the table, and also for logistics reasons, and if you're convinced that tricuspid regurgitation is significant, not just significant, but massive or torrential, and is not going to improve, then we more and more lately tend to do them together. What is your practice, Dr. Suri?
Well, I agree. This is the same questions that arise in our cath lab, and I agree. I think that in patients when you expect a straightforward procedure on the tricuspid, especially when you use a Pascal that allows you with a similar guide to go to the 2 valves as compared to the mitral clip and the triclip, and especially when I expect there's also a primary disease of the tricuspid. Sometimes you see some prolapse of one of the leaflets of the tricuspid. Then I expect that the improvement of the tricuspid won't be sufficient after treatment of the mitral. Then I go, as you said, also to do a combined procedure. But as you said, it's always a dilemma when to say, okay, let's wait to see how is the patient afterwards, and when to say, okay, we are here, let's go also for the tricuspid.
I'll say that the dilemma is more intense when you have a moderate to moderate severe MR, and the main problem is the tricuspid. What do you do in those cases? Do you also treat a moderate MR before doing the tricuspid valve, or you go directly to the tricuspid?
That's a big question. That's a big question. I try, when there is at least moderate MR, I try to treat the MR, because I think it is part of the vicious cycle of the tricuspid disease. So I try not to do isolated tricuspid when there is a significant MR, and moderate is for me a significant MR, especially when the patient is intubated and there is estimation of the severity of the MR. So moderate MR under anesthesia, I definitely go for a combined procedure and not doing isolated tricuspid.
Very good. One rare indication to do combined mitral and tricuspid is when you do the mitral, and because of elevated right-sided pressures, you get right to left shunt on the interdigital septum. So that really forces you to fix the tricuspid valve rather than just put a plug in the septal. So we've seen that work very well.
I agree, definitely.
Okay, any comment from the panelists? Dr. Koutsogyannis, Dimitriadis, Leodiadis, any comment? No? Okay. So I have to thank you, Kostas, once more. And
we can move on with Dr. Suvi in his presentation on MR TEER, tips and tricks for yellow and red zone patients, a very challenging topic. Thank you very much for being with us today, once again.
Great. Thank you very much for inviting me to this great conference. Unfortunately, due to unexpected events in Israel, I cannot leave the country now because there's no flight. But hopefully next year I'll be attending in person. So thank you again for inviting me. And I will speak about mitral TEER tips and tricks in the yellow and red zone. I have 4 cases. Hopefully we'll have time for all of them. 2 of the cases are leaflet issues, and 2 of the cases are access issue, which is also a very interesting part of treating the valve, because you need to get into the valve sometimes when there is some issues to getting it. But let's start from the beginning. We know that TEER is considered for patients with severe MR. It is an established procedure suitable for both primary and secondary MR. We have the classic mitral A2P2 functional MR as a candidate for the secondary MR, and we also have the primary MR with prolapse of one of the leaflets, and we know that the procedure is suitable and most patients will enjoy the benefit of a successful procedure. We also know that there is an anatomical differences between the mitral, which is directly related to your chances to get a good result. The classic green mitral valve is the A2P2 involvement with a mitral area of 4 with no calcification, with no significant flail gap. And as we go to the red area, the valve becomes more and more complex. And from the red and to yellow-red area, we always consider suggesting the patient a TMVR rather than a TIP. But we also know that most of the patients that are considered for an TMVR are excluded by different reasons, some of them anatomical, some of them others, anterior leaflets that need to do intervention in order to avoid LVOT obstruction. And we know that many of those patients remain without any treatment. So what is our ability to perform TEER in patients with complex valve disease? And I will present now 2 cases that might shed light on this issue. We know that in general, there is evolving indications for mitral TEER. We are far beyond the Everest criteria, and we are allowing us to do more and more TEER intervention in out-of-the-box indication, including complex anatomy. So the first case is a patient with DMR with flail of the entire posterior leaflet. This patient had several comorbidities, had a bypass surgery, a peripheral vascular disease, and he was hospitalized with heart failure several times. He was turned down from surgery. In all surgeons in Israel evaluated his cases and turned him down because of the anatomy. There's also some of the bypasses are crossing the chest, so they said that this patient is not a candidate for any surgery. So now we see the pre-procedural assessment. You can see here flail of the entire posterior leaflet, P1, P2, and P3, with multiple ruptured cord, which causing this disease of this patient. We see that the leaflets are big and allows us to use big devices, and allows us also to use multiple devices, because such a valve is rarely to develop any kind of stenosis. So we decided to start, and as we always do, if I think that I need multiple devices, I'm going first to the most medial part of the valve and putting the first device there. I must say that the grasping was a bit challenging because the valve was all moving, but I felt that after putting the first device, I will also stabilize the valve and make the other devices more easily grasping the leaflet. So this is the first clip. We put it on the most medial part of the valve. And of course, we can see that although the first clip is stable, there is still a lot of flail parts that are not affected by the first clip. So we decided to put an additional clip just close to the first one and then re-evaluate. This is the first one. And now we're putting the second clip close to the first one in the middle part of the valve around A2P2, and we see that there is still, of course, flail of the lateral part of the valve, the P3 area, and we can see it here. And then we decide to add another one. So I decided to put the third one in the lateral aspect of the mitral valve, but make sure that I have enough place to add another device between the second and the third clip. So now we're grasping the lateral part of the valve. Grasping is easier, but still a bit of a challenge because of the movement of the prolapse part. And here we see this is a third clip, and you can appreciate that we have enough space between the second and the third clip to add another one if needed. And it needed, because all the valve was leaking, so we decided to put the fourth one between the second and the third one, and by that we clipped all the flail parts of this valve. It is highly important in patients that they have flail prolapse, flail parts, to grasp all the flail parts. Never leave untreated flail parts, because even if during the procedure it looks fine, the day after or a month later it will become severe MR. And here you can see the 4 clips, each one beside that, all of them are symmetrical, in a good position, and this is the result of this TEER procedure. We put 4 devices. The severe MR decreased to a moderate, something like this, but the hemodynamics is very important. The V wave decreased from 50 to 15, and even more important sometimes, the pulmonic vein flow pattern. Sometimes it is more sensitive than the V wave. Especially when the V wave is around 20, 25 in patients with functional LMR, look on the systolic vein flow pattern and improve it. This should be your target, because this is the real hemodynamic effect of this procedure. We didn't get any gradient, and we also gave the patient an electrical shock and restore the sinus rhythm with this patient. Now follow-up of 2 years, I think, patient's feeling well, moderate MR, but no hospitalization. So this is the first case. Now go to the other side of the cases, not huge prolapse, but other things. This is a 90-year-old woman presented with sudden pulmonary edema. This is her valve. We can see here, relatively small valve. We see a combined pathology of severe mitral regurgitation and moderate plus aortic stenosis, which is common among patients with severe MAC. We can see here severe MAC and rupture cord. On the patient who is not suitable for any other intervention, not for surgery and not for TMVR. We can see here the fluoro of the valve. We can see here complete ring of calcification with severe MAC. So this patient is not really suitable for anything. And because she has a ruptured cord, she's very symptomatic, because this is a kind of acute mitral regurgitation. So we decided to try and go for a clip on her. So you can see here the device going down, and one of the problems with the MAC patient that there is calcium between the area of the MAC and the leaflet. And sometimes it is difficult to get into the posterior part of the valve. So in those patients, you go down to the ventricle, go as anterior that you can, grasp the anterior leaflet, then go up. After you cross the MAC, then slowly go to the posterior area and do independent grasping of the posterior area of the valve, of the posterior leaflet of the valve. And we can see here that the first clip had a very good result, but still we had a residual flail middle to this clip, And as we said before, we never leave a residual flail. So we added another clip. And I must say that one of the challenges in these cases was the imaging. You cannot really appreciate the grasping area because of the shadow of the calcification of the MAC. Therefore, it is possible and it is advisable to do the grasping in the transgastric picture like we do in the tricuspid. In the transgastric, you can evaluate and see the leaflet without the interference of the MAC. So whenever you have a calcification, go to the transgastric and evaluate your gasping there. This is the final result. We can see 2 clips in severe MAC. The patient improved. The TEER in the MAC is a minimally invasive, suitable for frail, inoperable patients, and can provide symptomatic relief. The limitation, of course, is the gradient that sometimes is higher than the conventional TEER, and sometimes, of course, patients with concomitant MS cannot go through this procedure, and it sometimes can be a complex procedure with difficult imaging. Therefore, you should do it very carefully. So this is the second case. I have additional 2 that are not related to leaflet issues. The additional 2 are related to the way to the leaflet. So this is a patient, he's 60 years old, with paraplegia, and the previous history of non-ischemic dilated cardiomyopathy. In 2020, 5 years ago, he had a mitral clip for severe mitral regurgitation. And we can see here that, sorry, it went here. So they put the first XTR, that was the device then. He had a good result, his V-wave decreased, but there was a significant right to left shunt that was occluded by Amplacer 14 in the same procedure. Unfortunately, in 2023, patients developed symptoms again, and he has recurrence of severe mitral regurgitation with a jet that is lateral to the first device. And when we evaluated this patient, we see that there is, of course, the ASD occluder in our way to get back to the left atrium. So what are the options of those patients? Maybe send him to surgery. We didn't want to send this guy for surgery because of his comorbidities. Therefore, we decided to try and go through the ASD occluder. However, we decided not to go in the middle of it because there is a lot of layers of the ASD occluder. We decided to go in the most posterior, most superior part of the LAD, of the ASD occluder. And the superior part, when you cross through the left part of the ASD occluder without crossing the entire entire ASD in the middle, which is difficult to cross. Then you need to dilate, and you don't really know if you can cross with the 24 French sheath of the mitral clip. So we're able to cross, see it, and then you can see in the right upper picture the angle of the delivery system. Because there is no movement in the septum, the delivery system is stuck in the septum. It is not very mobile. Therefore, you need to do special maneuvers that are not routinely done in the classic mitral clip procedure. We needed to use a lot of plus. We needed to gain height, and it was a challenging procedure to get the device into the mitral valve. However, we were able to do it, and we added another valve, another clip just across the first one that was implanted a few years ago. We got an excellent result with systolic dominance in the pulmonic vein flow. And when you evaluate the ASD occluder after we crossed back, there is no any damage to the ASD occluder. The patient was fine. suggesting that sometimes the door is closed but is not locked. And you can definitely go back to an atrium that had an ASD occlusion. And if I have additional 2 minutes, I will present the fourth case. Another issue of patients with an access issue rather than a leaflet issue. This patient had severe mitral regurgitation with occluded inferior vena cava. So we thought, what is the best way to go to this valve? Whether it's to go jugulary, but jugular really, you need to do, it's very difficult to do the maneuvers with the delivery system. So we decided to go in a transhepatic access. It was a very good collaboration with our angio operator that really accessed the hepatic vein, and he put the wire in the inferior vena cava after going through the transhepatic. We can see here the crossing through the liver area, and we can see here the transeptal. You can see that the transeptal is not in the best location. However, because you come with a different angle, this is something that you need to take. You will not be able to manipulate the angle of the transeptal needle because of the different angle of crossing to the inferior vena cava. So you go a bit anterior, and there's nothing you can do about it. Therefore, you should use a lot of plus knob in order to get a better coaptation and better delivery system into the left atrium. But after you fix the aortic hugger with a plus, the other part of the procedure are relatively straightforward. We're able to put 2 clips and to get an excellent result in the end. And of course, in the end, systolic dominance, which, as I said, is the most important part of the procedure. And at the end, the angio came back, and we were pulling back the delivery system, and he put a coil closure to the hepatic vein, getting a very good and safe result with no bleeding. The patient 2 days later went home with a very good result. So our conclusions are that TEER remains the most versatile technique with wide applicable indications. Of course, more and more applications are being explored, and due to the high safety profile and the minimally invasive nature of the TEER procedure, we can definitely suggest this procedure for more and more patients. Of course, most of this data on these unique cases is based on case series and case report, and further prospective research is necessary to reach conclusions regarding those indications. Thank you very much.
Thank you very much, Dr. Shuvi, for showing us that one of the key aspects of a good interventional cardiologist is to improvise and find solutions to any problem that may arise. So it's a great cases, all 4 cases. Thank you for that. Any questions from the audience?
Also for the panelists, Dr. Koutsogiannis, Dimitriadis, Leontiadis, any comment?
Very nice talk. I would like to ask you specifically about organic MR. How do you see the future of mitral clip in this entity? Because of 3 reasons. First, the vast majority of patients have P2 rupture, which is easy to grasp. Second, many surgeries do not perform, even now, a good repair. And third, the goal may be more liberally to bring the severity down to moderate MR, because a moderate MR is acceptable for a good ventricle.
So I think that this is a great question about primary MR. We are getting better and better, and now we can definitely compete with the surgeons with the results of repair. And now there are two big randomized trials, the REPAIR-MR, and another trial that's evaluating MitraClip compared to repair with surgery. So I think that we are getting a very good result with the edge-to-edge repair. The issue that some of the surgeons always say that, okay, we put also a ring that is related for the long-term result and efficacy of the intervention. We don't know it yet. We don't know enough data to show if a ring is really required in our procedure, which is, of course, now we do not really combine it with ring. But I think that in the future, if we want to suggest those procedures also for young patients that can go for surgery, we should think also for the very long-term outcome, which means 8, 10 years, and in those cases, we might need additional devices, not only a TEER, but I hope that in next year we also have percutaneous ring implantation, and I think that in the future we might allow it might allow us to do combined intervention to the mitral valve, which will probably also allow us to get a very, very long-term outcome, which allows us to propose our procedure also for young patients with primary MR.
Okay, so, Dr.
Another question from my side. Do you think it's a good strategy or a possible strategy to dilate an occluder, a septum occluder, if the sheath is getting stuck, especially in the case you saw already?
Yeah, there are some manipulations, but I think if you manipulate an ASD occluder, it is not really something that you can expect what will happen. So by doing our method, we tried not to get into the device itself, but definitely if you go through the device, you need to dilate with balloon, maybe do a gradual ballooning of the ASD occluder and then go with the delivery system. Another thing that you cannot really know what will be after you take it out. Will the ASD occluder remain patent after you cross through it and ballooning it with 24 French device? So if you can avoid it and go in the upper part, just when the disc of the left side is there, it is, I think, a better approach.
Okay, so Dr. Leodiadis, the final comment.
Just on a question, when before releasing the clip, when could you abort the procedure in terms of having an increase in the mean gradient on the valve?
Well, this is $1 million question. What is an acceptable gradient of a TEER? No one knows the answer. No one knows the answer. The cutoff of 5 is, I don't know, I don't use it. I must say that in many cases, I decided upon the hemodynamic aspect, which means if I decrease the LA pressure, the V wave, without increasing the mean LA pressure, which means the mean LA pressure is related to the mitral stenosis. So if I was able to decrease the V wave without increasing the mean LA, I go for it. Another thing that is important to realize, and we also published it, that there is important also for the gradient change compared to the beginning of the case, which means that if you started with a gradient of 1 and after the TEER you have a gradient of 6, I wouldn't live because it's too much. But if you started with a gradient of 4 and now you have a gradient of 6 and the LA pressure is good and the mean LA pressure is not going up and the V wave is down, the pulmonic vein is better, I live it. I don't care about this 6. But it's very, it's related to the individual, the pathogenesis of the mitral disease, and also the baseline gradient. It is different if you start with a 1, and it's different if you start with a 4.
Okay, so we have to close the session. We enjoyed a panorama of mitral valve interventions, and we shall proceed to the next one. Thank you, Dr. Soheris, Dr. Savi.
Thank you very much. Hi, Ari.
So one of the live in a box from Onassis Hospital will be transferred later in the next session for mitral, and now we have the opportunity to have 2 special keynote lectures. The first one is from George Dangas on TAVI and coronary artery disease. George.
Oh, very well, very well. I'm happy to hear Arik back online with us. This is a great pleasure, and let's see how he feels and how he comments about this a little controversial topic that used to be not so important, we thought, but turns out is more complicated than ever imagined in some ways. So first of all, the aortic stenosis has a lot of hemodynamic sequela in the coronary perfusion pressure and otherwise, and affects the function of the coronary arteries, and obviously it's also further affected by coronary artery disease. Ultimately, the coronary flow reserve and all the related indices are affected unfavorably. So what happened with coronary disease in patients with TAVR? I mean, initially, there seemed to be a lot of CAD, and lately, there doesn't seem to be so much. So first understand that in the initial years of TAVI, the patients were much higher risk in general. So to a certain degree, they're also much older. You remember it were the inoperables and the very high risk and the medium risk and all that. So expectedly, we believe those patients had a lot of CAD. At the same time, the definition, at the same time, because it was the initial trials, nobody paid that much attention in how do you define CAD in those studies. So the definition was also very permissive. So if you have CAD, some studies require even non-obstructive CAD to be marked as CAD. So there was a lot of people, there was a lot of, I would say, noise in the data field point of view. So over the time, and as we go into low risk, the patients are becoming milder comorbidities and expectedly lower CAD. At the same time, the definition became much stricter. In the past few years, the definition is essentially previous CABG, previous PCI, or any disease over 50%. So really, I'm talking about obstructive CAD, not any coronary disease. That's why the numbers seem to be plummeting recently. So let's understand that part. So on face value, one can say in the initial part how people did with a CAD or not CAD. And you can see in this analysis of several studies, doesn't seem to pay a lot of difference, maybe a little bit worse, but not so important. But if you go into important CAD, which is, I think, what everybody has really in mind when talking about TAVI and CAD, you can see that a reasonably complex, not very complex, syntax score over 22, all of a sudden you do have a significant interaction and a higher mortality as also expected. So the above result, the green, was a little bit unexpected. But I think when you look at it more carefully, that's why I say the way the data are collected and the way that the definitions of the data field are entered are very important in understanding what we're talking about. So talking about CAD that produces some high syntax score, mediumly high syntax score, then that becomes prognostically important, something to talk about. And the assessment of CAD is also a little variable. In the European guidelines, as a class 1 for coronary angiography. In the American guidelines, it's a bit more permissive. And if there is a CT angiography that we use for TAVI, at the same time, we have reasonable imaging of the coronary arteries, that's enough. In fact, I know that a major medical center in New York very rarely performs coronary angiography, and somehow they claim that their CT rules out CAD very frequently at a very high level of certainty. Somehow our CT scanners are not so optimized most of the time because of the differences in phases. But again, probably what they're evaluating is the proximal segments, and if they're happy with those, then they forego the distal segment and detailed analysis of coronary artery disease. We don't do that, but in general, that is what is available out there. The FFR and the IFR and all that have been a little bit flawed. There are some limitations. It's not a very, I would say, well-accepted consensus, but personally, I do use IFR for intermediate lesions in the patients in order to make a decision. Make a decision, it's important to also understand when I make a decision, are you going to go for TAVI, are you going to have a PCI before TAVI, or you're going to have a PCI after TAVI? That's an ongoing debate a little bit. And there's disadvantages and advantages. PCI before TAVI is a more of an easy procedure. Why? Because you have free access to the coronaries, you don't have a metal cage to worry about, and all that. At the same time, you have a disadvantage that the patient has significant aortic stenosis. And when I practice that pathway, a lot of times I end up having to do a bridge BAV if there's a very complex procedure to be done, such a rotablator or something like that, a left main. A PCI after TAVI, you no longer have the aortic stenosis, but you have the drawback of how you're going to engage practically the coronary arteries and all that in reasonably good, I would say, technical ability to perform a complex procedure, sometimes required. So to an initial result, some of these matters, sometimes you have to get an initial result from somewhere, perhaps the data limited or the quality of the study limited, but still makes news. And then you have to react to it, and then the subject starts getting discussed. Somewhat happened also here. We have a study here that indicated that the orange field, which is the minority of patients, seem to have lower event rates. So the minority of the patients were those who had a PCI during TAVI or after TAVI, essentially. So all of a sudden, they say, you know what? Why are those having low? Well, it's really bad if you do PCI after TAVI. That's how this came about in the news and in the discussion. And of course, what we understand about that is, first of all, you have to be cognizant that there's a patient selection here. So the people who have the PCI at the time of the TAVI seem to be selected for it. So would they have a very simple lesion or an overall favorable profile? Perhaps. And at any rate, we have to figure out better in a randomized trial. That's why it's very important, but at the same time, it worked to bring this whole subject into the news and into the discussion scientific community, because we had an unexpected result, that the stage PCI somehow did it better. But if you do PCI before the TAVI, you did worse, although the majority seemed to be in the blue pie, 65%. So talking about now PCI after TAVI a little bit more closely, because that's what we seem to be doing or seem to be advocating or supporting based on this study, you have to also look very realistically of how can you really engage the coronary arteries? Before TAVI, that's not a problem. You're hitting 100%. After TAVI, everybody says no problem, which means 83% for the left coronary artery and 64% for the right coronary artery. If you accept semi-selective cannulation, which might be okay for diagnostic angiogram of a medium importance, but not for PCI, or you have to figure out with guide extensions and all that, more involving procedures, you can reach about 96%. And you have about 4 or 5% of people who are very difficult to engage the coronary arteries, let alone to engage them with a level of ability to perform a PCI. So we have to be a little careful there because there's certain, this is not 0.1%. You can see the 5%, and if someone is less comfortable or less skilled in the coronary intervention field, we're talking about between 10% for the left coronary artery and 30% for the right coronary artery unable to access that. So we have a practical consideration. So let's see what this comes about. It comes about from the fact that the valve may be malaligned with the coronary artery. So although in the native sinuses you go in the coronaries, in the new neo-sinus you can't go into the coronaries because you have some material in front of there, either the valve, the cage, or the leaflet, or any of those. And you can see that the valve choice and the valve type, and in fact there's a lot of evolution in the evolute valve that seem to have more of a problem of that in order to resolve that. And you see that we have the newer additions of the FX Plus with some cells that are bigger in the areas of the coronary artery. So the manufacturers of the valves acknowledge this as a significant problem, and they actively have taken steps to help out the situation. And will continue to working on it. Why? Because everybody agrees it is important. So then we have a trial now, which of course it's a I would say a result of the fact that we had a good this surprise retrospective study. So in Canada, about a couple of hundred patients with symptomatic AS, a significant CAD, they were randomly assigned to have a PCI or don't have a PCI prior to the TAVI. And you can see that at 12 months, there was essentially not a big difference between the two, let alone that the no PCI seemed to have less bleeding. So all of a sudden, you have a broader situation here, saying, you know what, what's happening in these Canadian sites? Well, why you even have to bother with? And if you don't bother with doing a PCI, then secondarily, why don't you even bother defining the coronary arteries? So you see, one thing leads to another. Anyhow, PCI in patients undergoing TAVI was investigated in the Notion 3 trial a little bit more comprehensively from the Scandinavian point of view, and we can see there's conservative management plus TAVI and PCI plus TAVI. Let's see what happened at 1 year in this larger group, and you can see they're now double the size of the activation, about 500 people. Everybody picks up and says, you know what, the studies are like one way shows the other way. I don't agree at all. The studies are extremely consistent. If you look at 1 year result, which is the time point of assessment by the activation trial, this study also shows no difference. So the impact of treating CAD in patients with TAVI is a longer-term matter. It's not a 1 year matter. This study went out to 5 years, and you can see that although at 1 year things are looking good, exactly what activation did, showed in Canada as well, then beyond 1 year, you start having the problems. So the studies are actually quite consistent, if not identical. It's just that this study has just longer follow-up, and the differences emerged. These are the different secondary outcomes of death from any cause and myocardial infarction and urgent revascularization, again indicating that these patients were having non-QMI and related PCIs for the most part. These were the type of events that were not really deaths. What a good explanation. Then we had another study that said, you know what, these guys are crazy. What are we doing the PCI and the TAVI? Just send the patients for a bypass and a new valve. Well, how about that? Why do you need to muck around with the PCI before TAVI, after TAVI, during TAVI? cross a valve, don't cross a valve. Why don't we just send it to bypass? Seems to, at least on the decision-making point of the clinical cardiologist, that seems to be a simpler decision. Instead of having to continuously discuss with the interventionalist, just send to the surgeon, say, deal with it, and let's see how they dealt with that. About 150 to 160 patients per group. And actually, they did a FFR-guided PCI to even further, I would say, evaluate the situation. And let's see what happens with that. And they went ahead. And interestingly enough, the study had important messages that the Data Safety Monitoring Board stopped the study prematurely because things are really emerging as very different between the two arms. So are we in front of something unexpected? And indeed, it was presented in the PCR and later on published. And here, you see the result was staggeringly different in a completely unexpected way. The easy winner, the bypass plus AVR, was a big loser from in-hospital level all the way to 1 year, with an event rate of 23% versus only 4% in the TAVI plus FFR-guided PCI group. That included a staggering difference in mortality of 12% versus 1%. So one can deduce, one, perhaps the Canadians are no good in doing any bypass, which I hardly believe, or we have to really seriously evaluate all these shortcut decisions that in our mind think to be easy ones, and why not, versus to completely test exactly what may be happening in those patients. Be careful in the combined AVR CABG situations. And this is the outcomes after 1 year. It's mostly death and cardiovascular death that drove these results. And on the secondary outcomes, there was a lot of atrial fibrillation and, of course, repeat thoracotomy and bleeding with bypass. That, I would say, is expected. The unexpected was the death. And the strokes and the MIs and all that, they weren't really that different. So somehow patients didn't fare well because of other reasons, perhaps complications of surgery of some sort, and we're going to learn more about this study. But nonetheless, CABG plus SAVR inferior to PCI plus TAVI based on this randomized trial, and we're waiting for perhaps the next one to see if they can possibly refute the situation. And this is another example that we have. It takes now complete revascularization versus medical therapy. Clearly, these guys are favoring to do things after the TAVI, and particularly actually the TAVI with a balloon expandable valve in order to alleviate any concern that you might not be able to cross the coronaries. Let's see how this comes about, and I think I'll be interested to see that next year, in a few years, whatever. In the meantime, the guidelines are telling us that to consider PCI with 70% or more stenosis, and the American guidelines are a little bit more strict. They're indicating you have to pay attention in the left main, in the proximal LAD, in the proximal vessels, and PCI before TAVI gets a plug as a more reasonable approach, although it is a two-way indication. In patients with a low risk for surgery, then the bypass and plus CABG is reasonable, but this is, of course, 5 years ago and 5 years before. 4 years before the Canadian study I indicated to you that is perhaps expected to question this statement on the next guideline revision. Thank you very much for your attention in this session.
Thank you, George, as always, very informative. So TCW is the name to remember. Next time we deal with some argument with the cardiac surgeon and the heart team. Greg.
George, this was a great analysis, indeed, superb. One of the main reasons, actually, we have been deciding for surgery versus, TAVI has been the coexistence of coronary artery disease. And this analysis really, it tells the different thing.
Right.
And one more thing I liked is what you stated without analyzing, that you do use the IFR in assessing the severity of the stenosis. In all the studies, Notion 3 and the others, they use FFR, which might be wrong because it's a full cycle versus diastolic, which is the flow, and in aortic stenosis, the full cycle might not be very accurate. So I really enjoyed that this was a great analysis.
Yeah, the FFR, but also concerned from practical point of view, how some patients with AS might not tolerate the infusion. Sometimes you end up giving the low dose, you have a little bit of resistance. Oh, I would have resistance to go to the high dose. And you know, those very often actually in the stemmed actually from the era of several years ago, then a lot of these people had a lot of lung disease, but that
And it's physiologically more accurate, actually.
A little simpler, and at the end of the day also a little bit accurate. Yeah.
So my take, George, is maybe you are not penalized when you are dealing with TAVI and CAD in older ages, but in the younger, as you go in the younger group, you have to be really meticulous in treating coronary artery disease, right?
That's right. You have to. I think that the meticulous is a key word here. Is don't rush into fixing the valve just because that's a referral for. Just to go through the complete evaluation and let's prioritize the goals and use the stages. And I think it's an advantage of PCI. One can say it's a disadvantage because you cannot fix everything at the same time. But at the same time, on the other hand, is you fix things one by one. They're well tolerated, and you can see what impact it really has on the patients. Or, you know, you truncate the procedures, less die, less hemodynamic, less hospital stays, shorter hospital stays. And what's the big deal of fixing as you know, the way the schedules of the TAVIs go anywhere, you never get called by a TAVI and you got to have it within a week. It usually takes a few months. So in some cases takes 6 weeks versus 3 months. I don't think that's a big difference in order to get things regimented and well planned.
And according to this data and the guidelines, you should try to do the PCI before. But as we discussed yesterday, there are certain situations that you need to do it afterwards. For instance, if you're planning to do a rotablator in the left main or in the LAD, and maybe you should have your valve fixed before, right?
No, I never do those really in that. I just do a BAV with a 18 or 20 balloon before, like an incomplete BAV to get you through the procedure. We don't overachieve now to have like a gradient of 0 or something, but if you cut the gradient by half immediately before the procedure, you successfully go through the procedure really. In extreme cases, you have to put an impeller through the new valve. I guess you can, but through the valvuloplastid valve you can, but I think this is a rarity. Have a comment? Yes, Dr.
Yes. In last September, we saw in New England the Senorita trial from England with a population similar to our TAVI patients. And in 5 years, the conservative arm was the same advantage with a PCI arm, and even in non-STEMI patients, not in chronic stable disease. You have any comment about this in your talk?
Yes, the comment is that, as I indicated, we pay attention to left main and the significant proximal disease. So I have no doubt that there are lesions in the obtuse marginals and the diagonals or the distal LAD, and those contribute to a syntax score. Maybe they were part of some NSTEMI, quite frankly. They could be culprits or targeted in the Senorita. But I think here we're really dealing about the proximal disease, and I think that is the difference. I mean, we're not going to go after an AV continuation or a PDA or something like that in a severe AS patients. But a proximal RCA, a proximal AD, proximal circummajoramus or something, it's might as well not have that headache afterwards and clear it out before.
Okay, good. Arik, do you have a comment on that?
Hi guys. That was a phenomenal talk, George, you know. Before everything, I'd like to excuse my leave yesterday because we had a missile attack and alarm, so I had to run to the shelter. I hope it won't happen again now. Anyhow, it was a phenomenal talk, but you know, studies is one thing and your common practice is something sometimes else. And I think that I'm tired a little bit of saying again and again what I'm used to say, the patient-tailored therapy. I think that 85 years old lady with coronary artery disease and the tight aortic stenosis, yes, I can ignore the existence of coronary artery disease at first stage, and then later on, whether she's symptomatic or not, to treat it through the struts of the implanted valve, etc. However, I think that 65, 70 years old, and I want to remind you that the majority of patients in the United States of 65 years old and older are going to TAVR. So a 65 years old patient with coronary artery disease, I think that I can afford myself this task and do coronary angiography before, and if it's a proximal LAD or proximal SIC, you know, at the same time, treat it and then go to TAVR. So I think there is no good answer for that. I think it is patient-tailored therapy, but I think the data is pretty robust and we should not ignore it. But thanks again. It was an outstanding talk, George, really.
Yeah. Thank you, Arik, and all the best through all the troubles in your areas.
Thank you.
No, George, thank you, and maybe we will proceed to the next talk is from Roxana Beran, the recently elected president of the American College of Cardiology. She will talk on updates on heart valve disease and TAVR. Of course, I remind you and also the 285 colleagues that they are streaming now this conference. Please feel free to write in the chat whatever question you have regarding this topic.
Hello, Kalimera, Kalispera. It is my pleasure to be with you to talk to you about the updates on heart valve disease and TAVR. What's next? I'm so sad to miss the in-person meeting and delivery of this lecture, as I've had to travel for the American College of Cardiology as its vice president. But I'm really, really thrilled to be able to at least come to you via this recording. Today, we'll talk about updates on heart valve disease and TAVR. What's next? These are my disclosures. There's obviously no question that we've made huge progress over the last 2 decades. If you recall the very first patient by Professor Alain Cribier in 2002, April 16th to be exact, was an inoperable high-risk patient who survived the operation. Over the last 20 years, there's been so much progress from high risk to intermediate risk to low risk, and now the 2020 guidelines giving the class 1 indication is TAVR first in certain patient populations, and to 2025, where an asymptomatic severe aortic stenosis patient should have an early TAVR. And it is a very, very incredible progress. What's happened is that the annual volumes of TAVR and SAVR cases are there. You see through the STS, ACC, TVT registry, and high level of growth over the last many, many years, but certainly massive growth in terms of percutaneous TAVR procedures compared to surgical aortic valve replacement that is actually taking a dip. And we're seeing this growth in young, intermediate, and low-risk patients. You see these data from the data sets that are available, and very, very importantly, from our SDS ACC TVT registry, and a very important growth of low-risk patients, especially in the last 5 years. And what we need to think about when we're talking about young patients is the lifetime management of patients with aortic valve disease. Would it be SAVR, where you're the younger patient, and then in 15 years, a TAV and SAV, and then another TAV and SAV to get that patient to 95 years of age? Or is it to go to the higher risk surgical patients who then receive TAVR and TAVR and TAVR, and of course get them to the age that they could live by? And certainly in the low risk population, when there's been an individual patient data meta-analysis, we see that the stroke and death rates, in fact, the death rates are in favor of TAVR, but the combination of death or disabling stroke even on the favor of TAVR. But the very important difference is that we absolutely need to think about that even in the low-risk patients, but is this the right way forward, given that we need to manage these patients for their entire life, for their management of aortic stenosis, the lifetime management. But I think this study really pulled you aside with the early TAVR trial in asymptomatic patients with aortic stenosis that was published in the New England Journal of Medicine by Philippe Généraux in 2025, simultaneously with his ACC late-breaking trial presentation, when they dared to go after the asymptomatic patients who were deemed asymptomatic with severe aortic stenosis, and yet you see the separation of the curves in the TAVR patients with the numbers needed to treat at 6. Now, obviously, it's almost difficult when you're not doing a sham procedure to basically say that, okay, when you know you have severe aortic stenosis and half of the time you're going for surgery, that these other patients presented with need for aortic valve replacement, which was some of the things, but there were other events as well that separated these patients out in favor of this, and the FDA has approved this indication now. Why this is important is that over time, we've also seen a major reduction in TAVI complications with all of the new device technologies, and of course, you know, even cerebral embolic protection and better understanding on how to do with things. And in fact, in this small annulus, we were able to look at 2 different valve systems for the very first time, self-expanding versus balloon expanding valves, with a very important primary outcomes of valve dysfunction, as well as the composite mortality, disabling stroke, and heart failure for non-inferiority and superiority for bioprosthetic valve dysfunction, which actually deemed to be extremely meeting both of those very important outcomes, the primary outcome meeting non-inferiority for self-expanding versus balloon expandable valve for mortality, disabling stroke, or heart failure hospitalizations, but the self-expanding valve being superior in bioprosthetic valve freedom from bioprosthetic valve dysfunction, which was much, much lower in self-expanding valve compared to balloon expandable valve. And the superiority was also powered for women, which made a large majority of these patients. The new platform and tools to improve the outcomes are also there for very important guide wire technology, very important procedural optimization with cusp overlap technique, and then cerebral embolic protection to hopefully preserve some disabling stroke, maybe prevention, but I'll show you some of the data, but also coronary access for lifetime management with important changes in the devices that we currently have available, and also for devices that are open for future TAV and TAV. The cerebral embolic protection devices have gone through a very, very difficult course with a large patient population that was done in the NHS system in our UK colleagues with over 7,700 patients, who deemed to be suitable for a sentinel CEP, an opinion of the treating physicians without knowing the CT. Patients were randomized to TAVR without CEP versus TAVR with cerebral embolic protection, and basically showed absolutely no difference. Even though in a, this was an ITT analysis, but those who got cerebral embolic protection that the physicians thought they should be able to get it, 20% did not receive it. So it makes it very, very difficult to look at this and say that there's absolutely no benefit. But what's next is what's exciting. TAVR for bicuspid aortic valve, where we absolutely need more data to better understand this, because what we know is that it's probably safe and feasible, that it may be okay for 1-year mortality, the results improving with newer generation. CT is mandatory for procedural planning, and that this calcified raphe and highly calcific leaflets are associated with poor outcome, and especially if there's aortopathy there. But I think there are very, very important unanswered issues that we could actually find a place forward for TAVR in bicuspid valve, and that's going to happen through the Navigate Bicuspid trial, where it's a Bayesian and adaptive analysis and a very important event-driven approach, where we are looking at patients who are going to be equipoised for SAVR versus TAVR for bicuspid aortic valve, and Professor Windecker and Uni and Siepe are running this study with a long-term follow-up, and we will see what these data will show. In moderate AS, we have a lot of interesting ongoing trials that are going to be presented. The very first one was an overall negative study with TAVR on load with 600 patients, but now we have Expand TAVR 2 and Progress, where we're going to look at these patients in moderate aortic stenosis. And then TAVI for aortic regurgitation. This is an entire new area that I think is going to be growing, and it's very, very promising. We have the Align AR trial, where it's high-risk symptomatic patients with aortic regurgitation, where the technical success in a single-arm study looks extremely good. And I think for evaluation with a OPC, it looked very, very good, but I do believe we need randomized clinical studies to get this trial approved and this device is approved for pure AR. But in high-risk patients, maybe this could be better, and I think it would be great. The last but not least is if we could prevent aortic stenosis progression. Can we stop it? Now, there's been a lot of work that's been done with all these negative studies that makes it very, very difficult to go there. If you look at the early randomized clinical trials, there's a whole graveyard of them where we see no effect whatsoever on intensive lipid lowering, whether it's with simvastatin or ezetimibe with aortic stenosis, or intensive in calcific aortic stenosis. But I think the DAPA-TAVI trial gives us a lot of hope. This was a randomized 1-to-1 patients with patients who had diabetes, and at the time of hospital discharge after TAVR, they got a randomization to DAPA versus no DAPA, and what an amazing effect. These patients are absolutely gaining the benefit. It makes you think that there must have been some remodeling due to aortic stenosis, and that maybe we even need to, in early TAVR, get to them even earlier. But dapagliflozin and these newer therapies are very, very exciting. We, of course, need other areas to look at, Lp(a) being associated with calcific aortic stenosis. There could be a very, very interesting correlation, whether or not reducing the Lp(a) early, we could avert or change the progression of this disease, needs large clinical trials. So, my dear friends, for a take-home message and summary of what I've just told you, the last 2 decades have been amazing, disruptive for TAVI, expanded from inoperable patients to the lowest risk and even asymptomatic patients. The device innovation has reduced complications, improved outcomes, especially with challenging anatomy. And we are now broadening to bicuspid valve, moderate aortic stenosis, and pure AR. And now the future focus has to be on valve durability, personalized device patient matching, adjunct therapies, multimodality management, and prevention of aortic stenosis progression. Thank you so much for your attention. Ευχαριστώ πάρα πολύ.
So this was an amazing talk, very concise, very informative. So maybe in the future, a conference like that will be redundant because we are going to preemptively treat aortic stenosis, George. So what's your take?
Yeah, of course it is. Until the studies are designed, the work is done, and there is enough budget to pay for these expensive medications over the years, that's going to be about the time all of us will be retired.
Yeah,
but we need to teach the current students, though, because that's going to be a problem they're going to have to deal with.
I think as long as I don't see Medtronic doing any pharma business, maybe we feel safe.
No, I think we have to refer to the special session we had yesterday about the economics and see how that's going to pan out and how it's going to be figured out and fit in the budget.
Maybe this is the shape of things to come, yes. Maybe.
I have to move the special session to today, so take into account all the knowledge of the conference and have a second special session.
Maybe the universal bin counters, would take notice of that. So, good. So, if there are any other comments, we will proceed to Satellite Symposium. So, the next almost 1 hour, we're going to have Satellite Symposiums sponsored by Cardio Innovation. And there's a small change in the order of the talk. It's Professor Oldroyd from Glasgow will present the new data on the Empire study, the new catheter system of the Algra device, which is interesting. And Dr. Kosmas and Dr. Iliadou are going to start presenting the live in a box case. Maybe we have a camera issue, no? So it's coming. So there's a new iteration of the Algra device. There is not a permaflow system anymore, so the new iteration of the Algra will be like a receivaable and retrievable device like any other self-expanding device. So, Eleni.
Thank you. Thank you for the invitation. Welcome to our session. We have 2 interesting cases with severe aortic stenosis who are undergoing TAVI. The first case is a male, 79 years old, with dyspnea, NIHA 2 to 3. In his past medical history, he has undergoing aortic aortic valve replacement in 2021 with Magna is 21 millimeters. He has a coronary disease with 2 grafts, 1 to Limalat and 1 to radial PDB. He has ejection fraction 55%. It is a normal ejection fraction. He has a history of paroxysmal atrial fibrillation, hypertension, diabetes, dyslipidemia, and baseline creatinine 1.2 milligram per dl. We can see his medication with Eliquis, with double antithrombotic, with Eliquis and Plavix. He also takes diuretics with Tormis and anti. And he undergoing coronary angiography, in which we saw that the left main was without relevant stenosis. Left arterial descendant artery was 100% closed, and the graft to Lyman LAD was okay. Circumflex artery was also has also stenosis 99%, in which he undergoing PCI at 2024. His right coronary artery also has 100% stenosis, and his graft at LRA and to RCA was 50% stenosis. From echocardiography, we can see severe stenosis, severe aortic stenosis with aortic with aortic jet velocity about 3.95 meter per second. Here are some measurements from angiography, CT angiography, just to find which is an appropriate size of valve. In CT angiography, we can see that left femoral artery has some calcification plaques, so we choose to go from right femoral artery. Here are procedural steps. We start with light sedation. Where we access from right femoral artery under echo guidance, and from right radial artery. Then we with no.
Yes, so just to put it in a nutshell, so we are dealing with a very small valve. It's 21, right, Elias? Yeah. So 23. We have some access issues, but in the iliacs and the abdominal aorta. But puncture sites look okay, and we want to have a good hemodynamic result by placing a proper valve, have a good expansion of the valve, check the hemodynamics later, and of course try to avoid any disruption in the stent frame, which is located in the iliacs and the abdominal aorta. So what do we do? So this is the normal procedure that we do. We do light sedation and local anesthesia. We puncture the arteries with echo guidance, and we try to pace through the wire, which is located which is placed in the LV, to minimize any extra punctures and complications.
Here you can see the puncture of the right femoral artery, echo-guided as always, and
one of the discussions that we always have, it's when we deal with valve-in-valve procedures, is whether or not to do predilatations. Mostly we don't do, except if it's highly stenotic. And
so we see promising femoral access, no interfere at all with the stents in the abdominal and iliac arteries. And so we move on now. Here you can see the wire through the stents. We proceed to the prostyle implantation. Some heparin. And now we have to advance the pigtail 5 French to the aortic root from the right radial artery. Tortuosity, extreme tortuosity in the right subclavian artery. We advance second pigtail from the right femoral artery to advance the stiff wire. And then the sheath. Also, you can see the preparation of the valve. So we advance the sheath from the right femoral artery. And now we're ready to pass through the valve. With the AL catheter. So we managed to pass through the valve, and now we have the stiff wire inside the left ventricle.
So this is an Innovi wire, right? An Innovi, yeah.
This is a Safari.
Safari?
Safari small. So we proceed to the predilatation. And here you can see the balloon inside the valve. It's a SIPCA 18 to 40. Now you see the predilatation. Rapid pacing through the wire. And now it's time for the valve-in-valve implantation. The Algra valve. Let's see again. The opening, it's characteristic. Okay.
Of course, as always, you have to pay special attention to the markers. You have to align properly the valve in order to avoid any interaction with the coronaries and to facilitate easiness of cannulation later on.
We've implanted the valve. And now it's now for some measurements. No gradient here, no peak-to-peak gradient, as you can see here. So it's a successful implantation.
So there is a valve indication with this valve, very, very good hemodynamics. Professor Oldroyd will talk later on that.
And now is our post-procedural echo assessment. No regurgitation. And you can see that we have a max aortic velocity at about 2 or something like that. We recheck the valve. So the final result is this. We have a max aortic velocity at about 2.3, and the final result from the femoral arteries, the final angiogram, you can see here, nothing left behind. The next day, echo, no regurgitation, 2.3 velocity.
So good. So thank you, Liam. So it was a relatively easy, I would say, procedure with careful steps. Of course, we try to not to interfere with the EVAR stand. Might have very important sequences. So that's why we placed the sheath in order, the 18 French sheath, in order to be able to disengage and retract the valve and then reload it in case that we were not successful in the first place. But this is a kind of older, let's say, technology. Is the first iteration of the Algra device, and now we're lucky enough to, we're having Professor Oldroyd from Glasgow, who is online. And he will present new data and on the Algra system and the new Imperial delivery system. And he will present the results of the Empire 1 study. So, Professor Oldroyd, we are all ears.
Thank you so much, and apologies for the delay at the start. Had some issues with the time zone and the technology. Can you hear me clearly?
Yeah, definitely, very clearly.
Okay, I'll just share my screen. Can you see the slides?
Not yet, but now yes.
Great. Okay, well, thank you again for the opportunity to present this exciting data from the Empire 1 study. It's actually great that we've just seen a case using the PermaFlow delivery system, which was done very beautifully. And in the valve and valve setting, that delivery system works extremely well. Just before I go on to point out that I was the Chief Medical Officer for Biosensors for 4 years, but I'm back in clinical practice now. So you know the Algra valve, it's the shortest frame height of the self-expanding valves, nitinol frame, of course, bovine pericardium. It has this barrel-shaped stent frame, very, very good hemodynamics, as was demonstrated in the previous case. And as I'll show you, a very low incidence of prosthesis-patient mismatch. And a couple of features of the design are that it's very good for coronary access, and the overall package is very durable. Now, the delivery system that you saw in the previous case is the one that's on the screen now. This has the big advantage of allowing the valve to be implanted with no hemodynamic disturbance. There is no occlusive phase, but it has the major disadvantage that you cannot reposition the valve in situ. So if the valve is too deep or too high, you have to recapture the valve, take it out, and reload and start again. So to address this issue, a new delivery system was designed. This is it, the Imperia delivery system. It's resheathable, repositionable, and allows the valve to be fully retrievable in situ. It is used with the existing Algra valve, and it will be compatible with the next generation valve also. And the CE mark has just been awarded literally in the last day or so. And you're probably one of the first audiences to hear this news. So the implantation technique is different from the technique you've just seen. It's more akin to the technique you would use with an Evolut. We still have the gold markers on the valve. We position in the non-coronary cusp. Generally speaking, we're using cusp overlap. We, as you can see here, we open the inflow up to the gold markers, optimize the height, and then if we're happy, we pace, and we can open quite rapidly from this point on to a hard safety lock. So the delivery system has a safety mechanism that will prevent accidental release of the valve at 80% opening. The hemodynamics are usually very stable at this point. We can adjust the parallax using the gold markers to check for implant height, both on the non-coronary and the left coronary side. When we're happy, we unlock the safety lock and then slowly wind to release the T-bars. And then we have full detachment, as you can see on the far right-hand panel. If you need to resheath, you basically reverse the winding mechanism, and you can resheath from 80% to full closure, and then start again if you're not happy with the original position. So that's the device that was used in the Empire 1 study. It's still 18 French compatible. We still have the same 3 sizes of the valve. It's the same valve. So in the study, we did 121 patients with severe native aortic stenosis and a small subgroup of 16 patients for valve and valve, 11 sites in Spain, Germany, and the Netherlands. And everybody got an Algra valve implanted using the new Imperia delivery system. So this was the first in-man experience for every center who took part in the study. And in fact, some of these centers had no prior experience with the Algra valve at all. So it was a prospective non-inferiority single-arm multi-center study. The primary endpoint was derived from the almost identical study that Medtronic had to do for the CE mark for the original Evolut valve. So it was VARC2 device success at 7 days, which was the same primary endpoint as that study, and we derived a performance goal from the performance of the Evolut. So that's where we get our target device success rate. And of course, it's an independent Echo Core Lab Clinical Events Committee. The trial was run by cardiologists from the Netherlands. You can see the breakdown of the trial flow here. We actually only screened 176 patients to end up with 137 in the study, so we did not exclude a lot of patients. Each of the centers had to do 3 roll-in cases before they recruited into the intention to treat population, so we ended up with 30 roll-in patients, 91 patients in the intention to treat arm with native aortic stenosis, and the 16 valve cases. Here's a list of the investigators. Antonia Bath was the chief investigator from Vigo. Just a couple of highlights from the baseline characteristics. So the SDS score in the native patients was 4.1, so it's an intermediate risk population. But the valves were quite heavily calcified with a mean calcification burden of over 800 cubic millimeters. This is the very first case that was done in Vigo by Dr. Bath. Pre-dilatation as before. Pacing on the wire, as we just saw with the with a case from Athens. It's still a very flexible delivery system, just like the PermaFlow, so it goes around difficult arch anatomy without any difficulty. We're in a cusp overlap view here, and you have to bear in mind this is the first time that anybody had ever used this delivery system to implant the Algra in a human patient. So he's going quite slowly and quite carefully. We came to learn that you can go a little bit quicker than this. So slowly unsheathing the valve and checking the position up to the gold markers. And we're aiming for 2 or 3 millimeters in the below the base of the non-coronary cusp. So you can still see the gold markers separating, which does help you with commissural alignment. And that's a technique that obviously we can describe later. So when everybody's happy, we start rapid pacing, and then he opens up to the safety lock position. He actually goes fairly slowly here, but we discovered that you could go quicker as the trial went on. You can see it's very, very stable as it opens. There's no diving in. Implant depth in this case turned out to be excellent. Maybe 1 or 2 millimeters below the non-coronary cusp, so no need to reposition in this first in-human case. And so the valve was detached, again, quite slowly, just to allow the valve to orientate itself. But we don't really see any tilting as we detach the Algra with the Imperia delivery system. The inflow stays very stable. Sometimes a little bit of self-centering, but again, you can go a little bit faster than you see in this video, but this was the first ever experience, so the operators were being very, very careful. It's actually easier to get the T-bars off this delivery system than it is off the PermaFlow, because this is a titanium loading anchor rather than a plastic loading anchor, and the tolerances in the titanium are a little bit neater. So you can see the last T-bar is just about to come off now. There it goes, and that valve is now fully released, as you can see. And we have this very nice compression of the inflow with the outflow opening to increase the effective orifice area. So just a few comments on the valve itself. So in the native population, half the patients got a 27 valve, and the valve and valve, of course, more than 80% had a 23. Pre-dilatation was mandatory in the native arm, so that was 100%, and just over half the patients got post-dilatation. I mean, this has been commented on, but you'll know from the sad demise of the accurate neo valve how critical it is to do post-dilatation in self-expanding valves if you feel that the valve is under-expanded. Implantation was successful in every case except one patient who converted to a sapien, but that was without any valve embolization. So valve embolization was 0. We had one case where we had great difficulty getting a good stable position in Algra, so after 3 or 4 attempts, we switched to a balloon expandable. A resheathing was attempted in about half the patients, so we know the resheathing it works and it's safe. Coronary occlusion was 0, need for a second valve was 0. And of course, the data for the 16 valve and valves you can see there. There was actually more resheathing and repositioning with the valve and valve cases, but again, it was very safe. So did we reach our primary endpoint? So we had VARC2 device success. The performance goal was 78%. So think of that as an allowable failure rate of 22%. Non-inferiority margin or relative margin was 1.5. That gives you 11. So 78 minus 11 is 67. We actually got 91.6% with a lower confidence interval at 83. So 83 is, of course, well above this 67 mark. So we were able to declare non-inferiority with a very strong p-value of less than 0.001. The components of device success, so overall in the 121 native, so this is the 91 intention to treat and the 30 roll-in cases, the overall VARC2 device success was 93%, 87.5 for the valve-in-valve. There were 2 procedural mortalities, but neither of them was adjudicated to be device-related by the Clinical Events Committee. So absence of procedural mortality, 98.3% and 100% for valve-in-valve. Correct positioning of a single valve, 100%. And this is the really startling result. So that in terms of intended performance of the valve, 0 ppm in the native patients. So 121 native aortic stenosis patients, 0 ppm. And in fact, only 2 moderate ppms out of 16 in the valve-in-valve. Nobody with a mean gradient above 20, nobody with a peak velocity above 3. And in terms of moderate and severe PVL, we had 5.1% moderate or severe PVL in the natives, but they were all moderate. There were no severes. And of course, no PVL in the valve-in-valve. But this has been published in Structural Heart. And as I say, we are pleased to say that we've now just got the CE mark for this device. We have just reported the 1-year results at EuroPCR, again by Dr. Bath. I'll just briefly mention these. So this time we reported VARC3 device success at 30 days to bring it into line with the more contemporary VARC3 definitions. So VARC3 device success in the natives was 87.3, 100% in the valve-in-valves. Technical success, 94 and 100. Freedom from mortality was the same. Freedom from complications, very high, 95% in the natives, 100 in the valve-in-valves. Now, in terms of intended performance of the valve, what's happened between VARC2 and VARC3 is that patient prosthesis mismatch has been removed and replaced by a Doppler velocity integral. PPM has been moved into bioprosthetic valve dysfunction, which I'll show you in a moment. Also, we've now got less than moderate total AR, which combines both paravalvular and valvular AR. So again, for mean pressure gradient less than 20, it was 100%, peak velocity less than 3, 100%.
So, excuse me, Professor Aldrodi, we just lost your presentation. Maybe can you...
Recording stopped.
Oh. I heard a message saying the recording stopped.
Yes, I don't know. It's maybe a competing company of the satellite symposium. We'll see. So this is something that you might expect in a live event, even a hybrid one. So we don't hear you, Professor Aldroid. Yeah. Now we see. Okay, you can commence your presentation. Recommence, Professor.
Oh, you can hear me again?
Yeah, definitely. Loud and
clear. Right. Okay, right. Good. So I was just describing the VARC3 device success for Algra at 30 days. So you can see that although PPM has been replaced by DVI, for DVI greater than or equal to 0.25, it's still 100%. So actually it makes no material success. Even with VARC3, we still have very high device success at 30 days. So this is the echocardiographic core lab data at discharge 30 days and 1 year. You can see we've got an EOA of approximately 2 in the native patients, which is still approximately 2 at 1 year, so no evidence of any early structural valve deterioration.
Can you please make your presentation full screen, because we don't see the...
Sure.
Yeah. Better. Excellent. Good.
Yeah, sorry about that. So preservation of the EOAs over the first year, and if anything, a slight improvement in the overall pattern of PVL. So we've got, at 1 year compared to 30 days, we've got more none or trace. We've got less mild, and we've still got around about 5% moderate with no severe. This is the really interesting data now at 1 year, and this is bioprosthetic valve dysfunction and bioprosthetic valve failure. So you'll be familiar with these VARC3 concepts from the SMART trial that compared Evolut against Sapien. So for bioprosthetic valve dysfunction at 1 year, we only have 5.9%, so that's 5 patients in total. This is made up of 4 moderate PVLs, no severe PVLs, no moderate or severe PPM, and 1 possible valve thrombosis, which is counted here, although the Clinical Events Committee adjudicated that it wasn't a definite valve thrombosis. Because of that, we've got 0 hemodynamic valve deterioration at 1 year. So no stage 1, stage 2, or stage 3. And of course, we've got 0 clinical consequences, 0 bioprosthetic valve failure at 1 year. Now, of course, we need longer follow-up, but these are very, very impressive results with this valve. The pacemaker rate at 30 days was 14.3%, which is about the average for self-expanding valves. And there were no new pacemakers between 30 days and 1 year. So still 14.3% at 1 year. KCCQ looks very, very good. Big improvements at 30 days maintained out to 1 year and pretty well in keeping with the data from the SMART trial. And MYHA also dramatic improvements, even further improvements from 30 days to 1 year. Now, I just want to show you this slide, which is a comparison, a cross-study comparison of the Algra data from EMPERE-1 for patients with an annulus area less than 430 and the Evolut and the Sapien arms from the SMART trial. So you know the cutoff in SMART was annulus area less than 430. So we've taken the patients in the EMPERE-1 trial with an annulus area less than 430, approximately half the patients, and compared the data. And you can see these annulus areas are very comparable, 376, 381, and 383. The VARC3 device success rates in this cohort, 90.7 for EMPERE-1 with Algra, 94.5 with Evolut, 86.6 with Sapien. Moderate severe PPM, this is when the differences start to emerge, 0 for Algra, 11.2 for Evolut, and 35.3 with Sapien. Hemodynamic structural valve dysfunction, I've shown you that already, 0 for Algra, 3.5 with Evolut, and 32.8 with Sapien, driven by the higher gradients and the PPM. And overall bioprosthetic valve dysfunction, 3.6% in this cohort, so less than the 5.9 in the overall cohort, only 2 patients, 1 with a moderate PVR, 1 valve thrombosis, and then against 9.4 and 41.6 for Evolut and Sapien. Now, I appreciate these are cross-study comparisons, and this is not a randomized comparison, but it gives us confidence that Algra does offer something in addition to what you already get with the Evolut in the self-expanding space. So final slide, the 1 year results of EMPERE-1 confirm the safety and efficacy of the new inferior delivery system when used to implant the Algra valve. The excellent hemodynamic performance at 30 days was maintained at 1 year. We still have no native patients with moderate or severe PPM and no patients with bioprosthetic valve failure at 1 year. So thank you very much for your time, and congratulations on a fantastic meeting.
So thank you, Professor Aldroyd, for this excellent presentation. You presented, new data. It's a new, actually it's the same device, but implanted in maybe a different way, right? So it's, do you know, can you elaborate a little bit on the logic of why did they have to make this change, to get rid of the permafrost, which was supposedly one of the main advantages of the Algra system, and have the new iteration of the device to make it more friendly to self-expanding users, or?
Yes, I mean, basically the feedback on Algra since it was launched in 2017 is great valve, but we would prefer a delivery system that allowed the valve to be repositioned in situ. So I think MVT and biosensors made a very difficult decision in 2020 to redesign the delivery system, because as you say, there are some advantages to the permaflow system. But we think we've retained, obviously, the excellent hemodynamic performance of the valve and given operators the opportunity, if they need it, to reposition the valve. And in fact, what we saw in the study, and all of the cases were proctored by either myself or Anders Johnson, who took over from me as the Chief Medical Officer, what we found is very, very little hemodynamic derangement during deployment. So we've almost retained that feature, but given the operators the safety margin of being able to reposition the valve if it's too deep or too high.
Good. And of course, it's the same valve, the same hemodynamic characteristics, as you said. So, for people who are not knowledgeable on this device, which are the main future characteristics that that they constitute the advantage, the main advantage of this device as opposed to the other platforms? It's the pole movement. Maybe we don't know accurately. Maybe there's no big significance, but maybe on the long run or some other futures.
Sure, no, that's absolutely right. So the mechanical performance or the design of the frame is such that, as you know, there's very, very low leaflet stress. So we have high radial force in the inflow, but low radial force in the outflow. That allows the frame to move during each cardiac cycle and dissipate leaflet stress. And that should confer durability. Now we need much longer follow-up to prove this. But of course, excellent hemodynamics also confer durability. So the whole hypothesis, for instance, of patient prosthesis mismatch is that it will eventually lead to early structural valve deterioration. And this is the argument that's been laid out for clinicians by investigators in the SMART trial. The high ppm rate with the sapien will feed into structural valve deterioration. Now, we haven't seen that so far at 2 years in the SMART trial data presented in March, but let's wait and see how it goes at 3 or 4 or 5 years. But what we know now from EMPOWER-1, core lab adjudicated data, which confirms we knew before, the ppm rate with Algra is even lower than Evolut. And so, it's theoretically possible that Algra will have even greater durability down the line. Not to mention, of course, improved symptom relief, faster regression of LVH, and so on.
So is there a direct comparison between Evolut and Algra, like in one?
No. So that is in the planning stages at the moment, a randomized controlled trial between Algra and Evolut.
Yeah, and in the morning we had an excellent presentation by Roxana Meran, the president-elect of the American College of Cardiology, which presented the follow-up data of the SMART trial. You think this data can be, let's say, transmittable to, do they hold true for Algra as well, because it's a self-expanding platform, a supraannular self-expanding platform?
Well, I issue a health warning about cross-study comparisons. I showed you that slide. Looking at the patients in EMPOWER-1 that would have met the entry criteria for the SMART trial, and you can see that there's an incremental benefit for Algra even over Evolut. But of course, it's open to debate whether or not this will eventually lead to earlier bioprosthetic valve failure. We just don't know at the moment.
So yes, we will be open, of course, to the upcoming studies for that. So any comments from the audience? Greg, do you have experience with Algra? But you have. So we have together with us Dr. Pavlidis. He's under his guidance. The first TAVI was implanted in December 2007, right? So what's your take on the device? You don't use, but you use the other self-expanding valves, right?
The data look good. Actually, I have no experience with the Algra. It's not approved in the US, so I haven't used it. But the hemodynamics seems to be, excellent, and the low ppm rate is also of interest. So it's, other than, waiting to use it, perhaps I cannot really make any other comment.
Good. So, and of course, we have another session. We had another session today on coronary artery disease and aortic stenosis. So, how easy is to cannulate the Algra, the coronaries through the Algra cells, Professor Oldroyd? You think it's how meticulous should we be in aligning the valve?
Yeah. So, well, the gold markers can be used to assess implant depth because they mark the new valve plane. So you can tell whether you're above or below the coronary ostia using those gold markers. They can also be used to do commissural alignment, which of course is a critical factor for maintaining coronary access post-TAVI and also for optimizing hemodynamics and reducing leaflet thrombosis and so on. In the with a new delivery system, we have added, and I haven't shown you this, but we have added a marker on the loading anchor, a bit like the HAT marker on the Evolut, which will allow operators to do commissural alignment with the Imperial delivery system and the Algra valve. So we are still very, very confident that coronary access will be very easy after implantation of the Algra with the Imperial delivery system.
So this is a good point and very, very important, as times go by and, we try to treat younger patients. If there are no other comments, do you have a final say, Professor Oldroyd, before we wrap up this satellite symposium?
Yeah, well, just to reiterate the fact that we will be able to start doing cases with the Imperial delivery system soon. And the next development that will come along to address the residual 5% moderate PVL rate with the existing valve is a second generation valve with a unique anti-PVL mechanism. And we hope to be able to start testing that later this year.
So there are some surprises as well. So I didn't know that. So you have. So I suppose that there is an enhanced skirt, right? So
it's not a fully circumferential skirt. It's what's called a V skirt or a labyrinth seal. So we already have preliminary data on the first 60 patients that have been treated with this device, and it looks like it works extremely well.
Good. So hopefully we will see this device maybe in a protocol or in a study.
Yes.
In
I hope
Greece
so.
as well. Yes, and hopefully we'll see you here. So thank you for taking the time to talk to us about the new iteration of the Algra system. So thank you.
It's a pleasure.
So this was a nice presentation by Professor Oldroyd. So because we're a little bit back in time, and we will continue directly with the next session. It's on mitral valve interventions. Moderator will be Dr. Pavlidis and Dr. Kofidis. So we'll have more than experienced interventional cardiologist and cardiac surgeon, and Dr. Nignos is online. So I know it's late, early in the afternoon, but of course, feel free to have the lunch box or the coffee, and then we will enjoy the session.
Okay. Lassie, good afternoon. You're on again. It's me and Dr. Kofidis will be, just for this session. Just introducing your talk, I can say that you are one of the people in the country that has most of the experience for TMVR. So we're, eager to hear your primer tips and tricks when you apply the therapeutic method. Theo, any comments on your?
Well, I guess Dr. Niños needs no introduction. Hi, Vlasi, good to see you from this podium.
Hello to both of you.
So I represent the surgical side during this session, and we're equally interested to listen to Dr. Niños' presentation. So without much ado, Vlasi, you may proceed.
I hope you can hear me, see me, and look at my slides as well. So the first talk is to look into the tips and tricks of transcatheter mitral replacement. And one question, of course, is why do we need transcatheter mitral replacement? We're doing such a good job with TEER in the mitral space, or are we really doing it? If our target is to eliminate the MR, we clearly are not there yet. We're very efficient with the latest generation iteration of the two devices of TEER, both MitraClip and Pascal, and more devices are coming. But clearly, the option of having a replacement that potentially could offer a more standardized way to treat MR with somewhat less unpredictability and less operator dependence is very, very appealing. And, you know, we always have the TAVR as a paradigm to follow, and clearly, you know, it's what the industry wants and potentially will benefit our patient. But is it easy? Clearly, you know, we've done this with prosthetic mitral valves in place. This is one of our cases with severe stenosis. And the tip here is to have a very clear evaluation of the space in the LVOT and also some idea of the trajectory and the angle of attack going through the septum, because the preferable way here is to go transeptally and implant a balloon expandable valve into this previously implanted surgical valve. So quite reliably in this situation, we can measure the neo-LVOT, so by putting the new valve in there and pushing out the leaflets of the surgical valve, we create a cover stent. So effectively, the neo-LVOT that is left should be enough. And what is enough? Anything above 180, 200 ideally square millimeters would be enough, and here is 350. So it's quite easy in most of the situations to inflate a balloon expandable valve. This is a MIVAL with a fast pacing and have a very good result that can be assessed on the TEE and also hemodynamically. Of course, we can do that with valve in ring. There we need to assess the projected neo-LVOT, but also have an idea of the length of the anterior leaflet. Various lengths have been proposed, anything above 25 millimeters at the A2, but maybe lower, 23 or even 20. This particular case had a 20, and we elected to do a lampoon, so you can see the flying V on the left, lacerating the middle of the anterior leaflet, and then inflating valve in ring. And then you can see the result with the LVOT being widely open. And of course, we have the MAC, and the MAC is a problem for surgeons, is a problem for transcatheter, is a problem for TEER. And here is a very difficult case with a septal bulge and the elimination of the LVOT. The neo-LVOT here was 80 square millimeters. However, the skirt neo-LVOT, so the projected neo-LVOT space that would be left between the intraventricular septum and the skirt of the balloon expandable valve was adequate, was 185. So we elected in this case to perforate the anterior leaflet. This is a Batman case by using a steerable guide and the back end of an 035 electrified wire. You can see the electrification here. And by implanting inserting two wires and dilating with an Atlas 14 millimeter balloon, you can see how tough the leaflet is, perforating. We were then able to deploy a balloon expandable valve with a very good result and no LVOT obstruction. So always look at the LVOT, always look at the length of the anterior leaflet when we're talking about native, always assess the max circumference. But this is when we use balloon expandable prosthesis in the mitral space. This is a result of this patient, and this is the transthoracic echo on discharge. What about dedicated TMVR devices? It has been a long journey that started 2012 and failed badly, many $1 million later. And out of this first generation, only 3 devices are alive, and with several modifications. Actually, Tendyne is still alive, and About a year ago, we were talking that tendine would be dead because it's transapical and clearly the way is transfemoral. But actually, tendine is here and just completed the MAC arm. The enemies here again is LVOT, the presence of MAC, and also the size of the annulus. Also the angle, the approach, whether it's transfemoral or transapical, the size, and of course, clinical factors. These patients tend to be sicker than the TEER patients. But new kits are coming on the block, AltaValve, M3, Evoque, Cephia. You see the names. What is actually happening, and Summit trial has finished the MAC arm and had Tendine now has FDA only recently for the MAC, so actually still alive and still available, actually available in Europe, but also available in the US now. And the Encircle trial is ongoing, but the M3 now has got CE mark in Europe. And this is a device that has a docking system that is hydrophilic and wraps around the cords in the ventricle, creating the dock in order to inflate practically an S3 fully covered valve, the M3 valve. So it's like putting a valve in ring, but you have first to put the ring in there. But the Encircle trial has finished, and now we're waiting eagerly to look at the results of this trial. CE mark is obtained, however. And the Intrepid is alive, and now the Apollo EU and the Apollo US trial are ongoing with a new iteration 29 French system with a 54 millimeter. Actually, now more patients are being recruited as we had the refinement of these devices. The tips and tricks here are absolutely device dependent. So you have different tips and tricks if you go transapically, different if you go transfemorally, different requirements for the dock of the M3, different requirements for the Intrepid cohort. And we have AltaValve that I'm going to show you in the live case, which we started, what is the new iteration, the 29 French. This is out of the box device. This is atrially fixated, and you can see the tilt anteriorly, leaving a widely open LVOT. So for AltaValve, LVOT is not a big problem. The sizing here is mainly done on the annulus and the left atrium. So we're looking at left atrial height and width and also volumetric changes during the cardiac cycle in order to accommodate this device. But these three devices, Encircle, Intrepid, M3 finished, Intrepid, and AltaValve are currently in the pivotal state. So clearly we'll be looking out this space for this. InnoValve is a new kit on the block acquired by Edwards. Certainly a very interesting device. Of course, MAC and cords that are thickened are excluded, but patients with functional MR are probably an ideal target. And if you twist the cords, then you can deploy the flange and the device. So thus potentially remodeling the left ventricle. So different population to target on the InnoValve will see this space. So the tips clearly are device specific. It's a bigger intervention, bigger footprint device, greater disruption of the native anatomy, and afterload mismatch of the LVOs reality. So the main tip is actually manage the patients pre-procedurally, peri-procedurally, and post-procedurally is a big deal, is not the same as TEER, and preload considerations may be particularly important specific to the device. For example, AltaValve does not require big volume changes prior to the procedure because the LA may shift. And also always keep an eye on LVOT obstruction, may be not anatomical, but dynamic, particularly if the patient is dehydrated. Of course, another aspect that comes into play is the management of iatrogenic ASD. The flow can be left to right, bidirectional or right to left, and it'll have to be carefully evaluated for each patient. And last but not least are the anticoagulation concerns. We don't have them in TEER. Similar to TTVR, the bridging and the choice of pharmacological agents are very important. Thank you very much for your attention.
Thank you, Vlasi. That was a fast and very succinct review. Yeah, this is a very difficult field, and from the three valves that are currently still going on, which one do you think, I know it's a difficult question, but which one do you think has more potential?
I think ultimately it's going to be a toolbox approach. M3 clearly wraps around the cords, and in some subset of patients that may be beneficial, maybe some remodeling there. But again, LVOT is an issue, despite of gathering the anterior leaflet. Intrepid, for a long time, has been a lost cause, but perseverance and engineering refinement actually makes it a little bit more promising now. So I see now that the acceptance rate is up to 40% in the current iteration, whereas before it was less than 30%. AltaValve clearly has got the biggest potential when it comes to LVOT. In the EFS, about 70% of patients were eligible anatomically. But of course, we have the left atrial issues, like you have to have certain sizes. Too big left atria are excluded. And I would be looking out the space for InnoValve, particularly as LV remodeling is a possibility. That might be quite attractive for secondary MR with big LVs. We'll see.
Great, thank you.
I cannot give an answer, obviously.
Well, it's as good as it gets, your answer.
Vlasi, thank you for your great survey upon the incoming technology, and it's very, very timely for me. Since this is a conference reaching live cases, I'm going to have to ask you a question now. I was recently referred a 74-year-old lady, NIHA 3, allow me to say 3.5, eventually. And she's been sitting on a mitral valve stenosis with a semi-circumferential asymmetric calcium buildup on the posterior annulus mainly. Didn't want to be operated, now she wants to be operated. She's with the back against the wall. Problem is that she has a pulmonary hypertension recently measured on right heart cath, 110. While she was lying on the cath table, the systemic was 100. She did manage to finish her spirometry study. The FEV1 is around 45 to 50%. Right side remarkably contracts well. The ejection fraction is on the left side is 60-65, normal. And the family, very educated, they all push for solution. Number one, surgery with a calculated Euroscore yesterday of 36.5 on my computer, which underestimates the risk. Any other options from your side? Or eventually a hybrid procedure together?
Lovely case, huh?
This is what I get.
Well, if we exclude surgery, the options are balloon valvuloplasty, and other anecdotal cases with lithotripsy with shockwave balloons that they've been used to soften up the tips of the leaflets and use that as a bridge to something, either surgery by reducing the risk, reducing the pulmonary hypertension. Most of the dedicated devices are not used for mitral stenosis. I know AltaValve is now altering the protocol, incorporating in the pivotal trial moderate MS and moderate MR, but not isolated severe MS. And of course, you always have the option of a balloon expandable valve in there, but we have to see the distribution of MAGV, LVOT, all this that I discussed. Unfortunately, what I do see, because we also get patients like that, is the mitral stenosis currently is the Achilles heel of transcatheter intervention. For MR, you can do stuff, but for MS, it's kind of difficult. I don't know if Dr. Pavlidis or any other in the room has got a different opinion, but it's a definite solution when it comes to stenosis. I find it very difficult to provide.
Well, the current stenosis, which is mostly a calcified valve and an annulus, yeah, that's a major issue. It's very different animal from the old days rheumatic stenosis that could be treated by valvuloplasty. So you're correct. This is a difficult problem to solve. I don't have any solution either. We have three panelists. Dr. Lerakis is online, and Dr. Ninos and Dr. Dimitriadis in the room. Any comments? No, I don't see anything. No?
Well, it's nice. Thank you, Vlasi. I may as well send you some of the images and, share thoughts.
Let's discuss.
Yeah.
Thank you, Vlasis.
Right. Am I next with a live case, recorded live case, or not? Can you help me out?
Yes, you are.
So maybe I can share my screen again.
Go ahead.
So this is another presentation. This is a recorded live case. Actually, that was shown on CRT this year, and it's an opportunity to share this with you. So it's an Alta valve case in a box. This is the Alta valve, so it's a nitinol-based device. I briefly showed it before. There is a nitinol stent frame that gets opposed against the left atrial wall. The bottom part of the valve has got the annular ring, which is covered by PET fabric, and that is designed to mitigate PVL. It comes in 3 different sizes, 40, 46, and 54. And the valve itself is seated in the inside of the device, so it's a bovine pericardial 27 millimeter true size, 27 millimeter valve. This is delivered transeptally using a 29 French delivery system. So it's a single-stage procedure with 5 simple steps: transeptal puncture in an inferior-posterior position, like with any TMVR, balloon septostomy. Usually 8 or 10 millimeters is enough. The steerable guide is inserted, 29 French, and then the delivery system is inserted through the guide. The system is flexed down towards the valve and then deployed from the mitral annulus all the way to the roof of the left atrium. There is an internal catheter that you will see during the case, which we call the positioner. Is a 6 French catheter that is actually wrapped around the chimney with a snare and is reinforcing the posterolateral part of the valve in order to maintain stability and position during deployment. So this is our case, typically high-risk patient, 87 female, unsuitable for TEER because of leaflet calcification and also distribution of the prolapse. It's a DMR case, unsuitable surgery due to MAC as well as high risk. You can see some of the lab values. Patient had some renal impairment, but mostly was in heart failure and NYHA class 3 to 4 with NT-proBNP above 6,000. There is AF and a remote history of GI bleed, but nothing really. And she was able to do 195 meters of 6-minute walk. These are the medication, and she was approved to get into the Alta valve pivotal trial. She was actually number 2 patient, I think, that was enrolled into the pivotal trial. This is the right heart cath, 2.2 liters of cardiac index, moderate or borderline severe systolic pulmonary hypertension, 55, but everything driven by the left side, so PWP 28 with an excessive V wave. The echo, you can see there is a lot of MR, obviously, with prolapsing mechanism. You can see jets coming from the center and also the lateral part of the valve. So there was a prolapse of P2 and P1, and that's what made it quite complex for TEER. And that's why I recruited in the TMVR. Regards fraction was calculated as 100%. That shows the shortcomings of echo evaluation. The ejection fraction was about 46%. Some TR, but not severe. Interestingly, there was a jet that was directed towards the septum, and that made us think twice about the potential iatrogenic ASD. And this is the sizing, so the calcium distribution in the medial part of the valve. The MAC volume was 1,900 cubic millimeters, and actually that qualifies this for the MAC arm of the pivotal trial because by definition the quantity of the MAC qualifies the patient for that, and some other metrics in the left atrium and the left ventricle. So this patient qualified for the big valve, actually one of the biggest we put, so 54 at the level of the annulus, 85 by 90 millimeters the cage. So this is the procedure. So you can see the transeptal puncture was actually quite tough to get into the place. So we used an Agilis catheter and electrified a wire to go through in the exact spot because it was difficult to get it with the catheter. So with the transeptal system, you can see a Landerquist wire going all the way to the left upper pulmonary vein, balloon septostomy with a 10 millimeter balloon. And once this is in position, we get the steerable guide, which is 29 French that goes through the septum. It's actually quite easy to go through the septum. You can see the hemodynamics, both aorta and LV recorded at the same time in the bottom left, ECG and echo on the top left, fluoro on the top right. So now the delivery system is inserted inside the guide catheter, and the whole system is flexed down towards the mitral valve. You can see on fluoroscopy some calcification, which is a useful marker. On fluoro, of course, our guidance is the echo. You can see on the left, you can appreciate that there is also on the echo some disjunction of the posterior leaflet, so very complex anatomy. That's why we didn't do TEER. And now gradually we deploy the system from the LV to the LA. So we try to obtain a depth of about 10 to 15 millimeters below the level of the annulus as measured on the echo, mainly on the posterior and the lateral side. So you can see on the left, the echo is posing to get in systole an assessment of the depth, which is if it's about 10 to 15 millimeters, it's okay. Usually the patient remains hemodynamically stable throughout the procedure. Now you can see the annular ring is being deployed, which is like a bulb here. It's a 54 annular ring. Once this is deployed, we push the system laterally to get some engagement against the lateral wall. That gives additional stability. And then we go backwards to deploy the left atrial cage. Once we are at a certain height, we can loosen the internal snare. You can see perhaps that there is this internal catheter. By loosening, we open up the valve, and now the valve is fully functional, and that will help to maintain hemodynamic stability. And once we have this engagement, then the next task will be to deploy the left atrial cage against the left atrial wall, trying to be reasonably fast. And sometimes we pace to get some bit to bit to eliminate. But as you saw here, there was a pop out. So the valve slipped and went all the way up to the free wall of the left atrium. That sometimes is to be expected. If we can avoid it, we try to avoid it, but it can happen. The valve is designed to account for that. So we can resheath the atrial cage. We can go all the way to the chimney tips, to the tips of the internal valve here, and we can re-snare the internal catheter to reduce the profile of the valve. And once we do that, we will be able, as you can see here, to reflex the system right now. So we reduce the profile, and now we can go down again to the mitral valve by flexing down and monitoring on the echo. And then we can deploy a little bit deeper and trying to also improve our lateral engagement against the lateral part of the mitral annulus. This time we move a little bit faster and we pace at 110 beats per minute. You can see now that by pacing we eliminate bit-to-bit variation and perhaps reduce the stroke volume. Blood pressure is borderline, but it's okay. And then we just very quickly deploy by pushing in the left atrial cage. You can see that now. And this is real time, so we can go back really fast and push the insertion point. You will be able to see the insertion point now. It's being pushed against the rooftop of the left atrium, and then we open up the internal snare by opening the valve, and this is the valve now fully functional. We're able to evaluate the hemodynamics, evaluate the position of the valve, look at the color, and once we're happy, then we're able to remove the internal catheter here, and we will be able in a minute to deploy the valve right now. So the valve is now deployed. You can see that there was some left to right flow, but also some bidirectional flow. We were a little bit concerned about it, so we elected in this particular case to close the ASD. So you will see now a cardioform 25 millimeter occluder to be inserted to the left atrium. It's actually very easy to close the defect because you've got a very clear fluoroscopy marker, which is the cage against the left atrial septum. So now you will be able to see in a minute the disc deployed in the left atrium there and then pulled down towards the septum, and now the right atrial disc is deployed. You can see that on echo. So the ASD was closed. So device time was 27 minutes, despite the fact that we had to resheath and redeploy. Patient actually did very well, discharged on day 4. And I have to show you the 6-month follow-up. Actually, patient is now almost getting to a year of follow-up, I think, or maybe 9 months. But this is how the valve looks on echo. You can see that there is no PVL, there is nice diastolic flow. Here it is on the long axis view. You can see widely open LVOT, some AR, but no PVL, which is very, very important. So in summary, the AltaValve was deployed as a single stage, low profile 29 French delivery system, conforms to the shape of the LA and MAC. Despite of the MAC, there was no PVL, and actually preserves the LVOT, which is the key message for this valve. The patient that you saw was part of the Atlas pivotal trial that commenced both in US and Europe. We're happy to be part of the leadership of the trial, along with Yoshi, Kaneko, Paul Soraja, Leonard Conradi, Vinny Buppet, and of course, the study chair, Ron Waxman. And we did 4 patients in Inter-Balkan, and the first 2 patients done in MHI, Minneapolis Health Institute, and I know more centers are now being activated in US and Europe. So thank you very much for your attention, and happy to answer questions.
Any questions from the audience? Dr. Iacobu.
Vlasi, thank you for this presentation. Excellent as always. So, can you elaborate on the issues that came up lately with the AltaValve with the larger sizes? It's something you think it's something to worry about, or it's?
So what happened? There was a subset of cases that had some strut fractures. We had one patient that we had to deal by putting valve in valve. Patient is doing very well, and there was another patient also in the US. I can't remember which center, but I think a total of 5 patients, if I'm accurately informed about it. All patients are doing well. In some of these patients, there was PVL. In our patient, there was significant PVL. That's why we had to do a valve in valve. So we inserted, we went through the septum, through the cage, and we inflated the valve inside the chimney by bridging the gap between the chimney and the annular ring, eliminating the leak. So the leak was coming through the chimney, through the inner valve and the frame. So this has been already reviewed by the engineers of the company, and they realized that the issue was related to the internal catheter. That's why I made a particular discussion about it, and the snare that wraps it around the chimney. So it was felt that during the crimping process, there was excessive force at the base of the chimney, and that created these fractures. So now there is a process that already finished for the 46 millimeter valves and soon for the 54 millimeter valves, that the process of loading has been altered. Bench testing is already completed and submitted to FDA. And very soon the 46, I think in the next couple of weeks, will be released again. We never had any issues with the 40 millimeters. So hopefully once this is done for the 54, we'll be back on track again. It's one of the issues. I mean, that's why TMVR is very, very difficult. I mean, you have big devices, difficult loading conditions. I am aware that other companies face similar struggles, but I think if there is an honest dealing with that and engineering root cause analysis, it can be overcome and we can move on.
There's one more question from the audience, quickly.
That's a very nice presentation, a nice case. Just a question about the long-term outcome, especially in focus of endocarditis. Do you have cases with endocarditis, and what do you think will be the impact of all these cases in case of endocarditis?
Well, it's a very good question. We haven't had a case of endocarditis ourselves. I'm not aware of any case of about 120 valves have been implanted so far, so I'm not aware of any case, but I guess it's not science fiction. Endocarditis may happen as it happens for TAVI. Clearly, removing this valve from the surgical perspective, I mean, Professor Kofidis will know that better.
might be a little bit cumbersome by having to disengage the cage from the left atrial wall. Having said that, we had one case that had to be removed, and it was done by our surgeon endoscopically, and patient actually is doing very well. The valve was removed, I think, after 4.5 months, so it was feasible. Long-term outcomes, there are from the transapical cohort, because this valve started transapically and then moved in septally, transfemorally, that are up to 4 years out. And there are no issues with the integrity of the leaflets and the hemodynamic performance on the valve to the patients that are making it. We have patients that already are 2.5 years out, and they are doing well.
Leslie, any comment about anticoagulation? I assume they're on warfarin.
So we start them on warfarin mandatory for 6 months, and then we switch to NOACs or whatever the patients were taking before. Actually, most people are scared about anticoagulation when they look into all this metal in the left atrium, but really the anticoagulation is for the leaflets as for any other bioprosthesis, because the cage is nitinol, and we're familiar with nitinol with the ASD PFO devices is not really thrombogenic, but nevertheless 6 months of warfarin and then followed by NOAC is what we normally do. Most of these patients are in atrial fibrillation anyway.
Well, any other comments? No. Thank you very much, Vlasis. This was
Thank you.
An excellent
Pleasure.
presentation, both for this valve and the whole TMVR. Our next lecture is actually pre-recorded, and I think it is a privilege to have Dr. Maizano address the issue of the optimal treatment for mitral valve disease patients, especially for the transcatheter methods that we are using. So we're ready if we are.
Gentlemen, I apologize I cannot be with you. Anyhow, this is my short summary on how to choose the optimal treatment for our patients with mitral valve disease. These are my conflicts of interest. And I will tell you a story which is based on real events, but more importantly, a story which is ending with more confusion than you can imagine. I'm more confused than convinced about anything that I'm going to tell you. You know, there has been a revolution in the last few years with new interventions, new operators, new structures, and this has been inducing a new mindset, but also a lot of new evidence, which is creating some confusion in our mind for the plethora of different options we have. I can actually improvise and impress you with complex procedures like multiple clips in a single patient with Barlow's disease. I can show you some Batman procedures where actually we are able to electrify wires and to basically ablate the mitral valve in order to avoid LVOT obstruction in valve ring or valve-in-valve procedures. This is a case where we were able to do this in a valve-in-ring procedure with a high risk of LVOT obstruction. And this is the end result of this procedure, which is one of the most complex procedures in our practice today, but is very efficient in reducing the risk of these procedures. But I want to make it a bit easier and go down with the technology center of such a review and start with the concept that today almost everything is possible. If you have the right tools and the right imaging, almost nothing is impossible. But is there a limit to what we can and what we should do? Well, I have a privilege to be able to perform procedures as a surgeon, as an interventionalist, and therefore I have a little bit different point of view than many of my colleagues. And I have also on one side a conflict within myself for each patient that I have to treat. And the conflict is because I'm not sure what is the best treatment for every patient. How do we choose between the different options? Well, there are several steps. And again, both procedures are fantastic. What is better for our patient? Well, I think I have 3 steps. All of them are very important. The first one is clinical, which means we choose procedures according to the evidence, according to risk-benefit, according to the durability of our potential procedure, and the effect over the lifetime of the index procedure that we are going to perform. Obviously, there is also a technical element because not all procedures are feasible, and in general, we try to choose the simpler one, the one more predictable, the one less invasive. But above all, in my daily practice and as a solution for the uncertainty, emotional factors are really leading my final decision, which I usually take together with the patient. You need to take the patient perspective. You need to become compassionate or emotional with your patients. In order to get the decision together with your patient, you need to be able to deliver an unbiased and totally transparent information, sharing also all your doubts, all the gray zone that we know. And after this process, you feel released if you have doubts in your mind. There are obviously advantages and disadvantages in many different conditions. Sorry, I go back one slide, where every procedure have advantages and disadvantages, and we need to find a good balance which works for each patient. Guidelines may be useful to help us in the decision making. However, guidelines are made for average decisions. The population we treat is not made of black or whites, it's a variety of colors. And the real world really needs a tailored approach for all our patients, which means that we need really to adapt to anatomy, the phenotype of the patient, but also to the lifestyle of patients and to their hopes, to their objectives in life. The degenerative MR is it's a condition that has a number of different options. You see them all here in this slide, but in principle, it is mainly a surgical disease. Complex anatomies in younger patients are best treated with a totally endoscopic approach, which is today standard practice in most of our hospitals. On the other hand, if you have at the other end of the spectrum, single lesions in elderly patients become, in my practice, a good indication for endovascular procedures. This is a very typical patient, is an operable patient, 80-year-old with a relatively low Euro score, but with a very good anatomy for a TEER. Well, this patient will undergo, in my practice, almost in all cases will undergo, sorry, I have to go back, will undergo a TEER procedure. However, the TEER procedure in this particular patient, I want to have a surgical-like outcome where cure is achievable if there is a single leaflet segment. What is a surgical-like outcome? No regurgitation, no stenosis, no residual motion abnormalities, just like you see here in this outcome you see on the right side here. Being able to perform transcatheter procedures bring me many patients who are asking for a transcatheter procedure. 57-year-old patient, active entrepreneur who doesn't want to miss one single day in his own practice, comes to me with a lesion which is absolutely impossible to be treated with the TEER. It's a very large flail, resulting potentially in a stenotic procedure lesion. This patient, I was able to convince him that surgery would have been a much better choice, and he underwent an endoscopic procedure with chordal repair, and he was very happy at the end of it. There are also conditions where minimal invasive is not the best solution. We see many patients with severely calcified annuli. These patients, particularly in the younger age, they become surgical candidates again, where we can do a profound decalcification and the restoration of the regular anatomy in many of these cases. Usually we do these cases in sternotomy, although in some cases we've been able to do it also, like in this particular case, in an endoscopic fashion. But this obviously requires a lot of expertise and a lot of patience to be able to perform a decalcification in a young patient in an endoscopic approach. But let me go back to transcatheter procedures, which are actually bringing something that surgery don't have. In surgery, we observe very well the anatomy, but unfortunately, we don't see the function of the valve. We work with the valve which is not functioning. While valve function is always in front of us, we can do Doppler and see real-time MR reduction for any procedure we perform. So in this case, I think this is really the reason why for functional MR, transcatheter procedures are very important. Functional MR was initially not the center stage for procedures in the Everest trial. Very few patients were treated by TEER with functional MR. The majority of TEER procedures in the Everest were done in degenerative ones. But once the procedure became available in Europe, the majority of patients treated in Europe in the beginning of our practice was functional MR. This is the results from the Access Europe, where 77% of patients were functional MR as compared to 23% of patients with DMR. The coapt and mitral FR have been creating a bit of chaos in our community, showing different phenotypes and different levels of indication. We know what are the coapt-like phenotype, which is a patient with not too much dilated ventricle and some preserved contractile function, no right ventricular dysfunction, no acute syndromes, and severe MR. This is a subset of patients with predicts for better outcomes, and so today most people believe that coapt is the way to select patients. On the other hand, a trial which has been highly recruited in Greece showed with SHAPE 2 that even patients with less than severe MR may benefit from this procedure, both in terms of freedom from rehospitalization and improvement of quality of life. Still, the debate is open. There are many subphenotypes of functional MR, and so we need to be ready to be, again, able to optimize our therapeutic offer to the subcategory of patients we are treating. And we talk about phenotypes. There are many evolving indications for these procedures, particularly the acute indications are very important. We use this procedure in patients with SAM and hypertrophic cardiomyopathy. This is a case with, you can see a hypertrophic cardiomyopathy with mainly a problem of SAM with obstruction of the LVOT. We also use this in failed mitral valve regurgitation, mitral valve repair cases. It's a very useful and common indication in our practice. In patients where we are able to implant the clip, usually we have an excellent, good result at the end with double orifice end ring, which is a really surgical-like repair, aiming for long durability. We have been using now this procedure in congenital patients. I have a series of Fontan physiology patients, which are requiring multi-professionality around the table. I'm working with pediatric cardiologists to understand physiology and anatomy in very complex patients. And in these patients, we really can obtain good results and improvement of quality of life. An important application is the acute mitral regurgitation, both in patients with ruptured papillary muscle and in patients with acute ischemic MR without mechanical ruptures. This procedure may stabilize the patients with very minimal impact in the risk. Obviously, not all patients are candidates for repair. Replacement is going to be an alternative. There are many devices at the moment. Replacement obviously is very important. Again, what is the best option? We don't know. Again, anything is possible. How to choose in between all different modalities? Well, first of all, remember there are many options we have around the table, and adapt the option to our patients, not the opposite. The patient should not be adapted to what we can offer. There is a value in choosing surgery versus structural interventions in some patients where you can achieve best anatomical outcomes and full service. On the other hand, the structural intervention allow a culprit lesion approach with a stepwise approach, which sometimes will offer a lower risk profile as compared to surgery. There are different options, different targets of therapy. What is fundamental is that we work as a team. Valve centers and valve networks of care are very important. Understanding the issue of lifetime management in our patients, understanding what we do in the cath lab or in the operating room is only one step of the procedure, one step of the management, and a team approach is fundamental to obtain the maximum from these patients. Thank you very much for your attention.
Dr. Maezano, convincing as always, embodies the heart team. He could be a heart team on his own. It is very important to understand, if I'm allowed to offer a few comments, that as coronary artery disease, so too mitral valve disease, it's not black and white anymore. And with evolving technology, we now have a whole quiver in our armamentarium, many solutions, which, as Dr. Maezano, and I think that was the essence of his presentation, which we can choose from. Hence, this is also the way we approach it at the Yale Hospital, I guess at Onassis Heart Center, is we relay to the patient all the possible options so he can make the best choice with plus and minuses. It's not anymore just median stenotomy or a catheter solution. There are endoscopic, minimal invasive procedures that can be offered to reduce the trauma, eventually the burden to the patient. I think we are living in amazing times, very promising times in terms of personalizing, individualizing the solution, where I think we should work together as Greeks in our country is to improve communication between ourselves and quality control, quality assurance, maybe perhaps set up a database so we can follow up on these patients after the treatment they received. Because I keep wondering why some countries can establish perfectly transparent heart teams and others don't. Germany, for example, usually there is a very good communication and cooperation between chief cardiologists and chief heart surgeons, and they tend to be role models of collaboration and functional heart teams. And I wish that we could establish it in Greece as well, according to the example and mantra that Dr. Maezano shared with us, and I think we're on a good path. Perhaps Dr. Pavlidis can share some thoughts on that.
Yeah, I think that's very appropriate as an analysis, and I would add that what we need probably in Greece is our surgeons. I mean, my co-chair is excluded, of course, because he is already doing it, but I think that in most of the hospitals, our surgeons are not really familiar with the transcatheter techniques. And even when they are engaged into the heart team, they only think about surgery and they cannot really appreciate that there is a spectrum that, maybe a combined approach or one or the other can be. In our heart team at the University of Nebraska, for example, the champion in the TEER is our chief surgeon, Dr. Moulton. And he really wants to do that. I mean, he is almost, as a surgeon, able to do it by himself, a percutaneous technique. So we know that, between us and them, we can understand the different options, as Dr. Kofidi said, and this is really not black and white. And I think we're going to need more of this combined approach and shared experience. Like, we appreciate the surgical techniques, we probably more, but the surgeons do the same for the transcatheter technique. So we can really offer the best option for our patients in a field that is changing all the time. It's really just moving very fast. Dr. Iacovo.
I definitely agree with both of you. Of course, yes, and we learn a lot from surgeons as interventional cardiologists. And actually, most of the things that the interventional cardiologists do in the structural work is trying to replicate some of the procedures of the surgeons did. For instance, the TTVR is like the Alfieri stitch with no ring. So yes, I suppose that this is the way to do. So in our center, the last few years, we are doing a weekly basis, a heart team. We try to implicate, most of the time successors, but not always, the surgeons. And of course, some of the surgeons are reluctant to do. Sometimes we will speak on different, let's say, levels. But at the end of the day, this is a progress. And the thing is that at some point, I think we will talk to each other, in the same level, and because the most important thing is to treat, in the best way possible the patient. This is no different.
And it's not only the meetings of the heart team. I would say that, what we have achieved, for example, in the University, again, of Nebraska, is that we have a specialized valvular clinic where we both see the same patient with a valvular disease. It's the cardiologist and the cardiac surgeon at the same session, so they get the same answers. Now, this might not be feasible in a private practice setting or anything, but it underlines the importance of the common and cooperating approach to the patient. I know that Dr. Lerakis is online, so before we introduce him for the next online lecture, I would like to get his comments actually on the topic that we are talking. Stamatis.
Yes.
Good to see you.
Kalimera από τη Νέα Υόρκη, Professor Pavlidis, Professor Kofidis. Great to see you and great discussion. And I think, as you will see, actually I had that in my last slide of my presentation. This is an important topic, and as you know, many people are involved in these decisions, and it has to be like a heart team, as you know, that includes a surgeon who is also, who knows about transcatheter therapies, because otherwise we will not be able to make a decision, which technique to use. So it's very important for the surgeon, of course, to not be biased and to know all the available procedures that are available to take care of a patient. And of course, you need the imagers, you need the interventional cardiologist. So it's a team, and here where I am, the team, is working very well. And of course, sometimes there is tension, between surgeons, interventional cardiologists, but always we try to do the best we can for the patient. So I think having a surgeon open-minded, I think is critical, who knows, of course, of the devices, because, as you know, the devices that are developing now are, it's each one of those is, is very different. So knowing the in and outs of each device, when to use it, and of course experience is critical for the success of structural imaging, structural programs in the US, in Europe, and of course in Greece as well. So working together is the is the most important thing, I think, and be open-minded.
Thank you, Stamatis. Well, with this comment, we will proceed with Dr. Lerakis' lecture. He's a professor of cardiology at Mount Sinai School of Medicine in New York, and he's going to give us a talk about the anatomy and the imaging in TMVR procedures. He is very experienced, of course, in all structural heart disease and especially in the imaging. Professor Lerakis,
Ευχαριστώ πολύ, Grigori, Professor Pavlidis, Professor Kofidis. It's an honor, and Professor Iakovou is an honor to be part of this great conference. And in the next few minutes, I will try to show you, to talk to you about imaging, mostly, of course, for the mitral valve, is the topic today. And we have many imaging modalities. Echo, of course, is the most important for diagnosis and the planning of the procedure. CMR is important for and the gold standard for measuring volumes. And of course, today, CT for planning is very critical. And CT in the last few years, because of the advanced techniques that offers, it's the most critical for planning of basically all the structural interventions. So echo, as I told you, is especially for the mitral valve, is very important to separate and distinguish if it's a primary versus functional MR, the severity of the disease, and of course to plan the procedure. And I know we talk, a lot about mitral valve because, and as we know, and especially the surgeons know, the valve is very complex. So it's very complex and difficult to find the device. And that's why we have a lot of devices developing almost every day that try to treat mitral valve disease with transcatheter therapies because the mitral valve is a very complex structure that not only includes the valve itself, but also the muscle, the LV, which is very important to take into account when you treat mitral valve disease. And as I tell to our fellows, there is no way to do a mitral valve transcatheter therapy without to be able to cross the septum and the intra-atrial septum. And today we are lucky to have advanced techniques with echo, and especially the 3D and the X-plane, as you can see here, where you can see the intra-atrial septum and decide, especially for each procedure, like the mitral clip procedure, the height and all the things that you have to take care in order to be able to do the procedure safely and effectively. And as you can see here, I'm moving, this is the superior vena cava for the fellows, the inferior vena cava. This is the bicaval view. Basically, to treat mitral valve, you need two views by echo. Bicaval view, which is this view in order to do the transeptal puncture, and the other image that I will show you, which is the bicommissural view in order to perform the procedure, the transcatheter procedure. So this is the superior vena cava, inferior vena cava, and on the 90 degrees image, this is the aorta, so this is the anterior part of the septum, and this is the posterior part of the septum. So very important to know these landmarks in order to prevent of having a problem when you try to cross over and cause perforation of the wall or the aorta. So this is very critical. And of course, always the imagers, sometimes the interventional cardiologists and the surgeons don't appreciate very much, but imaging is very critical for, especially for the mitral valve and tricuspid valve, which is not the talk of today. But as you can see, always we are the eyes of the procedure. As you can see, this patient developed a clot, a thrombus on the catheter, on the transeptal catheter, and of course you have to detect this, tell the interventional cardiologist in order to exchange the catheter and prevent of going to the left side with the thrombus and cause a stroke to the patient. So we'll talk today, part of my talk will be the mitral clip, the mitral transcatheter edge-to-edge repair. And as we know, this procedure for a primary MR is, of course, the therapy is surgery, but for high or prohibitive surgical risk with favorable anatomy, it's a 2A indication by the American guidelines and 2B by the European guidelines. And of course, for patients with secondary MR who meet the COAPT criteria, it's for both the European and European and the American guidelines 2A indication to perform this procedure. So this is a case of a primary mitral regurgitation on a patient with FLEL posterior leaflet. As you can see, the calcium under the leaflet. This was a high-risk patient, wide open mitral regurgitation, and the important things that we take into account when we do this procedure is to measure the length of the leaflets in order to decide if we use which clip we use. You need to have even for the smaller clip at least 7 millimeters of leaflet. Most of the time the problem is the posterior leaflet, but you need at least 7 millimeters for the smaller clip and 9 millimeters for the posterior clip. That will make it possible to prevent dislodgement of the device. And also, I should make the point that you have to take into account the healthy part of the leaflet. Any calcium on the leaflet is an unhealthy part. You don't take into account for the measurement because, as you know, if you put a clip on the calcium, you can there's a risk of dislodgement. And the other thing we do is we measure. Today we have with MPRs on the 3D imaging, we have ways to measure the mitral valve area. And you want to make sure that by putting a clip, you will not develop mitral stenosis. Try to treat the MR with mitral stenosis. And what is suggested is for the mitral valve area to be more than 4, preferably more than 4.5 centimeters square in order to put a clip and don't have a mitral stenosis. Also, another important thing is to measure the gradient through the mitral valve. And because you have to know where you start. Sometimes the gradient in the beginning, you should know that may be high because of the high flow from the mitral regurgitation. So everything has to be taken into account. This is a secondary mitral regurgitation. And again, as I tell people, when we did in my previous job in Emory, the first mitral clip took us 5 hours with Pierre Bloch, the interventional cardiologist. It took us 5 hours because we had only 2D, no 3D. Today we are blessed to have 3D imaging. As you can see here, this is the X-plane, and you go across the mitral apparatus. This is the bicommissural view. As I told you, 2 views, bicaval view for the transeptal puncture, bicommissural view for the mitral clip or any other transcatheter intervention on the mitral valve. And here you have the lateral part, which is with the left lateral appendage, and this is the medial part of the mitral apparatus with the aortic valve, the anterior leaflet, the anterior part of the mitral apparatus, and the across is the posterior mitral apparatus. So you have the whole mitral apparatus in front of your eyes. You change the X-plane from one side to another in order to determine where the mitral regurgitation is coming from. And sometimes you have more than one jet, so you have to find all these jets. And at that time, and the place where the jet is, you go and measure the length of the leaflets and to make sure that you have enough length of healthy leaflet in order to do the mitral clip or Pascal device. We use here, we are mostly a mitral clip device. Other places use Pascal. We have used few Pascal devices here, but we are primarily a mitral clip site. As you can see again here, you are now another case. You are in the lateral part, as I told you. You are close to the left lateral appendage, and you have the jet of the mitral regurgitation. You freeze, and you see that the posterior leaflet here, you measure it, is almost is like 9 millimeters. So that's just to give you the what we do and how we do it here for planning, but also during the procedure. And of course, today again we are blessed by having great technology. This is Zoom, 3D live Zoom. This is what the surgeon sees when he opens the atrium, and you have the aorta on the top, 12 o'clock, and you have on your left the left lateral appendage. This is the lateral part of the apparatus, as I told you. The opposite is the medial part. From the lateral part, you have the anterior leaflet, A1 scallop, P1, A2, P2 in the middle, and A3, P3 on the medial. And you see this valve is wide open, secondary mitral regurgitation. This jet is wide, and you know that you will use more than one clip in order to take care of this. Another thing that we take into account is we see the pulmonary veins, because always you have to see to get more objective evidence before the procedure, but also after the procedure. This is the left upper pulmonary vein, and this you can see the flow is normal. This is the systolic, this is diastolic, this is the A wave, but also you have to see all the pulmonary veins. This is the right upper pulmonary vein. From the bicaval view, you clack a little bit the probe and you bring in the right upper pulmonary vein. And as you can see, you have systolic reversal, which signifies severe mitral regurgitation. And this is the diastolic, and this is the A wave. And you want to compare this with after the clip or after the procedure that you do to get more objective evidence that you have a successful procedure. Another technique that not technique, but another modality we use is the fusion imaging. We have this available in our cath lab. Of course, the surgeons and the interventional cardiologists, they are not very patient using this modality, but we have it, and it's very helpful, especially for the transseptal puncture. And as Professor Kofidis said, it's very important to talk the same language. So if you have a way to have the same image what you have on the echo screen on the fluoro, you can make it easy. The communication is very critical for this procedure. So having this fusion imaging make it easier to communicate between the imagers and the interventional and surgeons who do the procedure. So this is an actual procedure crossing over from the right to the left, as you can see here. This is the guiding catheter. Very important imaging, very important in order to prevent complications. This is the clip, as you can see here. Try to guide the position of the clip, and this is the clip coming into the mitral apparatus in the atrium. Very important technology. I remember this that I thought about this many years when I was in Emory and we're doing this procedure. Today the clip has an independent grasping ability, which is very critical, especially for difficult anatomies. As you can see here, you make sure that the clip, you should know which is the anterior and which is the posterior gripper. And as you can see here, this is the anterior gripper with the anterior mitral leaflet, and this here in the bottom is the posterior. So you have to know which is what, and having this ability to be able to grasp independently is very, very important and has made this procedure much, much easier. Then you have to make sure that the clip is perpendicular to the commissure of the mitral valve. Very important step, because if this is not perpendicular but oblique, and you try to grasp that way, first of all, you have a difficult grasp, and second, you may disturb the anatomy of the mitral apparatus, and actually sometimes cause more mitral regurgitation than what you start. So very important steps each way, and this is still being on the atrial level before you go down into the ventricle, and you want to make sure that you are on the clip. Now the clip is into the ventricle, and again the same thing, because sometimes if you have a lot of cords, the clip can change position by going from the atrial level to the mitral level to the ventricular position. So we check always again with 3D imaging to make sure that it maintains its position. And here you have to decrease the 3D gain in order to see the clip into the ventricle and to make sure that the position remains perpendicular. Otherwise, you have to clock or counter-clock, depends on the position, to bring it again perpendicular to the mitral apparatus. Then you open the clip. These are, of course, easy steps. And as you can see here, you have the leaflets onto the clip, and you get the feeling that in this case, the posterior leaflet will be a little bit problematic to grasp it. And by having this independent grasping ability, you can grasp the anterior and then move it to posterior, scoop it under the leaflet, and then grasp the posterior leaflet as well. And I hope these things play here. Okay, so this is, sorry for that. Let's see if bring this up. Yeah, I don't know. Sorry for this. Anyway, so this is, in this case, we use two clips. And as you can see, this is the delivery device, very dangerous, actually. And I don't know why the company has it like this. And very important to guide it and come out of the left atrium into the right atrium, and then out of the guiding catheter. Of course, we measure the gradients, as you know, and we don't want to have a gradient more than 4 to 5 at most. And we know the difference that doesn't play too much role for the functional MR, and that's because most of the time the orifice of the mitral valve in the functional MR is large. It plays more role if it's more than 5 in the degenerative MR. But by knowing where you start and also by knowing the valve area, also that can help prevent basically having mitral stenosis instead of mitral regurgitation. And of course, as I told you before, we evaluate to get more objective evidence the pulmonary veins, as you can see here, with normalized flow. After the 2 clips in this patient, as you remember, the right upper pulmonary vein, there was a reversal, and now the flow is normal. So this tells you that you are not like hallucinating by don't see much MR, but the procedure was successful, and hopefully the patient will feel better. This is a FLEL posterior leaflet with severe mitral regurgitation, primary MR, and this is how the very easy today. In the past, with 2D, we try to see what angle you are, to see if you are in A2 scallop, A3 scallop, P1, P2, 3D live 3D imaging, and you can see the FLEL P2 scallop on this anatomy. And this is after, this was a Barlow's mitral valve, and after 2 clips, as you can see, minimal mitral regurgitation. And here by the fusion imaging, there is no color. So moving on to transcatheter mitral valve replacement. Do I have a little bit time, Professor Pavlidis?
Yes, please go ahead. We still have.
So as you can see here, many devices, and when you see many devices, you know already that there is difficulty in trying to treat this disease. And I have been part of many of these devices, especially when I was in my time in Emory. But again, for the fellows, 2 views by cable view for the transeptal puncture, because you have to be able to go to the left side unless you do the transapical approach, and I will show you a case of that. And also the bicommissural view, which you need regardless what you do, a transapical or a transeptal, you need the bicommissural view in order to deploy the valve. And the complexity is because of the saddle shape and anatomy of the mitral annulus, to anchor and seal of the valve in a higher pressure environment of the LV, the proximity to the left circumflex coronary artery, and the most important problem that we have is the risk of LVOT obstruction. I think that's actually the most, the biggest problem we have to try to treat this with devices. We are here part of the Apollo trial, and I love this image. There are 2 or 3 transeptal at this time valves for this of this type, and this is again transeptal therapy. Again, as I told you, by commissural view. This is again the left lateral appendage, lateral part of the apparatus, the medial part of the apparatus, aortic valve, anterior, posterior, severe mitral regurgitation on this patient, high risk, CT critical. And we have, of course, today with 3D technology, echo, we can measure the annulus. We do this all the time in order to compare the techniques, but CT is very critical to measure the area of the annulus and decide of what size of valve it will be used. But most important, as I told you, the most critical and difficult aspect of finding and treating mitral valve disease is the development of LVOT obstruction, which, if it happens, is catastrophic. So as you can see here, CT is very important by using a simulator and putting the valve that you plan to put on the patient, to place on the patient, and measure, as you can see here, what we call neo-LVOT, to see if the risk of obstruction is high. And of course, the companies today actually, for this trial, they move the target always to a larger neo-LVOT. So this, at least for Mount Sinai, this is, and we have Dr. Adams, who is the PI of the trial, of this trial. This is the biggest problem for us in recruiting patients, the risk of neo-LVOT obstruction. And CT is very critical. As you can see in this particular case, the neo-LVOT is 525 millimeters, and usually it has to be above 200, 220. As I told you, it's a little bit a target, moving target, started from 180, but now it's about 220. And also the aortomitral curtain, aortomitral angle, very important, which is basically measuring the angle between the annulus of the aortic valve and the annulus of the mitral valve. And as you can imagine, the wider it is, the less the risk of having an obstruction. The highest risk will be if it's perpendicular, where you will obstruct completely the LVOT. So these are very important measurements, and all this always a big discussion between the surgeons, the interventional cardiologists, and of course, if you have a neo LVOT of 525, there is no discussion about it. The problem is if the neo LVOT that you get from CT, it's close to the margins of what is acceptable and what is not. And this is again very the same transeptal. You have to go to the left side, as I told you, by caval view, superior vena cava, superior part of the septum, inferior part, anterior with the aortic valve posterior, and this is a safe cross catheter that we use sometimes to cross over to the left. Now they cross already to the left. You have to dilate because of the how big is the catheter. You have to dilate the septum in order to be able to cross over. As you can see here, the balloon and this is the valve, as you see here. Just for the interest of time, deployment is, as you can see, the valve was deployed. Everything looks good. As you can see here on 3D, from severe mitral regurgitation, no MR, no paravalvular leak in this case. And also, in order to prove that the CT was correct, you measure the gradient through the LVOT, and as you can see here, the gradient is a peak gradient of 7. So everything went great on this patient, and we knew that that would happen because of the ankle of the and also because of the measurement by CT. And I know that now for 10 times this has got approval in transapical has got approval for Europe, and this is a case from Emory. We did many of these cases many years back in Emory, and again, you need CT in order to determine the path that the catheter has to take through the left apex. And as you can see here, this is actually the surgeon, as you can see, who with his finger is pointing into this was Dr. Guyton in Emory, pointing to where you have to, the catheter has to cross from the apex, and it's a straight shot. Actually, very easy procedure if you do it. If you compare transapical mitral valve replacement to transeptal, transapical is much easier, but of course we know the problems by giving another injury to the ventricle of these patients. So that's the problem, and that's why I think the long-term therapy transcatheter wise will be transeptal mitral valve replacement, and this is how the valve looks before it's deployed, and this is after deployment of Tentyne valve. Last but not least, cardiologists are very smart people, and always develop techniques. This is a patient, as you can see here, with mitral prosthesis, bioprosthesis, stenotic, very stenotic, doesn't open, as you can see. And you can see here, high risk patient, very high risk. The transcatheter therapies were considered basically to do valve-in-valve therapy in this particular case. But as you can see here, you can tell that the LVOT, you don't have to do CT. You can tell that the LVOT here is very narrow. And you can tell that most likely if you deliver a valve there, you may end up obstructing the LVOT and cause a catastrophe. And this patient, as I told you, we had a CT, and any new LVOT predicted 81 millimeters square, very, very small to try to do this procedure. But as I told you, cardiologists have a lot of discoveries. This is a Laboon procedure, left laceration of the anterior mitral leaflet to prevent LVOT obstruction. I would like to do the first of this again in Emory to image the first procedure of this in Emory. As you can see here, very easy today with the 3D to find the leaflet that corresponds to the anterior part of the mitral prosthesis, and this was not the one. As you can see here, this was the anterior leaflet of the prosthesis that you basically try to cause laceration, to cause a hole, and then you put the valve in valve, and by having this opening of the leaflet, you prevent obstruction of the LVOT, and this is what happened here. As you can see, it's a complex procedure, but now it's much easier. Many centers do that. As you can see, the anterior leaflet of the prosthesis is completely lacerated. As you can see here, the flow through the laceration of the anterior leaflet. And now is under rapid pacing, is putting the new valve, 26 millimeter Sapien Resilia valve. As you can see here, from severe mitral stenosis, post-valve in valve, wide open and not new LVOT obstruction. As you can see here, flow through the LVOT. This procedure would not have been able to be done without to have the Laboon procedure, or if you have done without Laboon, it would have been a catastrophe, complete obstruction of the new LVOT. So thank you very much for your attention. And again, as I told you, this is my last slide. Many people involved for all these procedures, from the surgeons, the interventional cardiologists, the imagers, the anesthesiologists, but also our nurses. And here we have also nurse practitioners, coordinators, very critical for the success of any transcatheter valve program. And I would be happy to answer any questions. And again, it was a privilege to be a part of this meeting and be able to give a talk in Onassis heart meeting. Thank you very much.
Thank you very much, Samati. This was an excellent review. Any comments, others?
Well, Professor Lerakis, you certainly bring the imaging and decision-making, or if you wish, personalization of treatment to the next level with the methods you have up in your sleeve. So let me push it up one notch and ask you a question, as well as make a proposal and invite you here and now out of this podium for a collaboration. So I had started a project in Singapore, and after my return to Greece, of course, it had to be interrupted, but now I'm preparing the application for this again, for some European funds. Now, you'd be surprised to know that we heart surgeons, as much as our instruments and tools have evolved, we still, in my view, make primitive decisions. Don't be shocked. What I mean is that imagine we open up the left atrium to replace the mitral valve, right? So our decision is two-dimensional. We use a primitive plastic tool to measure the dimensions, the void that is left behind after we remove the heart valve. Now, the heart is stopped in an end diastolic position with the cardioplegia. But we don't take into consideration so many other aspects of the system of the mitral valve, the heart, and the patient around it. That means if we have a 25-year-old patient with a measured size in cardioplegic arrest of 30 millimeters, we will ask the nurse, unpack a 30 millimeter heart valve. That's all. If we have a 70-year-old patient with half the ejection fraction, and we measure 30 millimeters with this primitive tool, we will still ask the nurse to unpack a 30 millimeter valve. So the valves that we have in our armamentarium are also primitive circular devices that allow for unidirectional flow, just like 70 years ago. 50 years ago in our profession, more or less, with small changes. So what I'm trying to say here is that back in Singapore, I tried to look at functional criteria to make better predictions and personalize the treatment. We don't look at the ejection fraction. We don't look at the LVEDD. We don't look at the global longitudinal strain of the left ventricle. I would like to have your comment on this. I mean, you have access to a massive database at ICANN, Mount Sinai, because I envision that AI will be the next generation as a new algorithm and protocol to guide our decisions in choosing the right mid-treatment or the right valve for the mitral valve. And would hope to have your extramural co-investigatorship and collaboration on that. What's your thought on AI as a powerful tool in taking into consideration all dimensions of mitral valve disease?
Yes, thank you, Professor Kofidis, and I have followed your work, and I believe strongly on personalized, medicine, and of course therapies. And I know your great work that you have done in Singapore, and I followed very closely. But I agree, and actually yesterday we sent out a paper using AI. We have a fantastic AI program here in Mount Sinai. We actually yesterday submitted a paper using AI for aortic valve, for TAVI, which valve, which platform, which size, and all this stuff. So I agree, with AI today, we are getting in different levels of abilities, and I agree with you that, as you say, putting the same valve on somebody 70-year-old versus 25 with low EF, we have so much technology today. We can measure basically everything, and we do measure everything, but I think we have to put it to work, and with machine learning and all this technology, I think, the future is bright. We just have to use it correctly, because even AI sometimes, as you know, may give us false information. But I'm with you, and I'll be, of course, happy to collaborate. You have huge databases here, and with your databases in Singapore, in Greece, we can achieve a lot with your expertise. And I'm for it, and I will be happy to help in any way. But AI is, we do AI for everything. From EKG, from MECO, from, as I told you, we just sent a paper yesterday about TAVI, and I'm sure mitral clip, all this mitral valve replacement, all these things are on the works, and pretty soon we'll have solutions. I don't know if we'll be able to solve all the problems, but for sure we can do better compared with what we do now.
If I can add something, is that AI, as we use it today, we need a big database for the machine learning technique. And I think that Mount Sinai, having the mitral valve program for many, many years, probably has a huge amount of data that could do that. So you have to feed the system with all the data, and then it will give you the answer that Dr. Kofidis just said. So yeah, that's probably the next step.
I call upon all cardiologists involved here, and of course, Professor Lerakis, I totally agree with Professor Pavlidis, because it's a matter of calibration of the algorithm. And that's the volume and the thousands of cases we need to calibrate before and after surgery using those parameters, functional parameters, will be thousands. And therefore, we hope that we'll have Professor Lerakis' help moving forward.
Any final
comments? I would be very happy. Professor Kofidis is very happy to collaborate and do whatever I can from my part and from Mount Sinai. It would be a privilege.
Yannis?
No. Stamati, this is an excellent presentation. Thank you for that, and thank you for sharing all the insights about the use of AI in how to better implement these technologies in the everyday practice. So thank you for that, and hopefully we'll see each other very soon and have you here.
Thank you, Yannis. Always great to see you all, guys. Always great to see you. Pleasure. Yes.
Yeah. Thanks.
Thank you, Stamati, again. Thank you.
Thank you. Good. Καλή συνέχεια. Καλή συνέχεια. Ευχαριστώ πολύ.
Ευχαριστούμε.
Bye-bye.
So our last lecture for this session will be a case presentation by Dr. Perlepé from the Onassis Heart Center, a life-in-a-box case, TMVR in mitral ring. Dr. Prelepe, you have the podium.
Actually, it's in the same vein. It's a continuation of the TMVR, and it has we did the same thoughts that we will always investigate the LVOT, and this is very interesting, I think.
Yes, thank you. No, it's not the right presentation. This is my next one. It was in the previous session, but it's changed, so that's the problem. Sorry. Thank you for the opportunity to present this case involving a patient with transcatheter mitral valve replacement in a patient who has already put a mitral link on his valve. To begin with, we're dealing with a 46-year-old male who has severe symptomatic regurgitation and has gradually worsening effort dyspnea. His past medical history includes inferior STEMI, complicated with cardiogenic shock, for which an intra-aortic balloon pump was put, and then an urgent coronary angiography was made, revealing a proximal stenosis, severe stenosis of LAD and diagonal brasses, complete occlusion of the LCX and the RCA, which was the culprit lesion. And after that, an urgent percutaneous coronary intervention was made to the RCA. And after that, the heart team decided that the patient should do a bypass, and because in the pre-procedural echo, a moderate ischemic MR type 3B carpenters was revealed, they decided that during the surgery, an MV plasty with a complete semi-rigid ring simulus should also be placed in the patient. Although this happened, the post-procedural TOE revealed a mild to moderate MR. 4 months later, the patient, an ICD was inserted. The patient is also obese. He is an ex-smoker, and he has also a history of hypertension, dyslipidemia, COPD, and mildly impaired renal function. At the time of the investigation in our department, he is on optimal medical therapy at the max tolerated doses, and his ECG did not reveal an LBBB or a widening of the QRS, so he is not a candidate for an advancement to a CRTD. Based on all this, the calculated scores, surgical scores, was compatible with patient of medium risk. So, in order to investigate our patient and see what we can do to to fix his problem. The following exams were made. First of all, a coronary angiography that revealed that the graft was patent and there was no interstenosis in the RCA. A screening right heart catheterization who revealed a mean pressure of 47 millimeters and wedge pressure of 36 and the current output of 4.2. And of course, transthoracic echocardiography who revealed an impaired function of the LV with an LVEF about 30-35%. And dilated left ventricle with end diastolic diameter being 55. And as you can see, a severe mitral regurgitation due to a severe tethering of the posterior leaflet and anterior coarctation of the leaflet, as you can see better in these images. The next exam was transesophageal echocardiography, and this was mainly in order to assess if this patient is a candidate for edge-to-edge repair with a mitral clip. This exam showed again the significant mitral regurgitation and the tethering, and also showed that there is a significant coaptation gap of about 10 millimeters. So we decided that this patient would not be suitable for transcatheter edge-to-edge repair. So the next thing that we have to do is to see if this patient is a right candidate for transcatheter valve implantation. And to do this, we use this application, the valve-in-valve application, where we can put the measurements of the previously implanted ring, and the application can tell us if this patient is a candidate and can tell us also the right measure of the valve that we can choose. After putting this on the application, the answer was that we can choose a valve of 29 millimeters, a sapien valve of 29 millimeters. So the next thing is to see, as we heard before, if the patient has high-risk criteria for LVOT obstruction. To do this, we again can use the app and put the measurements from the CT that was made in our department. And based on these measurements, the patient's risk for LVOT was low. So based on all this, the heart team decided that a transcatheter mitral valve implantation, valve in ring, with balloon expandable valve should be the optimal strategy for this patient. So these are, in short, the procedural steps that I'm going to tell you during the next video. And Mr. Iakovous, you can interrupt me and correct me whenever you want. And in general, the procedure was made under general anesthesia, and puncture of the femoral vein was made under ultrasound guidance.
Well, the main thing here is whether or not to plan a laboon technique, or because we were worried about the length of the anterior leaflet. So we measured its borderline, it's to ND2, as far as I remember, and I think so we decided that it's safe to proceed without endangering a laboon technique. So that's why we proceeded, and you can proceed the same.
So now I don't have my notes, so I don't want the correct time of what I want to say, but I'll try to be as fast. Yes. No. So, okay. Don't worry, I'll try to. Yes, because they try to fix it, but it's okay.
As I can see, Dr. Felipe has perfectly on the screen, so.
Okay, don't worry.
So it doesn't transmit to the big screen.
Don't worry. Έχω βρει τους χρόνους και τα έχω σημειώσει γι' αυτό, αλλά δεν έχω τις σημειώσεις μου για να μπορώ να το πω. Okay, now I'm okay. So, initially, as we can see here, I put the left femoral vein was punctured to allow placement of a temporary pacing lead, and subsequently, the left vein was also punctured. The right femoral vein was also punctured, and seats of 6 French and 9 French were first inserted, followed by an 18 French sheath. And also a 6 French prostyle closure device was also placed. So now, move on to something more interesting. Okay, here we can see that after vascular access, transeptal puncture was performed using an SL1 sheath and BRK1 needle. You can see also here the echo guidance for the puncture. So, upon successful puncture, Applager super-stiff wire was advanced into the left pulmonary vein. As shown here. And the transeptal sheath was then removed. Here we're removing the transeptal sheath, and an Azilis steerable sheath was introduced. This is the Azilis sheath. Now, the Amplatz wire was exchanged, and 2 Safari wires, one small and one extra small as body wires, were positioned in the left ventricle via this Azilis sheath, as you will see now. Sorry. This is the one. Okay, the one. And now the second one. So after this, a temporal pacing lead was positioned in the right ventricle. As you can see here. It is placed. And the next step involved the insertion of the Edwards E sheath of 14 French through the right femoral vein. So, let's proceed. This is the sheath that I was talking about. Then an Atlas Gold of 20 millimeters balloon was advanced and used to dilate the interarterial septum. I will show you this step. This is the balloon. We dilated this balloon through 2 or 3 times under echo guidance.
Well, I think it's a 12 by 40 Atlas Gold. Yes.
It was 2040, yes. 12, 40.
Yeah, you use 12 or 14, mostly.
Okay, so this was followed by the preparation of the valve delivery system that I'm going to show you right now. This is the preparation of the delivery system. And then this was advanced carefully up to the level of the mitral ring. You will see it in a few seconds.
Well, but it happened. It happened, yes.
Okay, so you can see the valve through the system, the delivery system. It's reaching the mitral ring. So after confirming optimal positioning of the valve just in the center of the mitral ring, rapid ventricular pacing was initiated. We started the pacing, you can see it. And in the next few seconds, you will see the deployment of the valve. The valve was gradually deployed, balloon expandable, until full expansion was achieved. It has some resistance, but at the end, the valve was fully expanded. You can see it here. So, color Doppler imaging showed a really satisfactory result with no regurgitation.
It's important to do it slow as we did, because as the valve shortens from the base to the apex, you have to make sure that when it's half
Exactly.
that you can pull it back a little bit.
It has to be slow, and we had
it has to be very slow, exactly as you did it.
Yes, as you noticed, initially we didn't have proper pacing, so we had Dr. Rodiadis had to be really exactly meticulous and very strong in his in the inflation of the balloon, and I have to hold the valve. So it's not an easy procedure. There are some things that you need to consider. You have to properly predilate the septum. The idea to have a second body wire that we will learn from our colleagues. It's a good thing. It's not easy to advance, and then of course you have to remember to take out the body wire, otherwise you will interrupt it. So this is, I think it's a fine result.
Yes, we also measured the transvalvular gradient with the withdrawal of a pigtail catheter, and we had no gradient either during the withdrawal or on echocardiographic assessment, and we also had no LVOT outflow obstruction. And we also made a left ventriculopathy, and which did not reveal any evidence of regurgitation. And although the patient remained hemodynamically stable throughout the procedure, an intra-aortic balloon pump was inserted at the end of the procedure through the left femoral artery as a preventive measure against the expected afterload mismatch phenomenon. You can see the pump here. It is inserted. So, despite the excellent procedural result with no regurgitation and no outflow obstruction, the patient developed hemodynamic instability post-procedure. This included hypotension, increasing requirements for inotropes and vasopressors, rising lactate levels, and episode of non-sustained ventricular tachycardia. Due to this, veno-arterial ECMO was placed the following day, and fortunately, this led to rapid stabilization of the patient, and the ECMO was successfully weaned and removed after 4 days. The patient was gradually weaned off both mechanical support and inotropic agent and was eventually discharged in good clinical condition and ambulatory. Pre-discharge echocardiography, as you can see, shows improvement in the left ventricular contractility compared to the immediate post-procedural study. And echocardiography follow-up of the patient at 1 month demonstrated excellent function of the prosthetic mitral valve and stable left ventricular systolic performance with an LVEF of approximately 30% with no outflow tract obstruction. So in closing, I would like to highlight a few key points regarding the phenomenon of afterload mismatch following mitral valve replacement. In general, in patients with chronic severe mitral regurgitation, the left ventricle adapts to a low resistance state as part of the stroke volume is ejected into the left atrium. Once the mitral regurgitation is corrected, either surgically or via transcatheter valve implantation, the ventricle is suddenly faced with a higher afterload, as it now has to eject entirely into the systemic circulation. These abrupt hemodynamic change can lead to acute LV failure, especially in patients with pre-existing systolic dysfunction, as in our patient. Recognizing this risk is essential, and strategies such as prophylactic use of mechanical circulatory support or careful afterload management may be required to ensure a safe post-procedural course. Thank you for your attention.
If I can make a small comment, so this is an example of the hard team work and discussion that Dr. Kofidis was advising before. So we discussed a lot with the surgeons how to deal with this patient. Initially, we tried to understand what kind of procedure had been done originally, because it had been done, in a previous hospital, and maybe Dr. Kofidis can elaborate a little bit on that. So it was, they placed a semiform ring, and then there are some neocordae, which I suppose that they were ruptured. And then we discussed with the surgeon, about the other steps, and we discussed also on the possibility to have an ECMO immediately after, or let's wait and see. So we decided the second, and of course they were ready, and the surgeons, along with Dr. Leodiadis, who was instructed not to sleep that night, and he came early in the early hours of the evening, and the ECMO was placed. So, Dr. Kofidis, what your approach would be in this patient?
Well, in hindsight, we're all smarter. But yeah, a few comments, maybe questions I have. First of all, congratulations on a close call. The patient did well in the end and left the hospital. Also, congratulations on making the early decision to go on ECMO when the patient was on the post-MV repair or replacement banana phase, which can be detrimental. Now, a question I have is, of course, being a surgeon on the indication. He was 46 years old?
Or
yes,
young
43,
patient?
43.
43, okay. Just a few years out of cabbage procedure. What was the immediately pre-op coronary angiography result? I may have missed it. Before you went in for the clip procedure, for the valve-in-ring procedure, was there a refresh coronary angiography, and what did it show? Were the bypasses patent or?
Yes, all the bypass grafts were patent,
Patent.
and there was no restenosis of the stent in the RCA. So he had no ischemia. And
I think, yeah, so the idea of the surgeon was supposed, because we read his review, it was, he didn't want to replace the valve, he just put the ring right in that maybe this will open up the possibility of having a TEER procedure in the future. So my question is, would you do that? Maybe why do you place a ring and then why don't you just refer immediately for a TEER procedure?
Well, I can't comment on the surgeon's actions or decisions because I guess here in Greece it's very difficult to get to operation notes from the last procedure. Okay, so that's the truth of the matter.
If you get it, sometimes.
Yeah, so they have,
It's
very marginal. Right?
Cryptography, you have to, read.
Or very short and so on. So, there are guidelines, or at least there are opinions on whether to replace or repair the valve, at least address the valve when you have ischemic mitral valve disease. The bypass has obviously worked, that's first step. And then on a valve that is moderately severe or above, you ought to do something for the mitral valve. We all know that ischemic mitral valve is difficult to repair. It may require leaflet extensions. It may require an approximation of the papillary muscles with slings or bands. So I don't know exactly what went on in the operation theater when the surgery was done. I noticed that the ejection fraction before your procedure was already low. What was the progress of the ejection fraction in the last couple of years, and why didn't the patient want to have a surgical procedure? I mean, what was the heart team's decision? Would it be very high risk to do a redo surgery? Or?
So yes, so the patient was excluded by surgeons of our hospital, another hospital as well.
Okay.
So he was discussed thoroughly in the heart team. So we decided that maybe the TMVR was the only solution because the patient was really sick. He could not, he had a New York Heart Association 3, a young patient, otherwise healthy.
Yeah.
But severe heart failure, and actually he was before coming to us, he was checked in the outpatient clinics of the heart failure specialist as a pre-transplantation screening.
I see.
So and we debated a lot with the transplantation specialist in our hospital. Just let's give this patient an opportunity, maybe he can get out of it. And I think we are happy with the outcome because patient, I saw him 1 month ago in the outpatient clinics, so he was feeling well. Actually, he could climb 6 flights of stairs in our hospital, which for him, after 1.5 years of severe heart failure, this was a big thing. I don't know how we'll end up, but we checked with the scintigraphy, it's mostly scar. We don't anticipate big increase in the ejection fraction, but for the time being, he's doing a lot better.
Was his MR at the time of the bypass moderate or severe?
Supposedly it's severe. Supposedly
severe. Because there is at least one study we know well that when you do bypass and you correct or not a moderate MR, it doesn't make a difference surgically.
Correct.
So that's why probably they thought putting a ring versus replacing the valve if it was severe or doing something more drastic. I assume we don't know what they did, but yeah, that was easy. Yeah. Good. Yeah. Good case. Excellent. Well, I think we have concluded an interesting session. We'll take a short break, really short, because it's been through for a while, and be back in about 10 minutes. Thank you very much, all. Others.
Okay, είμαστε έτοιμοι. Ωραία, κύριε Βραχλιώτη, δεν έρχεστε εδώ.
Είναι η κυρία Βαρτελά.
Πού είναι η κυρία Βαρτελά? Όλη η χώρα εδώ πέρα έχει 7 καρέκλες. Ωραία, έχουμε τον κύριο Τζίκα, ο οποίος είναι pre-recorded, έτσι. Imagine. Εντάξει, εντάξει. Ωραία, σας καλωσορίζω λοιπόν και στο απογευματινό session. Είναι late afternoon. Οπότε κάνουμε μια μικρή επίγουσα αλλαγή. Θα μιλήσει ο κύριος Βραχλιώτης για CT Imaging and Anatomy in Structural Procedures, the role of radiologists. Που και μπορούμε νομίζω να μιλήσουμε και ελληνικά τώρα. Η κυρία Βαρτελά είναι co-moderator.
Νομίζω μιλάω στα αγγλικά, έτσι.
Και αγγλικά, βεβαίως. Και αγγλικά.
Okay, thank you indeed for this very kind introduction, and congratulations on the highest quality of this meeting. I'm, more than pleasantly surprised since I arrived earlier today with all those innovations and things that are in progress, and certainly it's, very nice and very honorable to be working with you here at Onassis Hospital. Now, I have nothing to disclose. In the last years in the COVID area, TikTok, YouTube and everything, we are all getting wiser because we hear many, many quotes from many people. Everybody wants to say his or her quote and uploads it on YouTube or wherever. Now, I heard a nice quote the other day. If you pray for rain, you got to be prepared to deal with mud as well. So this comes sort of in conjunction with prosthetic heart valves. The heart valve is a divine device. It's the rain. However, once a prosthetic heart valve is implanted, it's a foreign body. It will do its divine job. However, that will come at a cost. And the cost is, of course, complications, the mud. The valve may be dysfunctional, there may be dehiscence, endocarditis, PVL, which is essentially the subject I'm going to elaborate upon today, thrombosis, Pan's formation, pseudoaneurysm, abscess, just to name a few. And paravalvular leak is maybe one of the most important ones. Para comes from the Greek prefix, which means next to. And PVL is, I assume you can hear me, that's why you don't interrupt me. Okay, so PVL is abnormal flow through a channel between the valvular prosthesis and the valvular native annulus due to inadequate sealing. It's something that shouldn't be there. And PVL is characterized by inappropriate apposition of the prosthesis in the native tissues, and that this leads to an abnormal connection between the cardiac chambers. As you much better know than me, the 4 cardiac chambers are sealed tightly between them. Unfortunately, PVL is a relatively common complication of both mechanical and bioprosthetic valves, 20% in the aortic area and maybe twice as much in the mitral position. Factors predisposing to PVL development are technique, position, sewing ring composition. Causes include dehiscence, infective endocarditis, etc. Now, has been observed recently that the volume of calcium when it reaches a threshold of 850 Hounsfield units, as measured with CT, is the best predictor of PVL in cases of TAVI valves. Speaking about TAVI valves, self-expanding TAVI valves are more prone to PVL than balloon expandable ones, and the most overall common cause of PVL is endocarditis-induced dehiscence. Interestingly now, PVL can be seen without any definite signs of dehiscence, and this may be due to alteration of the normal geometry within the heart itself. Almost up to 20% of PVLs are seen in the immediate postoperative period, and most patients fortunately have small PVLs and they remain asymptomatic. However, large PVLs are again fortunately seen in less than 1% of surgeries, and they can result in heart failure, hemolytic anemia, or endocarditis. Now, enough said, let's see some things. Is there a pointer here? There is, okay. Thank you. As I mentioned earlier, yes, excellent. As I mentioned earlier, PVL is something that shouldn't be there and connects two chambers. Now, this is one chamber. Here is the aorta, and the other chamber is the left ventricle. This is the prosthetic valve. This multicolored serpentine is flow of blood that goes to and fro, okay, when in between systole and diastole, and this happened because the valve ultimately got detached from where it was initially placed. Now here you can see the arrow in the aortic valve area. You see this chamber, LV, is connected to the aortic chamber, and this corridor of contrast is the PVL. Now the same here, we have a TAVI valve here. You can see that there is a channel here, which is contrast. And when you see contrast connecting the left ventricle and the aorta, and having a strong hint from the cardiology department, the ultrasound department cardiology, then you must look for a PVL. And this is what a dehiscent valve looks like. In this scheme, you see stitches here have been disrupted. So this area shouldn't be like this. It should be like this, where the stitches are intact. And the result of stitches being broken here is this crescent-shaped area, which is contrast outside the mitral valve, the prosthetic valve, which is this, and this is the myocardium, where it was initially attached to. Now, first of all, a good clinical history, hemolytic anemia, heart failure, endocarditis, is what will give the referring physician, the cardiologist, the first hint that something's wrong. Next step, and it's an extremely important step, and this is the step that actually gives us the diagnosis, is echo. And 3D transesophageal echo is the gold standard of diagnosing a PVL. Now, my talk is mostly about CT, so slowly I will deflect into more CT images. So in CT, what we see is contrast material going from one chamber to the other, or even better, contrast material connecting two chambers. Let's see, I'll show it to you further down. Now, the problem with demonstrating a PVL arises when we don't know it. For example, on a daily basis, we see and read 5, 10, 20, I don't know how many, coronary CT angiograms. Now, those angiograms are automatically displayed for us to diagnose in the 3 elementary views. That's axial, sagittal, and coronal. it is extremely difficult and highly unlikely that we will diagnose a PVL in those images alone, even if we have the history and the hint from you. So we don't have any radiologists here, but the thing to remember here is that the only view that will demonstrate the PVL is the view that the radiologist himself or herself will create, and this is a true axial double oblique reconstruction of the data set. Now, someone will ask us, can MR do the same thing? Well, MR can be done, but there are too many dephasing artifacts. The 3 data set is getting better, but not at the same level of resolution as the CT data set. There are some sequences that show dephasing, and thus they are diminishing the quality. And however, we can quantify the regurgitation using phase contrast MRI. I think enough said. These are some technical aspects of us radiologists to know. What you should know is that when you refer to us a patient with, the question, is there a PVL or not, just please try to have your patient with low heartbeats. 60 is very good, 70 is acceptable. So in the 60, 70 beats per minute area. Okay, some images now. Now arrows here show where the paravalvular leaks are. We are in the aortic area on the left-hand side image, and in the mitral valve area on the right side. This is before and after interventional cardiology corrected a PVL. Here is before, sorry. Okay, here's the PVL, and here's after correction with all those ambulatory occluders. Again, this is the PVL. Okay, again, the sine qua non is you see a contrast medium column connecting proximal and distal chambers. Okay, again. Now, this view here, see how nice the aortic valve and the mitral valve are presented. Yes, this is not a standard view for us. Okay, it may take a few minutes, and of course you have to know what you're doing in order to present to you this nice image, this nice view, so that we can perform, measurements on what dimensions the PVL has in order to plan your intervention. Again, see some measurements here, here again. I think we are at Onassis in collaboration with a certain company which makes 3D models of the valves and the PVLs more specifically. See here the PVL here, and I think this is the PVL here. Okay, I'm out of time, but I'm getting close. Okay, this here is the PVL next to the mitral ring. Oh, good. Okay, so the 3 most important things: history, history, history. You and us must have a high degree of clinical suspicion. It's one of the complications that usually or unusually arise when you have a prosthetic valve. With echocardiography, cardiology has first diagnosed what's going on, so we urge you to give us that piece of information, because as I mentioned to you earlier, even if we do double oblique images in all prosthetic valves, in any location, if we don't know where and what to look for, chances are that we may very well miss it. And I'm talking from personal experience, not others. In CT, what you have to look for is a contrast material filled channel in the paravalvular region that connects two adjacent chambers. Again, it's very easy to miss. And for radiologists who are not here, always use double oblique reconstructions, and this is the most essential part to demonstrate a PVL. Thank you so much for inviting me.
Dr. Vrachlotis, thank you for this enlightening lecture. I would like to emphasize that, of course, CT is an increasingly important imaging tool for the structural cardiac disease. Using echo, we can identify paravalvular leaks. Although, using the CT, we can have the access of the, for the procedure. We can have the right angulation for the measurement, and maybe this paravalvular leak is a little serpiginous, I can say. So I think this technique must be done in every paravalvular leak.
I think we do it. I think we do it. What we are asking you to do for us is tell us, because it's, I mean, it shouldn't be happening, but the truth of the matter is that it's extremely easy to miss, and this is not from personal experience only, it's in the literature.
Yes.
It's in the literature. So we have to abide by what the literature says, and since, you know, this is a very, very nice and open
exactly, and this is the point
here.
of having multidisciplinary teams.
Exactly.
So
I'm telling you, and you know, one day so let me just finish this. I got in the meeting, they had already started, and when I saw the name, I said, yes, I know that, and in front of everybody, I said, fine. Now, don't tell me this is a PVL that we missed, which was, you know, what had really happened. But the most interesting thing is that everybody was looking and was trying to find it, despite the double obliques, and we couldn't, because we didn't have the right guidance. Of course, it was not a huge PVL like the one I showed here. It was something small, but still. And the other thing is that, and Dr. Vartela, you suggested that some time ago when you came from, you know, your sabbatical in England. Yeah, we have to sit together. You know, radiologists don't know cardiology, and radiologists don't know cardiology. So unless we sit together and, you know, get things.
And we sonographer, like the sonographer, yeah, we feel very confident for all these paravalvular leaks. And sometimes we miss some things on that paravalvular leak that we are studying. So that's the reason we have to ask for a CT.
So well, we're happy if we're getting our collaboration.
Okay, so now we have a radiologist, we have an echocardiographic specialist, and we have a CMR specialist. This is Dr. Niktari. She's hybrid. Dr. Niktari, can you?
Yes, I'm connected. Good evening to all.
Excellent, excellent. We, as interventional cardiologists, we don't communicate a lot with CMR specialists, apart from certain, let's say, quantification purposes. We want to be very thorough in ejection fractions, in volumes, or in regurgitations. So do you have any other idea? Do you think that there are issues that you can help us more identify problems in structural heart disease?
So to begin with, I think there is a lot of improvement the last couple of years regarding the elimination of artifacts that have to do with the metallic rings and all the prosthetic material you get into the heart. So just to make a comment, BSSFP, CNS, which are the traditional way to visualize the paravalvular leak is the worst way to check it. So now with the 4D flow technique, we can actually mimic the three-dimensional transthoracic echo. And despite the fact we have the metallic artifact in situ from the ring, usually, or the stent segment of the valve, we can actually visualize the paravalvular leaks. So I'm not sure if I can share my screen. This is a present to Dr. Rakliotis, because he had asked me if I can show a picture showing an MRI image that has depicted the paravalvular leak. This is not mine, but I can show you how it is. I'm just trying to find out whether I can share my screen.
Μπορούμε να βοηθήσουμε, κύριε Νύχτερη, να κάνει share.
Yes, that's fine. So this is from a publication. I'm not sure it's showing. I'm not sure whether you can see it.
Well, no, it's not, but is it possible? Yeah. Yes, we see it.
Can you see it? Can you see the picture?
Yes, yes.
So you can see now the metallic artifacts from the rings in situ, but despite the material, you can also see the red jet projecting next to the metallic artifact. So yes, if you ask me whether MRI can be useful, yes, it can be, but with the newer techniques, the more novel techniques, just like 4D flow, which of course are time consuming, but we have a new under development sequence that we can take this image in 6 minutes. Unfortunately, we don't have referrals yet. So you are very welcome to refer patients, and then we can actually compare the findings with CT and
ultrasound.
Yes, and CT. Dr. Rakliotis, we can actually take comparable images with MRI with a new sequence named BOOST. And this is a research proposal. We can actually get the sensitivity and specificity of detecting and quantifying such leaks using 3 techniques, and using TOE as a standard.
Excellent. So this is a real-time heart team discussion. So thank you for that, Dr. Nektaris. Maybe we will continue the discussion of the heart team on Thursday afternoon. So good. So we have to proceed now with the live in a box after the theoretical discussion and on how to spot and quantify the importance, the clinical importance of the paravalvular leak. Then we'll see how we deal with a situation like that. So, Dr. Perlepin.
In the next few minutes, I'm going to present you another interesting live in a box case, this time involving the transcatheter closure of a paravalvular leak in a patient with an aortic mechanical valve. So our patient is a 63-year-old male presenting with progressively worsening exertional dyspnea, along with clinical and laboratory signs of hemolytic anemia. His medical history includes arterial hypertension, COPD, and an episode of infective endocarditis in 2016, leading to the need of surgical aortic valve replacement 4 years later in 2020 with 23 millimeters Sorin bicarbon mechanical prosthesis. Immediately post-operatively, he required the replacement of a pacemaker due to conduction abnormalities. In January 2025, the patient was admitted with a respiratory infection, and during this hospitalization, laboratory workup showed an hematocrit of 22%, very high LDL and very low aptoglobin levels, findings compatible with hemolytic anemia. At the same time, transesophageal echocardiography revealed moderate aortic paravalvular regurgitation, so the patient was referred to our department for further evaluation. The transthoracic echocardiogram performed in our department, as shown here, demonstrated preserved LV ejection fraction of 50-55% with normal disc motion in the mechanical valve, and confirmed the presence of a moderate paravalvular leak at the region of the left coronary cusp with a vena contracta of 3 to 4 millimeters. A transesophageal study with 3D imaging was then performed, which better highlighted the exact location of the leak in the left cusp, as well as its crescent shape, suggestive of a relatively narrow and irregular tunnel. The next examination performed was a CT scan, which, as you can see, provides us with additional information regarding the shape, the length and the width of the tunnel, the calcification in the area, and the distance from the origin of the left main, all of which are crucial for optimal management planning. The same are visualized here using multiplanar reconstruction. Based on all the above and taking into account the patient's history, the heart valve team of our hospital opted for a transcatheter closure approach as the optimal strategy for this patient. So the next step is the selection of the appropriate closure device. In general, there are two main devices available for transcatheter PVL closure: the Amplinger vascular plug 3 and the Occlutech paravalvular leak device. The Occlutech paravalvular leak device is available in square and rectangular shapes, and each shape is available in two configurations, one with a central waist and one called twist, which has no waist and offers greater flexibility in irregular or calcified defects. Each variant of Occlutech devices comes in a wide range of sizes, as you can see here. And the Amplinger vascular plug 3 device from the other sides come in 9 different sizes and has a multi-lobed structure that adapts better to smaller circular or central leaks. In our case, based on the crescent shape and the rather irregular and sure calcified tunnel, we chose the rectangular twist device by Occlutech, while the size selection was based on echocardiographic measurements taken during the procedure. So we move on to the live case. I will describe the steps during the live video. In general, the procedure was performed under general anesthesia with TOE guidance, and femoral access was obtained bilaterally with echo-guided puncture. As you can see, as you can see, a 10 French sheath was placed in the right femoral artery, and a 7 French sheath that you can see here is placed in the left femoral artery, through which a 6 French pigtail catheter was advanced into the aortic root for angiographic guidance during the procedure, as you can see. So initially, let's move on here. So initially, we used an AL1 6 French catheter to successfully cross the paravalvular defect with a straight wire, as you can see. We managed to cross the defect, the leak, with a straight wire, but the AL1 catheter itself could not be advanced through the track, as you can see here. Therefore, it was removed and exchanged for a 6.5 French multi-purpose catheter, which was able to advance further into the tunnel. I'll try to show you the step. Here. So the straight wire was then removed, and through the multi-purpose catheter, a Landerquist wire was advanced into the left ventricle. Here is already advanced. This is, I don't have a pointer. Ah, okay, I don't have. We have inserted the, okay, I can show you. But here we have inserted the multi-purpose and the Landerquist through this catheter. Next, after echocardiographical measurements of the defects, the appropriate device size selected was a 5 French, I'll tell you later, but this size needed a 7 French occluded delivery system, which was introduced via the right femoral artery. Here we can see the insertion of the sheath. So then, after removal of the dilator, the occluder device is advanced through the sheath. As you can see here. You see the sheath, and we are waiting for the deployment of the device, the advancement. Okay, here the device is advanced, and the one disc is extracted into the left ventricle, and then the whole system is pulled back as you can see. Until it reaches the outflow of the leak. Okay, so I'll show you again this step. Then it has reached the outflow of the leak. And the next move is to deploy the twist segment and the other disc to the aorta, as you can see here. This was our first attempt, and the second disc was not very well deployed, was deployed within the tunnel. So we recaptured the device, and we attempted redeployment in a more optional position. Here, you can see the redeployment. Here. So this step can theoretically be repeated multiple times until satisfactory positioning of all parts of the device is achieved. At this time, the device appears to be in good position, and after confirming its stability and being satisfied with the echocardiographic reduction of the regurgitation, as well as the observed increase in the diastolic pressure in aorta. The device was successfully released. Somewhere here. Okay, we released the device. So the procedure was completed with a close of the right femoral vein using a prostyle, and the left femoral artery using an angiosyl. At 1 month follow-up, the patient showed marked clinical improvement, and although echocardiographically still detects a small to moderate paravalvular leak, as you can see here, patient reports minimal exertion dyspnea, NIHA 1 to 2, and his hematocrit has been improved to 40%. So in conclusion, I will tell you some things about aortic paravalvular leaks. Aortic paravalvular leaks are more commonly seen following transcatheter valve implantation compared to surgically valve replacement. According to the data shown here, after surgical aortic valve replacement, the incidence of PVL is reported between 1 and 5%, while after TAVI, mild PVL may occur in up to 30% of cases, and moderate to severe PVL is seen in 5 to 15, depending on valve type and operator experience. Etiologically, PVLs result from incomplete annular sealing, calcification, or sutured adhesions. When moderate or severe, are independently associated with increased mortality, underscoring the importance of early recognition and appropriate management. 3D TOE is the gold standard for diagnosis, while CT complements complex cases. Surgical reoperation is the gold standard, but transcatheter closure offers more than a 90% success and low procedural risk in appropriate candidates. Thank you for your attention.
Very nice, Dr. Parlepé. So this presentation is open for discussion, and I have to remind the colleagues that they are streaming. We have 314 now streaming. So feel free to ask anything on the chat box. Dr. Niños, you have a lot of experience in paravalvular leak closure, right? So maybe the Transbalkan Center is doing the most in Greece right now? We don't know. So I think they're pretty rare in Greece. But they should be a lot more frequent, because a lot of these patients, end up doing a reduced surgical approach, and we know that this care has an inherent increased risk of complications. So we notice in this this is the Oculoc device is the only specifically designed for paravalvular leak closure, and maybe, of course, there are some caveats. There are some the sheath is more burdensome to manipulate, but I think I think it's a good depiction of how to close paravalvular leak closure. How long do you have to wait in order to see a complete, let's say, so as long as you are successful, how long do you have to wait for complete endothelialization to occur and then see a meaningful decrease in the paravalvular leak?
Very much again for the invitation to be here, part of that wonderful meeting. I think that the story with the paravalvular leaks is a very frequent one. I mean, there are a lot of cases, as you mentioned before, And a lot of patients also have hemolysis, and that's a very bad thing. They require blood transfusions, and that's of course those patients can be reoperated and then have again a relapse. I don't know why, but we have seen that before, sometimes it's enough to modify the leak, not to have a perfect result. And the modification of the leak can be enough to stop the hemolysis or to improve the functional status of the patient.
And which are the situations that you don't actually touch when you have a rocking valve, or when you have a lot of do you have like
exactly.
180 degrees and more
yes, a rocking valve, or if the ring is detached, of course, that's another story. But if there is a paravalvular leak or two, then you can try. It's deserved to try. I would wait for 1 month to evaluate the result. And sometimes somebody can be disappointed initially because the color Doppler shows some color, and somebody can say, okay, I don't have a good result, but it's not the time to evaluate during or immediately after the procedure. You have to wait and evaluate clinically the patient and echocardiographically after 1 month.
Okay, good. And I see Dr. Zarogiannis, do you have experience in paravalvular closure? How do you deal with in this setup, right? Okay, good. Excellent. So any other comments from co-moderators? Vaso?
Yes, I would like to ask how many times after the first deployment of the device could you deploy a new one if the residual, if the regurgitation, the residual regurgitation is,
I mean, other than immediately?
Moderate.
Of course, you can place immediately, but you can wait and see. But there's always the case that you might have a dislodgement or compromise of the metallic or valve. You always have to be
concerned about the metallic valve and the discs. Yes. Okay.
Good. So thank you, Dr. Perlepin. So now we have a pre-recorded talk by Dr. Gigas. We know that it's a European authority. In LAIO, he will talk about patient selection for LAIO.
Good afternoon from Frankfurt, Germany. Thank you very much for the kind invitation. Unfortunately, I could not attend this year because I'm attending CSI. I will do this lecture in English because I believe there are maybe some international participants in the meeting. We will talk about the need for left atrial appendage occlusion and particularly the patient selection. And these are my disclosures. We are in the decade of stroke. Hopefully stroke reduction. Stroke is a major socioeconomic problem and it affects patients worldwide. It's a big problem. And more specifically, the cardioembolic stroke is another subgroup of stroke, which is very, very important because it has higher morbidity and mortality. These slides you will see at the end, these are potential indications for left atrial appendage occlusion. But before going there, I will start with this anatomical structure per se, which is the reservoir for thrombus formation in patients with atrial fibrillation. You can see here, this is a transesophageal echocardiogram by a patient who is under general anesthesia. His blood pressure is 90 to 60 and his heart rate is 60. And these are sleeping conditions, okay? We have this hemodynamics when we are sleeping, when we're asleep, and this is what happens. This is a dynamic situation in the left atrium, in the left atrial appendage, as you see here. When we give inotropes and the bed pressure increases and the heart rate is higher, then we have a totally different scenario. I put this video here because it shows that this is not black or white. The thrombus formation is something that it may be continuously changing, and we do not always capture all the details. The anticoagulants started as rat killers. It can be poisonous. And no matter how much they helped in the stroke prevention, I think we may have reached a limit in their use. We talk about p-values and risk reduction, and we're happy when we have small improvements in our results. However, there is an elephant in the room, and the elephant is called adherence. The patients do not want to take this medication. And we can see that from data when we introduced in clinical practice years ago the non-vitamin K anticoagulants. It did increase the adherence somehow, and but it did not increase it substantially. Less than 50% of the patients are treated according to the guidelines. This is a huge patient population. Even and this is true for all the anticoagulants, all the new anticoagulants. And the main reason for that is that these drugs are associated with a major bleeding risk of 5 to 7% per year. So the introduction of the anti-11 factors has been promising at the beginning. However, it looks like the drugs are safer, they have less bleedings, but they seem to be not so effective. So, for example, this trial was stopped 2 years ago. Now, the proof of concept for left lateral appendage occlusion were given by the surgeons in this very nicely conducted randomized clinical trial when they compared surgery alone versus surgery plus LA closure. And the study was very clearly positive in favor of left lateral appendage excision in particular when a patient undergoes surgery. However, there is a lack of data in the percutaneous LA closure. And this is true, meaning that we have this nice result by PROTECT AF when we show reduction in all-cause mortality in 4 years. However, we do not have big trials comparing LA closure with NOACs, with the exception of PRAC 17, which was a small study. This has changed, and I will show you 1 or 2 items about it. What has been very disappointing is that in the ESC guidelines, the LA closure, the percutaneous LA closure was still in 2B indication, whereas in the American guidelines, it has increased from a 2B to 2A indication. And there is a discrepancy between the European and the American guidelines, and this creates quite a lot of confusion. We are trying to solve that. Now, in this consensus paper that we published years ago, we were saying that patients that are suitable for oral anticoagulation should receive it, and others should be discussed. 7 years ago, we conducted this study that was published in a European Heart Journal. It's called MISOAC-AF, and this shows potential indications for LA closure, but it shows also another important thing, that when you do an intervention, and these are a study that was conducted in Greece in 1,000 patients randomized, and we did an intervention on the half of the patients, trying to increase the adherence. The positive effect of this was when we increased the adherence to 77%. So that was the top. Whereas the adherence, when you do a procedure, an LA closure in particular, is 100%. There is no issue. So this should be taken into account when we're discussing an intervention as compared to drug therapy. Now, the main indication for LA closure in this sub-study that we did from the MISOAC-AF were intracranial bleeding or gastrointestinal bleeding on patients who had an embolic stroke while on adequate anticoagulation, and these were considered stroke indications. And we had a loose indication, the end-stage renal disease or just a Hess-Bled score, and we didn't even put in the equation the Atkins. And you can see here that 1 out of 3 or almost patients who were hospitalized with atrial fibrillation in a Greek hospital for any reason were potentially eligible. And 70% to 80% of these 1,000 patients had a strong indication. And you can see here what were the main indications. It was prior major bleeding, the stroke on anticoagulation. These were the strong indications. These were the more loose indications. And we also had the poor adherence with almost half of the patients. Now, from the patients that were eligible, most of patients had an upper or lower GI bleeding. So in this particular group, we need to make sure that there is no correctable cause of bleeding. If there is no correctable cause of bleeding, then we have a strong indication for LA closure. In every subgroup, in this study that we published almost 10 years ago, and since this was a physician-initiated study, we tried to investigate these subgroups. And I will just briefly show you studies that we did, subgroup analysis on for each particular indication. And these were the general results. We had the 60% stroke reduction and a 60% bleeding reduction as compared to the events that we would have predicted by the Charles-Vass score and the Hess-Bled score. Now, in the patients with intracranial bleeding, we had 200 patients with previous intracranial bleeding. The results were even better, probably because we were giving only aspirin for the short period after the procedure, which had no real effect in the bleeding in these patients. The stroke severity after left atrial appendage occlusion is also very important. The few strokes that we have seen in this sub-study were mostly non-disabling. More than 80% of strokes were non-disabling, and this is a very important message for the patients. In patients with chronic kidney disease, we did a sub-study, and we found that they had similar procedural safety, and they still had a dramatic reduction of both stroke, TIA, and bleeding. And in the patients with the resistant stroke, the stroke on anticoagulation, which had similar results from the ACP registry, no matter what the patients were sicker and had higher Charles-Vass score, the reduction and the achievement that we had with LA closure was similar to the rest. There are several randomized clinical trials happening. There is a nice review that we wrote recently. You may refer to that in the European Heart Journal, where you can see the studies that have been conducted and the studies that are in progress. You see that we have many studies in progress. The option trial was published recently, and this is what I will briefly present to you. And the top study that we're expecting soon is the Champion AF study. This will be completed in February next year, and this may change completely the field of stroke prevention. So this study compares LA closure with Watchman to NOACs in all comers. It means that we have every potential candidate who has a Charles-Vass score of more than 2 or more is a candidate. No issues with previous bleeding. There is a similar study conducted by Abbott, the Catalyst study. This is a little delayed, but it has a similar patient profile, and we hope we'll see the results soon. The closure EF is supposed to be presented in ESC in Madrid 2 months later, but we're not sure if this is going to happen or it will wait for November. And the option trial, this is already published. It showed some substantial findings published in the New England Journal of Medicine. This is a comparison between ablation plus Watchman versus ablation plus oral anticoagulation. And in half of the cases, 60% of the cases, the two procedures were performed sequential, and in 40% they were performed in the same session. And there was a non-inferiority for the device versus the drug in this group of patients in stroke prevention. And at the same time, we have a very strong stroke reduction for both groups, 1.2% in 3 years. This is a very strong message, means 0.4 per year. And there was the superiority endpoint was met with respect to bleeding. So the patients who underwent the procedure and had a Watchman device, they didn't have bleeding at follow-up, or much less bleeding. And even if you included the peri-procedural bleedings. So this was a very important message, and I will finish with this practical guide on LA closure. Just to go back on the indications. You see here patients with recurrent major bleeding that cannot be corrected, patients with low adherence to anticoagulants, patients with ischemic stroke despite anticoagulation, patients with intracranial hemorrhage, or patients in which we want to avoid triple therapy after coronary stenting, patients with deep LA left atrial appendage thrombus, or the ones that have been isolated with ablation, or patients with renal failure and hemodialysis. These are all potential candidates for LA closure, and we're hoping to send the elephant from the room to vacation to take the adherence out of the equation. Thank you very much.
So this was a very nice talk, as we expected, from Dr. Dzikas. So any comments from the audience? Vaso?
One point is the selection of the patient. Yes. One point is the selection of the appropriate candidates for the LLAO. The other point is the new devices that are coming. And a question is about the device-related thrombosis.
Good. Yes. So the patient selection, it's an interesting thing, and it's there is some let's say peculiarity in the Greek numbers. The LAAO procedures are very low, very much lower compared to the other Western Europe. So maybe in Greece, multidisciplinary teams are not communicating properly, and I don't know, maybe it's we need to talk to gastroenterologists, to neurologists, and must, but most importantly, to convince other cardiologists which are not convinced that LAAO is a worthwhile procedure. And this is very interesting. And now I have a live in a box after this theoretical talk, and Dr. Hadzitofim from our center will discuss a live in a box case that our team did some time ago. And we have also Dr. Voudris with us, and Dr. Mezilis. Vasily, do you have a... So we were discussing about the issue that, LAAO procedures are not being very frequently performed in Greece. Do you have an explanation for that? You've been from the start of the interventional cardiology in Greece. So my idea is that probably the multidisciplinary teams don't communicate a lot, and maybe don't communicate to the other subspecialties or the other specialties like the gastroenterologist or the neurologist.
It's a very difficult issue because at this time there is a competition between pedocardiologists and CAD cardiologists who's going to deal with these patients. Another issue is how to connect these patients. We need to have a neurological department.
So, yes, so it's
very, very important.
Patient selection problems and the patient identification problems.
And the indications.
Yes. So.
At this time, we expected by the end of this year to have some more data implicitly around the indication of these devices.
Yes, and Yes, and it has. It's interesting because when you compare, Greek data with actually Southern European data compared to Western European data, they're a lot. This procedure it's a lot less frequent, and if you take into account that it's in the States, it's the increase in the number of LAAO procedures is incrementally increasing. Actually, it's increasing a lot more compared to TEER in MR or TR and the TAVI together. So this is very, very. It looks very, very promising. So, Maria, can you describe our case? Exactly. So, yes.
More than 10 years. You remember the first study in 10 years to complete this.
Yes, definitely. So, Maria.
So, good evening. As a follow from Dr. Trikas, he told us everything about the theoretical part from the LLA occlusion. I'm now going to show you a case that was performed in our hospital. It's about a 66-year-old male who is under oral anticoagulant therapy with apixaban 5 milligram twice a day. The reason is the persistent atrial fibrillation that he's having, but unfortunately he suffers of recurrent severe gastrointestinal bleedings with habefol and transfusion need. His CHED-VAS score is 3. And his HASPLET score is 4, and that is translated into that he's in a higher risk for major bleeding, and we should advise him, or we should take into consideration alternatives for anticoagulation. An alternative is the LLA occlusion. In order to do that, we have to screen first the patient. One way of screening, we could do a CT scan in order to see how the morphology of the left atrial appendage is. As we can see in this picture, and of course in the TOE, but I'm coming there next, we have a windsock-shaped LAA. And afterwards, before we did the LLA occlusion, we had a TOE screening, where it's very important to see if there is any thrombi in the LLA or we have spontaneous echo contrast, because of course we are working in the LLA and we do not want to mobilize any thrombi in the arterial system. In the TOE, we do also our first measures. A very important measure is the area of the LAA ostium and also the length of the LLA in order to choose the right device. That could also be done in the 3D reconstruction, where we also can measure the AVA from the LLA ostium. Taking in consideration the high HAS-BLED score from the patient and that he's suffering from gastrointestinal bleedings, we did decide that we want to do a transcatheter left atrial appendage occlusion. We do that while the patient is intubated, and afterwards we do a puncture in the right femoral vein. Of course, under echo guidance, and we do insert a sex French catheter. We go then with the catheter with a guide in the right atrium to the vein, and we go and we have to do for first the transeptal puncture. It is very important that we are away from the aorta, and it's very important to do the transeptal puncture in the fossa ovalis in order to do not have any pericardial effusion. As we can see here, first the tenting from the needle, and then we go through the septum in the left atrium. Afterwards, as you see here, we are inserting a wire in the left upper pulmonary vein in order to have stability. Afterwards, through the catheter, we insert pigtail catheter in the LAA, where we do flash contrast agent. And with this flash, we can measure once again the length and the LLA ostium, the area, in order to be sure that the device that we selected is the correct one. We did select in this patient an Amulet 25. It has two parts, this device, one lobe that is going in the LLA, as we see here, and one disc that is that occludes the LLA ostium. So under echo guidance and also under fluoroscopy, we are inserting the amulet in the LLA, and we try to position it so that it doesn't have any leakage. We do then perform a 3D reconstruction as well as measurements in various grades so that we can be sure that the LLA is occluded from every aspect. At last, we do another flash from contrast agent so that we can be sure that the LLA is rightly and appropriately occluded, as we see in this fluoroscopy video here, that we see that the contrast agent cannot insert the LLA and that it's being left in the left atrium. So afterwards, we decided that as a team that that the occlusion is successful, so we deployed it from the catheter, as we see here. And here I have the end result. That's a 2D image. We see here how the LLA occlusion, the amulet is occluding completely the LLA. And here we have also the 3D reconstruction, the 3D video to see how rightly it is positioned.
So thank you, Maria. This was a nice presentation. So when we deal with this procedure, we always rely with what the imagers inform us. So we need to have accurate information about the size and the type of the left atrial appendage, but mostly if there is thrombus in it or not. And yes, and how accurate is TOE as opposed to CT, the information that Dr. Vrachliotis informs us. So it's pretty accurate in both, or you think, Dr. Vrachliotis, that CT is more accurate compared to the TOE? And of course we have also Dr. Nectari. She can make a comment on that and can inform us on the usefulness of CMR in this setting.
Well, to begin with, what is your take on those places where What is your routine to begin with? I don't know your routine.
So our routine is when we screen patients, we always do a CT, because we want to properly identify the thrombus, but also to have specific information on the type of and to have accurate information regarding the dimensions and the type of the LAAO before
because
at the screen.
Oh, okay. Well, are you telling us that because we don't get too many from you?
Yes, we do from time to time. We don't have a lot.
You don't have a lot. Okay, maybe that's the reason why. So you have 1 or 2 every month.
Well, pretty much, maybe even less.
Okay, so if you want to image and demonstrate the appendage, you have to do it right. And as you very well know, since the patient is in a supine position, if you do a first pass and you image too early, chances are that in a big atrial appendage, you will not have uniform enhancement. So there you will have a pseudo-positive result. That means to the unfamiliar eye, someone will say, okay, there's a filling defect in the left atrial appendage.
So maybe it's thrombi,
So the trick here is to wait, you know, there's second, third circulation of blood, and that will usually do the trick.
Good.
And also, it's a very, very frequent event when we're doing CT, coronary angiograms, totally different, for a totally different reason. It's not unusual to see that the left atrial appendage is not opacified, so there's a potential filling defect, and that's the usefulness of the second low radiation pass we do for the lungs. Personally, I have observed many times that I had a question in the early phase when everything was nice and brightly imaged, but in the second pass, in the low, with low radiation, it filled up, so there was
Good.
no...
So you should always rely on second pass. And that's
But if you want to do a measurement, you have to do a high resolution scan. So we need beforehand to know that, so that the second pass is done with high resolution settings.
So so if you do a coronary angiogram, a CT angiogram, of course you can still spot.
Absolutely.
Yeah.
Absolutely.
So maybe we don't need to tell you that then.
So it's extra work. Okay, fine.
If I can interfere.
Fine. We'll add another paragraph with the measurements.
Dr. Mazilis.
Thank you. We'll be happy to.
To continue from the comment I heard just as I was coming in, I think the numbers definitely are not going up, and there are many reasons for that. First of all, the this is not a big cohort of patients, obviously, and the thing is that the indications were not clear. In the beginning, we were receiving patients who had thrombosis despite anticoagulants, and then obviously the indications have changed a bit now to patients who had Hasbled high score. And another reason is that we're not getting back these patients. Most of them going to other specialties, and maybe the neurologists and gastroenterologists are not convinced that this is the right treatment. Plus the fact that the medications have got better now and safer. And all of these reasons contribute to the fact that the numbers stay low.
Yeah, and then there's the issue of adherence, which of course it's a lot better compared to to the previous decade, but still there is an issue because the Greek study that Apostolos just showed us, still there is a big issue. So 30% of these patients, the Greek patients, don't take the adequate pharmacology. So this is something to be aware of. Yes. So Vaso, you.
So I think this was a wonderful session. The core messages is the selection of the patients, the candidate for the LLA closure or the paravalvular leak closures. The devices that they are coming, the new devices that are coming, and what else?
Yes.
And the communication between the experts, neurologists or gastroenterologists, in order to be
exactly. So we need to communicate each other. So Maria, thank you very much. And so we'll go directly because it's Saturday night and some colleagues need to be away. And the first that I have in mind is Elias Ninos. Is going back to Thessaloniki. So we go to Saturday patient vignettes, and I call Dr. Voudris. Dr. Voudris, can you come here at the point, as a co-moderator? Yes. So, and Elias.
Thank you, Dr. Iakovou. It's a nice session. Thank you, all of you, being here.
Thank you very much. My case is about the transcatheter approach of the multiple valve disease. I will present a case of a 71-year-old female. She was on NICA class 3 under optical medical treatment with 2 recent hospitalizations for heart failure in the last 6 months. She had COPD, diabetes, and chronic renal disease. No coronary artery disease, elevated NT-proBNP, and pulmonary hypertension, and a Euroscore 2 of 7.6. And that's the MR. It is severe MR of ventricular type, if I may say so. And in the 3D, we see there is clearly a coaptation gap between the anterior and the posterior leaflet here, and there also. And that's the tricuspid valve. There is also a TR, which is massive. You see here the vena contracta and the pisa. And again, it's a secondary severe mitral regurgitation, dilated LV with ejection fraction of 45%, and a massive TR. The question is, what should we do? Should we treat isolated the mitral valve? Should we follow a wait-and-see strategy, or should we perform a concomitant therapy of both valves? And there are, for the concomitant therapy, pros and contras. Improved outcomes with concomitant therapy, no risk of undertreatment of the progressive TR, no need for additional general anesthesia and vascular access in frail patients, and no additional hospitalization required. There are the pros. Contrast are the possible overtreatment of patients with reduced TR post-TEER. That sometimes there are problems with the imaging of the tricuspid valve, that we need sometimes also separate the delivery system and more money. Unknown is the learning curve, the technical feasibility, and of course, if there is an increased peri-procedural mortality or other MACEs. We decided for combined M-TEER and T-TEER. And we start with the mitral valve. We see our device open here. It's an XDW mitral clip. And then after clocking and performing a 3D also on the ventricular side, then we perform the clipping on the right panel, and we record also the grasping to review. But we see that there is a remaining jet on the lateral side, and we put a second clip here with nice result, as you can see. And after that, we assess the ASD, and you see there is a right to left shunt through the iatrogenic ASD. And we go then after inserting the clip on the right side now, we go for the tricuspid valve. That's the transgastric view to clock right the clip, and that's again the transgastric view. We go for the anteroseptal
And that's the mid-esophageal view. And we put one device and reduce the regurgitation. And that's the end result of the tricuspid valve clipping on the left and the mitral valve clipping on the right. And after that, we had an oval-shaped 7 millimeter iatrogenic shunt ASD with remaining shunt, and we decided to close it with a device. And you see, we put the device here, and we close also the ASD. That's also the result. After 1 month, there is a trivial MR, a trivial TR, and no ASD flow between the right and the left atrium. Thank you.
So this was an excellent case. So your plan from the beginning was to
go for both parts.
For both. Mm-hmm. And did you anticipate that you might have a problem regarding the ASD iatrogenic, communication?
After putting the clip in the tricuspid valve, we had right to left shunt, an existing and remaining right to left shunt. And that's why we decided to close it.
So, there was no compromise in the hemodynamics of the patient? So
not really. We had the desaturation in the beginning, but we had also the possibility to extubate the patient, to wait and look if it gets better after the extubation. But we decided to close it.
But this is very rare. So patient, I didn't see, but was on pulmonary. Did he have pulmonary hypertension?
Yes.
This patient?
He had pulmonary hypertension. He had also the jet, the remains after putting the clip in the tricuspid valve was directed to the septum. Maybe that played a role too.
Okay, so this is interesting. So, Dr. Mazelis, do you have a similar case? Do you ever close
with the closure of ASD?
Defects?
No,
yes.
we sort of thought of it in a couple of cases, but we waited to see whether there's a desaturation, which did not exist after the extubation of the patient. So we didn't go on to close the ASD. But I'm sure that the decision is not based on the size of the ASD rather than the hemodynamics and the saturation.
So if you have a desaturation, maybe you can wait a little bit and then extubate the patient and then take it from there?
That's right.
Dr. Zarogiannis, do you do that? Okay. Dr. Voudris, yes.
A practical question. What's about the DRG, the approval you're taking?
Yes, about the money, I don't know.
Because it's a good idea to...
I'm not sure about that point.
Because as I've seen, we have an approval for mitral or for tricuspid clip.
We worked with a tri-clip guide, and we put and we did both valves with the same approval.
I think that if you use
the company provide.
Yes.
All.
You can do the mitral and the tricuspid in one DRG. The problem is the ASD closure, which requires a second
indeed.
one. Yeah.
That's a big problem. That's a problem.
Fine.
We also have Dr. Triantafylou and Dr. Spilias as commentators. So, Dr. Triantafylou, do you have a comment on that and the issue that we were discussing on desaturation of the patient and whether or not to wait for the desaturation, probably to go to resolve by itself when you extubate the patient, or do you just place an SD closure device?
Excuse me, Dr. Iakovo, I think I respect the conversation, but one big thing is if we have to do concomitant both valves, or rather we have to do the mitral first and then wait. That's a big conversation also.
Exactly.
ASD closure, okay, depends on several factors, also on the feeling of the team and on the clinical status of the patient.
Definitely, this is an important conversation that we had also earlier today, and we have some very nice examples. But this was complete. This completes the whole conversation, I think. So, if there are no other comments, we can proceed. So, thank you, Leah. We can proceed to second case by Dr. Kalogeras from Soteria General Hospital.
Good evening. First of all, I would like to thank Dr. Iakovo for the very kind invitation to participate in this session. So I'm going to, the next few minutes, to present a case about a complicated redo mitral valve paravalvular leak closure. So our patient is a 68-year-old woman who, despite her low age, had a very complicated past medical history. She had undergone in the past 3 times surgery of the mitral valve with back in 1997, 1998, and the last time in 2014. And since then, she had a Sorin 25 millimeters valve. She also suffers from chronic kidney disease, stage 4. She has right ventricular heart failure, and since 2008, she has a permanent pacemaker implanted, and she also suffers from permanent atrial fibrillations. She came to us due to symptoms of fatigue, new onset dyspnea with characters of orthopnea, with a very severely reduced exercise capacity, New York Heart Association Class 3. From the labs, she had some signs of mild hemolysis and high BNP. As expected, initially we proceed with a transthoracic echo showing good LV function and a paravalvular leak in the mitral valve position. She had right high RV pressures and pulmonary vein systolic flow reverse. As you can see on the right side, we proceed with a TOE in order to investigate further the location of the paravalvular leak. And as you can see, it was you can see at hour 6 in the posterior wall with measures of 5 by 8 millimeters. So based on that and the very high surgical risk, we decide to proceed with the transcatheter PVL closure. Here you can see the attempt to cross the to do the transeptal puncture. Due to very thick and fibrotic septum, we had to use the Bailey's radiofrequency needle. As you can see on the left side, it was quite easy using this device to cross the septum. However, we were not able to further cross the catheters, and we had to dilate further the septum with 8 by 40 millimeters balloon. So the next step was to advance 12 French flex cath, which is a steerable catheter in LA. And using that, we can manipulate and we can position the catheter just above the leak. And using the mother and child technique with a long MPA 5 French catheter in a guide 6 French catheter MPA again, we managed to cross the leak with hydrophilic Terumo wire. Following that, we advanced a super stiff wire in LV. And finally, we implanted successfully an Amplager vascular plug 3 device, 14 by 5 millimeters. As you can see here, the device is successfully released. And on the right side, you can see upright the initial picture of the valve. You can see the PVL, and just below, you can see the device here and the successful closure of the leak. However, 7 months later, the patient came back. She presented with recurrent signs of dyspnea. And as expected, we conducted a new TOE, which revealed a new PVL just close next to the previous implanted device. You can see on the up right side, and you can see the new leak just next to the first initial implanted device. So the surgical risk remains high, so we decided to continue further with a new attempt for a PVL closure. Again, we use the Bailey's radiofrequency needle in order to cross the septum. And with the FlexCath steerable catheter, we managed to cross the leak with a hydrophilic wire. However, if you see here, during the manipulations, in order to advance the catheters, the initial implant device embolized in the left atrium like a fly, and there was an increased risk to get stuck and trapped in the mitral valve. So we decided to proceed with trying to catch the device and pull it back in the FlexCath catheter. The only device we had available in the cath lab was a only single loop snare system that we used, as you can see here, and we managed to retrieve the device, catch the device, and retrieve it back in the tip of the 12 French catheter. However, we were not able to retrieve the whole device in the catheter, but it was partially retrieved, and that was quite tricky. So the next step was to pull it back in the right atrium, partially collapsed in the sheath, and we think that it was possible to pull it back in the right atrium due to the stiff fibrotic atrial septum, due to the repeated surgeries. So we managed to retrieve the whole system back in the right atrium, and the plan was to bring it back in the femoral vein. However, as you can see here, we conducted an angiography from a contralateral vein because, as you can see, the device was quite, due to the large dimensions, we were not able to take it back through the vein, so we called the vascular surgeons, and they helped us in order to retrieve the whole system successfully. Here's the embolized device outside. As you can see, if we had an alligator clip, which could be more useful in order to catch the device from its pins, and it would be able to elongate the whole device. On the other hand, with the loop, which actually we grab the device from the waist between the two discs. You cannot elongate the device, and it's not easy to take it back in the sheath. So it would be useful to have more devices in the cath lab. The patient remained initially hemodynamic stable, extubated. However, a few hours later, she required inotropes. The decision was made to send for a surgery. She had a very long post-surgical course, and unfortunately, she passed away 3 weeks after surgery due to multi-organ failure. So a lot of complications can happen after a PVL closure. Device embolization, as we saw here, valve interference, as you can see in another case of our lab. Here is the device actually interfering with one disc of the mitral valve, and you have to remove and change the orientation in order to avoid interference. It can happen pericardial effusion, heart block, coronary ostial occlusion. A lot of things can go wrong. So closing. Comparing surgery and transcatheter treatment for PVL management, we don't have any randomized trials. However, we have data from registries and meta-analysis like this one, which showed that there's no difference in all-cause mortality between the two modalities. Also, another meta-analysis of 22 studies showed that surgical repair is associated with higher rate of technical success, but with worse short-term outcomes. So, surgical repair should be chosen when you have active endocarditis, when you have a very unstable valve, or when there is need for concomitant cardiac surgery. And also there are data showing that patients with technical failure in a percutaneous approach did not have increased mortality after surgical repair compared with those who underwent surgical repair up front. So this suggests that there are complementary methods, and both surgery and transcatheter closure. So closing, in conclusion, the transcatheter closure offers, of course, is less invasive. It offers better in-hospital short-term outcomes compared to surgery. However, the long-term follow-up, the two methods have comparable outcomes. PVL is a common and underdiagnosed complications of both surgical and transcatheter valve replacement. Percutaneous closure is feasible, but with a significant learning curve. Imaging is the key to success for both pre-procedural planning and procedural guidance, and requires, of course, a very good collaboration between the interventional team and the imaging cardiologist. Thank you.
So thank you, Dr. Kalogeras. This is an amazing case, very learnful, depicts the difficulty in placing another device adjacent to the previously placed. So, you know, we have to be very careful, especially if it's a lateral one, more lateral.
Posterior medial.
Posterior medial.
Yes.
Yeah. Because I thought it was lateral. So yes. What would you think would you do different from the first time? You know, in the second time, you place the same the same plug, or it's?
I'm not sure it's a problem of the plug.
Yeah.
Actually, this lady was very, very, very fragile. Very fragile lady, 3 surgeries in the past. So I think, again, we will go with the same plan, transcatheter closure. Again, the second procedure, because of the position of the leak, somebody could think about transapical access,
yes,
which could be less dangerous for embolizing the device. On the other hand, she's a very fragile patient, and what you want to avoid is to be very
yes, to be very, very meticulous in closing.
So
yes,
I'm not sure we would go with something different.
Yeah.
What the learning from this case was to have more equipment in the cath lab, and we have now in this alligator clip just in case if we need it in the future.
Yeah, this is very important. Dr. Lodiades.
Congratulations on the presentation. Did you answer the question why this happened in the first place? I mean, was this kind of a rocking valve, or was it the dehiscence? If you put the second plug, did you ever think that maybe you could have a leak on another position of that? You know what I mean? Did you have any clue that maybe this was a dehiscence of the surgical valve? I mean, this was a fragile.
There were no signs of endocarditis, if you mean.
No, I mean, because it was a frail patient, so maybe if you put the second plug in, maybe 3 months later, she would come with another hole in the ring. I mean, this is something that you think about the pathology.
Yes, it's something that we see quite often. I mean, you put a plug and then a new leak happens. It's something quite often in my experience. So, and sometimes even if you leave behind a small leak, the hemolysis problem doesn't resolve always. Patients still remain with hemolysis problem.
Notice, Dr. Mazelis?
One thing that you might consider doing differently from the first procedure is trying to deploy 2 plugs simultaneously. This large hole sometimes requires 2 plugs, and the only way you can do that is by deploying them simultaneously. Otherwise, the one may sort of push the other one, and then the results to the condition that you had here. That's probably the only thing that you might
but if you see the result in the echo, the first procedure, it was quite good, and it was not the hemolysis problem of this patient, it was the heart failure problem. So you want to reduce the residual the regurgitation as much as you can. So the initial procedure result was quite good. However, I think there was a progress of the disease, I don't know what, so it deteriorated.
Yes, good. And how do you do that, Nico? You just have a second protection wire in order to deploy both of them?
Yes, you use two wires, and what I found very useful in a case that I had recently was a posteromedial, which is the most difficult to do, like yours, is I used one of the electrophysiology catheters, which are very big, and they bend a lot, so you can go from the interarterial septum and you can look down just over the hole, and then you can
so you use the Agilis,
and
right?
Not the Agilis. There's a drive from catheters that are doing cryo or PFA, which are very big, and they're very bendy, and you can use two sheaths in this simultaneously, and you can deliver two plugs.
Also, the problem of this catheter, the flex catheter, is quite big, it's 12 French, but it's not supportive at all.
That's the reason that the electrophysiology catheter might give you a lot of support.
The Agilis is more supportive, but it's 8 French.
You lose support when you go medially. Yes, that's the problem.
This is interesting, yes. Good. So we have also three from the panel. They're Dr. Poulimenos, Dr. Spilias and Dr. Teradafilou. Do you have any comments? Can we have the three panelists, please?
Good afternoon. I could make a comment if I may. Yes. Thank you for the invitation. Unfortunately, I could not be there with you. First of all, congratulations for having the courage to present such a difficult case that did not end well. I just have two questions. What were your considerations before the procedure, the first and the second, regarding the site of the transeptal puncture? And what were your plans regarding the best alignment possible to deploy the devices?
Regarding the first question, the transeptal puncture, when we aim posterior medial, so you have to, as we mentioned before, to have some high, so it's similar to mitral valve punctures. And regarding the alignment, you mean when you put the device, how you align the device?
Regarding the combination of the transeptal puncture and how you gain height in order to have the best possible ease and maneuverability in order to have a good alignment to deploy the devices, in order not to have friction when you deploy it. I mean, what was the position of the transeptal puncture that you aimed for?
Mid-posterior, actually, like when you want enough high in order to do all this curve and guide your steerable catheter to the posterior medium, where was the...
So it's not posterior inferior, it's posterior medial, let's say.
Posterior medial.
Okay. There are opinions that say that posterior inferior is the best one in order to have the height to be at ease with maneuvering in the atrium, but this is open for discussion. Anyway, the posterior leak that you had was very difficult to reach, and I think at the end of the first procedure, you had a residual leak. I was expecting you to say that you were going to implant a second device to completely seal the leak. Am I correct or not? Or did you just accept a good result in order not to make things too complicated?
Yeah, there was a mild residual leak after the first procedures, but as I told before, because the main problem of the patient was the heart failure and not hemolysis, we were satisfied with this result. It was a very fragile patient, so we stayed there.
Okay, good. So we have to leave it there. So thank you, Dr. Kargeras. Dr. Vouders will present the next speakers.
Okay, so we follow with the third case from the last hospital. And I would like to invite Dr. Perlepe, who will present the case.
think it's in the same vein. You have a paravalvular leak still.
Yes.
One more.
So thank you once again, and thank you for the opportunity to present another interesting case. This one is, again, a case of transcatheter closure of paravalvular leak, but this time after a TAVI procedure. This case involves a 26-year-old male patient with a medical history of hypertension, type 2 diabetes mellitus, atrial fibrillation, and severe symptomatic aortic valve stenosis, which was treated in our department in February 2023 with the transcatheter implantation of a 29 millimeters Medtronic Evolutar bioprosthetic aortic valve. As we can see here from the pre-implantation CT scan, the native aortic valve was heavily calcified with calcium not limited to the valve leaflets, but extending into the aortic annulus and the left ventricle outflow tract, particularly in the region between the left and non-coronary cusps, also clearly illustrated in this three-dimensional reconstruction. You can see the extension of the calcium into the left outflow tract. So pre-dilatation was therefore performed pre-TAVI, followed by the deployment of the bioprosthetic valve, as you can see here. However, due to clear evidence of paravalvular leak on angiography post-deployment, balloon burst dilatation with a 24 millimeter balloon was carried out. This resulted in mild improvement, although a moderate paravalvular leak persisted, as you can see. During close follow-up after the procedure, the patient remained clinically stable with mild dyspnea, and serial echocardiographic evaluation consistently described a moderate to severe paravalvular leak, while left ventricular dimensions remained within normal limits. However, from September 2024, the patient experienced a deterioration in functional status with worsening dyspnea. In response to this deterioration, a new transthoracic echocardiogram was performed, revealing mild dilatation of the left ventricle with preserved systolic function. There were no signs of stenosis of the bioprosthetic aortic valve. However, the paravalvular leak was confirmed and classified as severe based on the size of the regurgitant jet, the measured pressure half time, and the presence of holodiastolic, as you can see here, the pressure of holodiastolic flow reversal in the descending aorta. Moderate mitral and tricuspid regurgitation was also observed, along with mild pulmonary hypertension. A transesophageal echocardiography was subsequently performed, which allowed for better visualization of both the extent and the precise location of the paravalvular leak, situated between the left and the non-coronary sinuses, as seen here, and more clearly here with magnification and 3D imaging. The next examination performed was the CT scan, which, as you can see, provided us with additional information regarding the shape, the length, and the width of the tunnel, and the calcification in the area, all of which are crucial for optimal management. Based on all this, and taking into account the patient's history and age, the heart valve team of our hospital decided that transcatheter paravalvular leak closure should be the optimal strategy. So, as I said earlier this day, in general, there are two main devices available, the Ambulatory Vascular Plug 3 and the Occlutech Paravalvular Leak device. The second one is available in square and rectangular shapes and in two configurations, with waist and without, called twist. And the second one offers greater flexibility in irregular or classified defects, while the Ambulatory Vascular Plug 3 is better and adapts better to smaller round leaks. In our case, based on the crescent shape, the rather narrow and surely classified tunnel, we chose the twist device by Occlutech, and the size was based on echocardiographic measurements taken during the procedure. These are in short the steps of the procedure. The procedure was performed under general anesthesia with TOE guidance, and vascular access was obtained via the right femoral artery, through which 6 French, 9 French, and 10 French introducer sheaths were sequentially inserted. An initial attempt to reduce paravalvular regurgitation was made by balloon dilatation of the valve using a NewMed 25 to 40 millimeter balloon. However, due to the persistence of significant regurgitation, as you can see, the decision was to proceed with paravalvular leak closure. Initially, we managed to cross the paravalvular leak with a straight wire through an AL1 6 French catheter. But AL1 itself could not be advanced through the tunnel of the leak, as you can see. So we overpassed this problem with the mother and child technique, which means that we advanced through the AL1 guide catheter, a longer 5 French multipurpose catheter, which was able to be advanced further into the tunnel and the NV, as you can see here. The straight wire was then removed, and the Landerquist wire was advanced into the left ventricle. Subsequently, a Nocultec 5 French sheath was inserted via the right femoral artery, and then the device was advanced through the sheath, and the first disc was extracted into the left ventricle. The entire system was then retracted until the first disc reaches the outflow tract of the leak. And then the twist segment and the second disc were deployed. After confirming the stability of the design, an angiography through the sheath was made, showing persistent regurgitation, as you can see. But an increase in diastolic aortic pressure was observed, and the echocardiography also showed reduction of the regurgitation jet, so we decided to release the device, as you can see here. And this is the final angiographic result. The patient remained stable, and his hospitalization was completed uneventfully. And at the scheduled 1-month follow-up, despite the echocardiographic evidence of residual paravalvular leak, as you can see here, the patient reported marked clinical improvement. And he says that he is now able to walk up to 500 meters, corresponding to an improvement to an EHA class 2. So in conclusion, paravalvular leak is a relatively common complication after TAVI, and one of the most important anatomic risk factors is severe annular calcification. In our case, the patient had extensive calcification, which likely contributed to PVL formation. Fortunately, percutaneous closure was rather successful, and the patient experienced significant clinical improvement at follow-up, despite the presence of residual regurgitation. This case highlights the importance that PVL closure is a safe and effective option in selected patients. Thank you for your attention.
Thank you, Dr. Perlepe, for your excellent case. The first question is, do you think that the paravalvular leak is because of the calcification, or the valve was deeper inside the left ventricle?
No, I believe that this was because of the calcification, because as you saw, the leak was exactly in the region of the calcification that we saw before TAVI. So I think that this is the reason.
So because of the position of the valve?
No, because of the calcification.
For the calcification?
Yes, clearly.
And for this reason, you decided to have a leak?
Yeah, it was heavily calcified, as you could see in the initial 3 Mensio. So it was we expected in the initial procedure to have some leak, but we did pre-dilatation. We were really modest because we were aware of the calcification extending at the LVOT, and we were afraid to disrupt the annulus. And this case is very similar to the initial case that the case that Dr. Pilates showed us yesterday. So he had a similar expansion of the pre-dilatation balloon The left cusp was never been properly approached by the balloon, so he ended up rupturing the aortic annulus. So this is something that would always pay special attention, because it's something that maybe you cannot get away with it. But definitely there was at least moderate AI. So at that time we checked, and it was the AI index was 28. So we left it alone. But as in the next year and in the next follow-up year, you will see that there's deterioration of the clinical status of the patient. So we need to do something. And I think this is that this is a good approach. We need to be able to tackle these cases and maybe not be afraid to place a plug when there is a need to be placed. Dr. Kalogeras.
Congratulations for the case.
I'm sorry. Please, microphone.
I think it's Evolutar.
Evolutar. Yeah, would you think because of the massive calcification, a pro would avoid this happening initially?
Yes.
Because it was a perfect landing height, so obviously the calcium was the problem. So probably the pro would be better for that.
Probably, but we don't know. Yes. we saw also in pro as well. So.
And another issue, because I want to share with you a similar case we had in the lab, and trying to, because it was just a few months after the initial implantation, trying to cross the leak with the sheath and the liver sheath was quite risky to embolize the device. So we kept it with a snare the whole valve in order to avoid migration or embolization of the valve towards the ventricle.
Of the valve, yes. But after 1.5 years, I don't think it would be really, maybe. And with such a huge calcification, I don't think that the valve was pretty stable. So, Vasily, you were asking about the technicalities of the.
I think that this may happen because the valve, because of the calcification, is not stable and sometimes move. I don't know if you have signs. And another question on technical view: do you need that? You need to have a transesophageal echo. You had also, yes. Because it's very, very important to. Dr. Mazilis.
It was a great case. I want to ask you a technical question, or if this is very important or not. When you cross the wire, do you check that you are outside the frame, or you go in and out? Does this make any difference to the way that you deliver your plug? Because I guess in this case, the wires seem to be outside the frame.
Yes,
but sometimes you can go in and out.
Yes, but
then you might interfere
we check with multiple projections and also with TOE, which is very important, as Dr. Wooder said. Yes.
Maybe Dr. Kalogeras remember a case. We implanted the valve. The patient, 3 months later, presented acute pulmonary edema. It was transferred. It entered in the emergency department of your hospital. You try to put...
Yeah, that's a case I mentioned before.
I know this. Unsuccessfully.
Unsuccessfully. We couldn't
and finally,
cross
the patient is operated and had valve explanation.
Exactly.
Finally, he died, not from cardiac problem, but for intestine hemorrhage. It may happen. Okay, thank you, Dr. Perlepe. And I would like to invite the next presenter, Dr. Mazilis, who is going to present his interesting case.
I will change the subject a bit. This case is a bit of everything. Interesting. Some words about clinical data. She is a 67-year-old woman who had worsening shortness of breath and peripheral edema due to tricuspid, severe tricuspid regurgitation. I found the sheet from her first operation, and it was nice to see this historic, so detailed. Morrow, yes.
It's the guy who did the
in Maryland, yeah. That's right. She had complex acyanotic congenital heart disease, incomplete persistent AV canal, valvular pulmonary stenosis. And what the surgeon did is he closed the ostium primum atrial septal defect, closed suture, put some sutures on the cleft of the mitral valve, and did pulmonary valvotomy successfully. When I saw her, this was the transthoracic ultrasound. You see a huge right atrium, very big right ventricle. The valve was definitely distorted. There was a big gap. The leaflets were sort of calcified. There was a patch in the septal leaflet, and you see that this is clearly not a case for a transcatheter edge-to-edge repair, or at least the result would have been dubious. And I'll show you the transesophageal ultrasound. You see here anterior, posterior leaflets. And when we scanned the valve, there was a big gap. Take in mind that this patient was sedated here, so the tricuspid regurgitation was much more than what you see here. And a transgastric view where you see that the septal leaflet is very distorted, very small and retracted. And this is the mitral valve. Where? Oh, okay. Right. So mitral valve, nothing very important there. And there was a small residual ASD, as you see here, but not hemodynamically important. So she had minimal response to diuretics. We did the right heart catheter. She had good right ventricular function. Obviously, she was not good candidate for TEER. And the decision was to perform a tricuspid valve replacement. We had surgeons that were keen to do that, minimally invasive, through a right lateral thoracotomy. And she received an Edwards Magna is 31. This is the result, quite nice function of the tricuspid valve. She also had a pacemaker wire, as expected, but the function of the valve was very good, but the patient continued to be hemodynamically unstable, could not get her out of the CCU. She required anotropes, and we just tried to find out what was going on. And what we saw over the next few days, and this was a dynamic phenomenon, there were few shunts. As you see here, there was a shunt coming from the right ventricle towards the right atrium and a bit to the left atrium, but the most important was a big shunt down here between left and right ventricle. So there was clearly a VSD, which was causing the hemodynamic instability of the patient. You see again here, maybe the picture here is not so clear, but we decided we had to do something, and obviously she was not, again, for another operation, and we decided to close that percutaneously. And we planned the procedure. We did a CT scan. The TO imaging was very difficult because of the valves and the shadowings, but on CT scan, we managed to measure the hole, and the hole was approximately 5 by 9 by 10. So we decided to use one of these ambulature, the muscular VSD occluders. The hole was in transition between the muscular to fibrous defect close to the aortic valve, and we thought that a VSD occluder 10 would be sufficient to close it. I'm going to show you the angiogram. This is a left ventriculogram done with a pigtail, and the hole was located here. And you can see the contrast going to the right ventricle from there. It was quite difficult to find this hole, but eventually we managed to catheterize it with a Cobra catheter, the catheters that they use for carotid interventions. And here we are in the right ventricle, obviously. Exactly as we planned with the CT scan, that the pacemaker lead was up and the catheter was going through down to from the pacemaker lead, and we passed the wire from the right ventricle through to the pulmonary valve in the pulmonary artery, and then we had to snare it and to take it out from the right femoral vein when we had the catheter. And this is the efforts to snare and to pull the sheath from the right femoral vein through to the left ventricle. It was not easy, very difficult, because we were not coaxial, but finally we managed to get through to the ascending aorta here, and the Cobra catheter is here. So the part of the wire that is exposed is only this here in the arch, and I think this is very crucial. And then we removed everything from the right femoral vein and inserted the device. And as you see here, this is the left disc in the aorta, and then pulled back the whole system against the hole here. Still attached to the wire. We did some angiograms to confirm the position and the stability, and then we released the device. And this is the final angiogram. There's still some flow, but all this is common with these devices. The whole thing seals after a few days. The patient gradually recovered. She discharged finally after several weeks in hospital. She's now, it's a few months after the operation, and she's quite happy, taking only 1 tablet of furosemide and in good renal function. So, to sum up, I have a couple of take-home messages. I mentioned the wire. Never leave the wire exposed while performing these maneuvers, because you pull and push quite aggressively, and you might tear the aorta or the valves or the heart like a Swiss cheese. So be careful to cover the wire as much as possible from both sides. And be prepared for a lot of hemodynamic instability. When you pull and push, you pull the tricuspid, you pull the aorta, and then you create a lot of regurgitation. The blood pressure drops. So the role of anesthetist is very crucial in this sort of procedure. Thank you very much.
Congratulations. Very, very difficult.
It was difficult.
Case, very hard work.
We had her few weeks in hospital, and we just thinking what to do, really. And finally we decided to do it.
So the reason that you advanced the sheath to the aorta, to the ascending aorta, was to protect the wire?
No, you have to do it from the right side,
yeah.
the closure. You can never be able to do it from the left, because you're not, as you go down, there's no possibility that you can turn, that you're not coaxial, and it's going to the device will not sort of centralize normally. So you have to go to the aorta from the right side. You have to catch the wire in the smallest possible area, which is the pulmonary artery. Otherwise, there's a lot of space and everything moves. So you leave the wire somewhere when you can catch it with a snare. And then when you pull the wire, you push the catheter from the left side in order to cover it. You don't want exposed wire. And then after you externalize the wire, then you are able to advance the delivery catheter.
Yeah, and your first disc has to be deployed in the higher pressure cavity,
yeah,
right?
you deploy it high and then you pull back. Yes, just to be sure that you're really on the left side.
Also
and leave it to centralize.
Good. Maybe we have some comment from the audience and also from the commentators and the panel. Dr. Spilias, can you hear us? Do you have a comment on the case?
Yes, hello from Miami. That was a great case, very complex case. Honestly, I haven't seen this type of percutaneous VSD closure before. I haven't been part of it, but we've closed maybe a couple of like post MI VSDs that are usually more distal into the ventricle, mid to distal. That was a great case from beginning to the end. And one question I had. Was it way more challenging to cross that VSD based on the location compared to a more like mid to distal VSD?
Well, VSDs are always difficult to cross, but in this case, I think there was the problem with the previous operation. There were calcified patches there, and there was the second valve, which was quite bulky, and the position, which was close to the aortic valve, so you have to go down and turn immediately to the right. So all this made the crossing quite difficult, yes. And also to advance the catheter from the right side. This is also quite...
Great case, congratulations, great case.
A lot of time.
I think, Dr. Spilias, it was a great journey for this lady from 1973. Sorry. I think it was a great journey, Dr. Spilias, for this lady from 1973.
Yes.
Right.
And
from the United States too.
It still continues.
And it was a very detailed surgical report, which you don't see these days. All the sutures and everything was.
Not anymore. So this was really learnful. So maybe you should have next year's prize this year.
Okay.
Yeah. So good. So thank you, Nikos. You can stay here. Okay. So the next case is pre-recorded by Dr. Tsikas. I suppose it's an LAAO.
Yeah. Good afternoon. I would like to present the case, case number 5, left atrial appendage occlusion case, and this is a case with a LA thrombus. These are my disclosures. The environment, as I presented in a previous presentation, in the left atrium can be very variable and can change depending on the hemodynamics. Here we have a patient with low blood pressure and bradycardia, and you see the conditions, and this can change as we increase the blood pressure and we increase the heart rate. So, which means that thrombus can occur in the left atrial appendage in different phases and for different reasons. So I will present you a case with an 81-year-old male with who had an ischemic stroke on early May 2025, while he was on optimal oral anticoagulation therapy with warfarin with an INR of more than 3.5. Subsequently, after the stroke, the ischemic stroke, he had an intracerebral hemorrhage, but he recovered from that and he was gradually improving. In the workup, there was a TE done, and a thrombus in the left atrial appendage was found, which was confirmed by cardiac CT. So the neurologist requested left atrial appendage occlusion as an option for this patient because we call this malignant LAA, and there was a continuous risk for second ischemic stroke. So I will show you the analysis that we did on CT. When you have a distal LA thrombus as the one that you see here, there is an option to close, whereas when very proximal, then there is no room for the device. So here we have approximately 2.2 centimeters depth to deploy LA occluder. We do measurements of the ostium and the landing zone, and we chose the amulet device to close this case. Here you see 3D reconstruction of the CT of this patient. And we can predict the optimal projections during the case. And this is very important because we will not do contrast angiography. We will not inject contrast in the appendage because this may create an embolization of the thrombus. We do also the planning of the transeptal puncture, the CT analysis, as you see here. The transeptal puncture in this case has to be low and mid. Now, there is also a way to take some extra measures to avoid periprocedural stroke. As you see here, we implant the Sentinel cerebral protection device in order to, I'm sorry about the sound, I'm in an airport. So we have the Sentinel in place here. And this is the actual procedure, which is TE guided. And I'm fortunate to have Dr. Papadopoulos Kostas helping me with this procedure. As you see here, we have a 3D, very nice imaging of the left atrial appendage. We have the amulet device that's in the right position. The only, issue with this case is that you don't have. You're not supposed to do multiple deployments, so it is important to go in a single visit maneuver and then just deploy the device. So you don't have quite a lot of room for misizing or deploying the device in the improper position. So I just want to show you also the angio in this case. So we do a non-selective angiography in the left atrium just to evaluate where the disc of the device is going to sit. And then we have the upward projection that is coming from the CT. This is the ball, gradual formation of the amulet lobe, very slowly, and then all the thrombus is trapped behind the lobe. And then we can deliver the disc of the device, and on the right image here, you can see an angiography. Now, it is the only moment we can do angiography, and we see we have complete closure of the appendage and no issues. So this is my case for today. Thank you.
Thank you, Dr. Tsikas, for a very interesting case. Do you think that the presence of thrombus is not an absolute contraindication for LAA?
I think it's pre-recorded. It's not online.
So it's pre-recorded. That's okay. So we move to.
Obviously, the use of Sentinel, the data are not supporting strong use, but would you dare to do such a case without protection, as they did here? I think it makes sense that when you have thrombus,
maybe you need a good radiation, vascular, to be sure that.
But it's quite a risky.
Maybe with thrombectomy sometimes.
Yeah.
That's fine. Okay, so we move to the next presenter, Dr. Korkovelli from Ygea Hospital, Iota.
Dear colleagues, good evening. I would like to thank the organizing committee for inviting me once again in this meeting. So in the next few minutes, I'm going to present to you an interesting case of a relatively young patient. So we have a 61-year-old male, quite obese, with 46 BMI. He presented at the emergency department with acute respiratory failure and hypoxemia. He had a history of MV prolapse, but he didn't follow up. He didn't go to any cardiologist. And he had a history of arterial hypertension. This was the chest X-ray on admission. His CRP was 7, BMP of 500, and increased white blood cell count. I need to mention that all cultures on admission and during his in-hospital stay were all negative. So this was his chest CT on admission. You can appreciate the bilateral pleural infiltrations, the bilateral pleural infusions, and the pulmonary infiltrations. So the radiologist said that there's definitely the infection on the top of acute pulmonary edema. So this was the transthoracic echo. So you can see a torrential mitral regurgitation due to the flail of the posterior leaflet of the mitral valve, and the coaptation gap around 30 millimeters, which is quite big. The LV was mildly dilated with good contractility, as well as the LA, which was again mildly dilated. And this made us think that probably the whole condition was acute or subacute. So what we have a 61-year-old male, obese, with acute respiratory failure, pulmonary infiltrates, and a picture of probably RDS in his chastity, severe mitral regurgitation due to posterior leaflet flail, good LV function, pulmonary hypertension. The patient was starting high-flow oxygen, IV diuretics, empirical antibiotic treatment, and steroids, I'm sorry. So this was his chastity on the 6th day. You can see that there's definitely no improvement. There was no clinical improvement as well. And on the 8th day, because of hemoptysis, he had a CTPA. There was no emboli, but you can see how tragic his lungs are. So we had all this. We had a patient that didn't went well, despite what we did. We had to make a decision. So the heart team discussed, and there were two options, either the surgical MV repair or replacement, or the transcatheter edge-to-edge repair. So this was the transthoracic echo of the patient. So you can see the flail of the posterior leaflet with the ruptured cords, the regurgitation, more views of the mitral valve and the P2 prolapse. And basically, the posterior leaflet had no support. There were ruptured at least 3 cords, so it was unsupported. The planimetry showed an MV area of almost 10 square centimeters, big valve, and the posterior leaflet length was 25 millimeters, and the anterior like 30 to 35. The systolic flow reversal in the pulmonary veins indicated severe regurgitation, and there was also a mild tricuspid regurgitation. So the right air cath showed an area of 50, PA of almost 50 millimeters of mercury, the wedge pressure was 30, and the cardiac output was 6 liters. No issues from the coronary vessels. So based on all that stuff, he didn't have coronary artery disease. He didn't went well with what we did, and the fact that he had these lungs made us think that probably this patient wouldn't survive, and he couldn't be weaned off the mechanical ventilation after an operation. So we thought that probably the most viable solution for him was the transcatheter edge-to-edge repair of the mitral valve. So we were planning initially for 2 devices at the A2, P2 segment. This is the guide sheath in the left atrium. We went for a Pascal Ace device. So this is with the open device just underneath the valve to the lateral segment. We tried multiple times, simultaneously grasping, and this was the final result after the first device was released. And we had good grasping at the A2, P2 segment. We know that the lateral part was quite okay, but we had to put another device medial to the first one. And this is what we did. This is the positioning of the second device, medial, but not very close to the first one. Again, it was multiple attempts, simultaneously grasping. This is after we closed, but not yet released the second device. And this is what we had after we put the second device. And we tried to optimize the second device, mostly because we wanted to see if we had enough length of both the posterior and the anterior leaflet inside. So we did, so we didn't change or move it at all. And this was the final color assessment which in our opinion was quite good, depending on what we had in the beginning. And this is after we released the second device. More views, and the final result with the 2 Pascal ACE devices. So this is the fluoroscopic image. I need to say that the devices are quite movable. They're moving a lot when we have DMR. They're more stable when we have ischemic mitral valve issues. Normalization of the PV flow after that. And this is how we remove the guide seat from the ELA. We had a very small left to right shunt. And the mean gradient was for like 5 millimeters, were very acceptable. And the planimetry of both the lateral and the medial orifice was calculated to 0.8. So the patient stayed in the ICU for 48 hours. He improved dramatically after that. He was discharged home 6 days after the procedure with 180 milligrams of furosemide, eplerenone plus amiloride, and steroids. He came 1 month later. He had lost 5 kilos. And he was like in 120 milligrams of furosemide and a tapering dose of steroids. We optimized his medical treatment just to have like lower blood pressure and heart rate. I'm sorry about the images, but I need to remind you that he was still 120 kilos. And we had like a mild to moderate I would say, residual regurgitation, but it was the best we could do. And the patient felt better, so that was our purpose from the beginning. 6 months later, 20 kilos in total less, good hemodynamics, less furosemide, no steroids, and the final echo views. The most important thing is that we didn't have any the image is quite the same as we had immediately after the operation and 1 month later. So to conclude, I would say that MTR is the most important transcatheter treatment strategy of the mitral valve. We have technical device improvements, and because of that, the MTR is an effective option in selected patients. The MTR is currently recognized as an alternative to surgery in the latest American European guidelines, and in acute MR seems to be a safe and effective approach and to be present in all algorithms for the management of acute mitral regurgitation. Thank you for your attention.
Congratulations, Dr. Kurkovelli. It was a fantastic case. So in the future, we'll expect to have a MTEER call.
MTEER? I'm sorry?
MTEER call, as STEMI call.
I mean, I don't know if it's in the near future, but it's an option.
That's for the new generation.
Yeah, definitely.
And of course, it is a question because this gentleman was 61 years old.
Yes. Mm-hmm.
How long this procedure will last?
We don't know. It depends on him, to be honest, because if he remains
based on the experience already existed.
Mm-hmm. I think at some point he will have like a proper operation, but he couldn't be the case at this point. He was very unstable and he couldn't manage an operation. So if you ask me, I think probably in 5 to 10 years he will have like a proper operation in his mitral valve. But I mean, he's good now, feeling okay, and he went back to his daily activities. So yeah.
So this is an amazing case. Congratulations, and for the presentation as well. So did you have any radiography and chest X-ray in the patient? Did you have any?
Afterwards.
The lungs. How are the lungs?
Yeah. So we still have infiltration. So he has fibrosis as well. But I mean, it's not. I mean, I didn't put it in the slides, but it's better. But it's not definitely as it probably. Not a clear lungs, and probably he won't have clear lungs. We don't know what happened. We didn't have any viruses or something that might. So
and I noticed that you didn't change the diuretic, right?
No, we didn't.
Yeah.
We changed. I mean, we reduced like by 1 the Lasix, but I mean he stayed on 3.
Yeah, this is something that we discussed in detail in the morning, so we shouldn't be. Don't rush in order to change the diuretic dosages before. And so if there is an on-call, duty in our hospital in Mitral, I know the guy. So Dr. Elodiadis, So do you have any question, since you are going to be on call in these situations?
Congratulations on the...
Are you still ready?
Yeah, I'm ready.
For the ECMO, he's a constant, on call for ECMO and the mitral clip now, yes?
Yes,
especially in the early hours. Yeah.
Dr. Voudis, I'm always on call for his patients. So congratulations on the patient. Maybe this is like an CTO, this is an investment procedure. Now he lost weight, he's okay, he's better. Okay, this is not an optimal result, but maybe in 10 years or something, he could have a replacement of the valve, and so excellent result.
Okay, and Dr. Katsianos has a question, and maybe Dr. Poulimenos, if he's still around.
Yes, I was eager to speak. It was a brave decision. Congratulations and many thanks for being here, Dr. Iakovou. Congratulations to the team of Aegea Hospital. Let's reflect on the case. You have a patient that might be septic. You have a patient with a flail valve that might be endocarditis there. It's not very possible because of the excellent imaging you had in the TE, but nevertheless there is a slight possibility that is the cause of the problem, some endocarditis. Yet this patient would be lost if you didn't do what you did at the end of the day in a technically demanding operation, and with a very nice planning, as always, by your team. Pascal, I think it was very beneficial for this patient, and of course the results put many kudos on you and the team. I don't know how many of us would take the decision to operate in a possibly septic milieu, though, and but the result is that counts at the end of, is always that what counts at the end of the day. Congratulations.
Thank you. Just to mention, because I mentioned in the first slide, so the patient had all the cultures, because he had like repeatedly blood cultures, sputum cultures, everything was negative. So he had a septic-like appearance, but we didn't have anything. So that's another thing that made us...
But yet, as you know better than me, there's a whole category of culture-negative endocarditis.
Yeah, definitely.
So that it's not, you are not completely safe. You can never be completely safe when you have this clinical presentation. So congratulations.
Thank you.
And Dr. Katsianos, one final comment.
Thank you. Congratulations, Jota, for the great presentation. As Dr. Voudis and Dr. Poulimenos said, actually it was a rescue intervention, and in such cases, Dr. Poulimenos, we have the go from our infectiologist. A definite go before we proceed, and indeed we have to say that we can use devices with a strong grasping. In this case, would also be possible to have a good outcome with the mitral clip, which shows the Pascal Ace due to the strength of the clasping, and I think we shouldn't consider a P10 in such cases. Because of the spacer, and then it doesn't have a lot of strength by clasping this device.
So do you think in this situation a more rigid device like the mitral clip would be a better proposition, or you think it would be more traumatic?
No, I think it would be a very good proposition, yeah.
Okay, good. So Jota, thank you so much.
Thank you.
So the next speaker has a somewhat familiar name, and we know that he is excelling in Minneapolis Heart Institute, is Dr. Kostas Voudris. So Kostas.
Hello from Minneapolis, and thank you to the organizing committee for the invitation. I'd like to present a case for mitral valve and valve with balloon-assisted anterior mitral leaflet modification on behalf of the structural team over here at the Minneapolis Heart Institute. Our case is a 72-year-old female. She has a history of rheumatic mitral disease. She had a prior surgery back in 2014. At that time, she received a 25-millimeter Edwards Magna valve with concomitant tricuspid valve repair. She has multiple back surgeries with chronic back pain and sciatica, COPD with restrictive pulmonary disease. She came to our attention as a second opinion. She has known degenerated mitral valve bioprosthesis. In the context of heart failure exacerbation, shortness of breath, and NYHA class 3 symptoms. She's been optimally medical treated, and I think just looking at her TE, there's no question that her symptoms are clearly originated from a heavily calcified, degenerated mitral valve with a combination of stenosis as well as regurgitation. You see a mean gradient of 20 millimeters of mercury on her transesophageal echocardiogram at a heart rate of 65 beats per minute with minimal opening. She was originally evaluated combined with our surgical team, and our plan was for a redo surgery given the fact that she had a smaller mitral valve placed at the index surgery. However, when she came in for a right heart cath prior to her surgery, lots of things were discovered that were not previously expected. So she does have severe pulmonary hypertension. You do see almost systemic pulmonary artery pressures and PVR of 9 Wood units. And that was in the context of moderately enlarged right ventricle with globally reduced RV function. And as a result of that, there arose a lot of suspicion of the ability of this patient for post-surgical care and whether that RV would be able to tolerate another redo surgery. So we always get a CT heart morphology to actually better assess the anatomy of the valve, and you can nicely see the mitral annulus in systole and diastole. If you were to go to the mitral valve and valve app that's been developed by one of my partners, Dr. Bapat, you'll nicely see that a 25 millimeter valve actually has a true ID of 24 millimeters, and it is fracturable using true balloons. So if you were to consider a transcatheter mitral valve, you will be looking at a 26 millimeter sapien, and it will nicely show you also the position of the valve so as to make sure that there's no leaflet overhanging and the valve is not ventricularized. The things changed a little bit when you assess for neo-LVOT. So you see a small neo-LVOT less than 100 millimeters squared, and if you were to look for a skirt neo-LVOT, that will bring it about 180. So not exclusive for transcatheter mitral valve and valve, but it will definitely require a leaflet modification. And that's our clinical challenge. So you have a really severely degenerated bioprosthetic mitral valve, almost systemic pulmonary artery pressures with significant right ventricular dysfunction. You have the risks, the inherent risks that come along with redo surgery in this population. She's already having enough comorbidities, and she has a class 3 symptoms. And you have a mitral valve in valve, which is high risk for LVOT obstruction if you were to proceed without leaflet modification. So the decision of the team was to proceed with Batman procedure, and that's pretty much the balloon-assisted laceration of the leaflet and then placement of an S3 through it. This was done in a multidisciplinary team. You can see the imaging from my colleague, Dr. Hamid. We proceeded with a transeptal puncture, balloon septostomy, 14 by 40 millimeters balloon to allow over an Inoue wire to allow for our Agilis catheter to come through. The most important part of this procedure is actually identifying the leaflet that you need to lacerate through, to transverse through, and make sure you transverse at the base. So that's a key component. Otherwise, you will not have enough leaflet removal to establish a safe deployment of your sapien valve. So 3D NPR, again, from my colleague, Dr. Hamid, you can nicely see that we identify the base of that anterior leaflet. Once we're sure, we electrify through it. We use a Asahi Astado wire, quick electrification. We pass into the left ventricle. We proceed with externalization of the wire across the aortic valve. 3/0 by 15 compliant balloon to create a little bigger hole at that base of the anterior leaflet, and you can nicely see it on the TE that we're right at the base of it. Following that, this is a technique, there's a lot of modifications in that technique that have been described. This is our own modification we'll be publishing soon. Instead of actually going aggressive with ballooning of the leaflet and creating a big tear that would create hemodynamic compromise, we actually do kissing balloons. So we put a second wire through the same hole and we proceed with 2 inflations, one next to each other. We believe that this technique, as you can see down on the TE nicely, it will actually allow you to expand the hole more basal instead of across the tip of the leaflet. And as a result, it will still maintain will maintain the leaflet intact. So you can nicely see our kissing balloons in the middle picture. Following that, we bring in a 26 millimeter S3 valve. Across it, slow deployment under rapid pacing. We control the position. You don't want to be very ventricular because otherwise you always run the risk of LVOT obstruction. You don't want to be too much atrial because you will end up having leaflet overhang. And that's the picture right after the valve deployment. You can see a nicely expanded sapien valve. We had already pre-decided, knowing that's a 25 millimeter valve, that we're going to proceed with the balloon post-dilation. We only have some trivial wire-related valvular regurgitation. So you can see our true balloon, 24 millimeter, and expanding the valve more so we can get better valve expansion, more symmetry, reduce the risk for leaflet pinwheeling, and increase the longevity of this valve. And this is our final picture. So you can nicely see no regurgitation, no PVL, no LVOT obstruction. We have a final gradient of 3.7 millimeters of mercury. That's a heart rate of 60 beats per minute. And because we had created the iatrogenic ASD that we had ballooned, we opted to close it with a Gore cardioform device. We got invasive gradients, 2.6 millimeters of mercury from the mitral transvalvular gradient, and a 7.4 peak-to-peak LVOT gradient, so no LVOT obstruction. Patient was discharged home 3 days later. She's doing great, back to her home state and feeling great and enjoying her daily activities. So take-home message, transcatheter mitral valve is a great option for high-risk reduced surgery patients. In a lot of those cases, anterior leaflet modification is required in order to mitigate the risk for LVOT obstruction. Balloon-assisted translocation of the mitral anterior leaflet is a potential therapeutic strategy. Keep in mind, it's a pretty novel technique. There's limited data regarding its use and its success rates. And currently, there's a lot of different small modifications of the procedure being described. Thank you.
So, Costa, thank you for this excellent presentation, amazing case. Everybody learns a lot, from these cases. So it's a modified Batman technique, and it's let me ask, how easy is, of course, in order to have a successful Batman, you need to target the base of the leaflet, right?
Absolutely, this is correct.
How easy is to get to the base of the valve of the anterior leaflet?
The very honest truth is that you need excellent imaging. It takes a team. It's not a one person. Fluoroscopy has a lot of limitations, and one of the basic limitations of fluoroscopy is that it's two-dimensional. So if you really want to confirm you're the Batman, you are at the base, you have to take your time, depend on your sonographer, get multiple views. If you're not sure, what we've previously done is rapid pace, so you can actually stop the motion of the leaflet and confirm that you are truly at the base of it. When you cross with your wire, if on imaging you confirm and you're not at the base, you just have to recross. It's one of those procedures that it takes time to. Actually, it's the most crucial step, and once you achieve that, then the rest is kind of moving forward at a higher pace. But it's that make or break moment.
Amazing. So maybe we can have a comment from Dr. Spilias from Miami. Maybe we can go from Minneapolis to Miami. Is it possible to have a comment from Nico? Because 2 years ago he presented the first Batman technique, the original, and maybe you would see that this is the different, is the same animal but a different iteration. So you use kissing balloons, right? You said?
Yeah.
Yes. So, sorry, Nikos. So we use kissing balloons on this one. This is our own modification. There's a few out there. Our rationale behind it, and we have some bench testing behind to show it, is that instead of splitting the leaflets more like base to tip, that's going to create the hemodynamic instability. You increase your base to base split. So that allows you, the whole reason you balloon for is to actually allow for a valve to be, to cross through it. So that's the main target of it. It's not to completely get rid of the leaflet at that step. That's later on. The valve will trap the leaflet. You don't want to remove the anterior leaflet at that step. So everything you do is try and make your hole as big as possible, deliver your valve, while your patient stays as stable as possible.
So it's a safety measure. So Nico.
Exactly.
Yes.
Dear Constantina, great to see you again, even if it's online, and amazing case, amazing technique. And I'm very happy to see the continuous improvement of this technique. Now with the kissing balloon inflation, which provides, as you said, probably a little more controlled, laceration of the leaflet there. And yeah, in the case, I presented a couple of years ago, we had used a 12 millimeter peripheral charger balloon, that the same one that we used to do the septostomy. So we used the same one also for the leaflet. So it was a 12 millimeter balloon, and I created, quite a large hole. And as you said, the goal is to create some space for the sapien valve to get through. Amazing technique. And another thing I noticed, and I wanted to ask you on the TE, on the surgeon's left atrial view, it looks like one of the valve, the mitral valve, the posterior mitral, it was my impression probably, was not like fully aligned with the aortic. So one of the commissures was a little bit close to the LVOT or the aortic valve.
You're absolutely correct. Yeah, you're absolutely correct. So it was placed, what my surgeon called it as the old way of placing the mitral valve. So the commissure was coming more closer to the LVOT than actually having the anterior leaflet covering it, which is why we opted to actually go with Batman instead of Lampoon in this case, because we felt that lacerating like in the middle of the leaflet would not really give you the splay you need necessarily if part of the commissure is coming in there also.
Right. My question was if that alignment, or let's say not perfect alignment, made the procedure more difficult in any way, or not really?
Not really. It's just, it was the tipping point for us to decide whether we're going with Lampoon or Batman, more than that. We still approach it the same way. The main problem with that would have been if it was right in the middle, then you would have two leaflets pretty much affecting, and the technique would not have been efficient. So the fact that it was only a little bit anteriorly directed, but not a lot, allows us to make sure that just by removing the anterior leaflet, you would still have enough space.
Yeah, amazing case and result. Congratulations.
Thank you.
Can I make a comment? Congratulations, excellent case. I want to ask you, you said that the problem is frequent with these valves. I thought that it was more frequent with native valves, when you have MAC and you put a valve there. Do you think that the frequencies has to do with the type of this valve, or the way that it sits, or the small morphology? What's this? How frequent do you think is this problem with the prosthetic valves to obstruct the LVOT?
I think it's a combination of everything. I think it's actually everything originates from the original pathology of what caused the initial valve replacement. So a lot of those times you either have like a rheumatic heart disease, or you'll have some primary MR. The ventricle is not dilated. And as a result of that, you have a very large dilated left atrium with a normal left ventricle. So the moment you'll put a valve in it, that sits either angular or a little extending into the LVOT, that automatically makes it a problem, which is also what happens with MAC. Like frequently in MAC, you have more mitral stenosis with minimal mitral regurgitation. So surgeons always used to say that MAC protects the ventricle, which is the case. So you'll have a normal ventricle, you'll have a large anterior leaflet that pretty much will interact with your LVOT. I know Nikos also has done it in the past, do Batman or like Lampoons in those cases with like a native leaflet. We always have the concern of how truly protected is your ballooning, and you cannot really control whether it's going to expand towards the aortomitral curtain. In prosthetics valves, you have a ring, and the valve, the annular ring is protecting from extending the laceration towards the native tissue. On native tissue valves, we've done it before, but it's always a matter of concern of what the extent actually, how long will your laceration expand, and whether you're going to actually set into issues the aortic valve and the anterior mitral curtain.
Good, excellent. And one final comment. So, and a question. So, which are the indications of a Batman or this modified Batman technique as opposed to the classic Laboon technique? When do you use which technique to modify?
So I think they're both great options. My personal feeling is Batman is a little bit easier compared to Lampoon because you only have to lacerate once. You don't have to snare, you don't have to electrify, create flying V's and all this stuff. From our standpoint, decision is how much calcification do you have on the leaflet? One of the issues with Lampoon is that if you have a heavily calcified leaflet, most likely the wire will just deviate left and right around of the calcification because you can't really burn through calcium. That's one. Two is where's the leaflet positioning? As we were chatting with Nikos, is it like truly in the middle? Like Lampoon works great in splitting the leaflet down the middle. If you don't split the leaflet in the middle of it and you're like a little left or right to it to create a smaller tear, you're not really relieving the leaflet from the LVOT. Last thing is I think data on Lampoon are a lot more. There's a lot longer period of data. There is a lot of published success rates, and it's definitely a more established technique. This is a lot newer. We're learning a lot from every case. And I think that it's still a growing field. So both are options. I think you always look into the anterior leaflet. Is my first step is always look at how much calcium does the anterior leaflet have, what's the chance of a successful Lampoon, and then take it from there.
Good, excellent. So are there any other comments or questions? Okay, good. So Costa, thank you so much. Thank you for your contribution.
Absolutely. Thank you for the invitation.
Thank you. So the next presenter will be Dr. Lodiadis. We have some change because he may be on call for mitral clip work later.
MT call.
Actually, this is a good idea. Maybe we should start, and I see Dr. Bonios, so maybe we can discuss. Maybe you need some heart failure department has, there's a need for better coverage, right, in this situation, yes.
It's always good that you come up with such good ideas. Okay, so this is an 85-year-old female who underwent mitral valve replacement with a biological EPIC 29 millimeters and TV plastic with a physio ring with a preserved ejection fraction. This happened 9 years ago. And last year, she underwent pacemaker implantation. In the last 6 to 9 months, she had a shortness of breath in mild effort. Coronary angiography revealed no significant disease, but she had moderate pulmonary hypertension and a slightly reduced cardiac output and cardiac index. Transthoracic echo showed severe stenosis of the EPIC valve with a mean gradient of 12 millimeters mercury and an MVA of 1.2 square centimeters and severe mitral regurgitation and moderate to severe tricuspid regurgitation. You can see the labs here, and TPRO-BNP was over 4,000. You can see the medication, and so this is a symptomatic degenerated biological mitral valve replacement. She had to undergo some kind of intervention with an STS score of 2.1 and Euro score of 15%. These are the images I showed you. You can see the calcified, degenerated mitral valve replacement, severe MR, severe MR, severe stenosis with a mean gradient of 12 millimeters mercury and And so a few words on the valve. This is a valve, the EPIC valve is a valve with porcine leaflets. The leaflets are mounted inside the stent. You can see the dimensions of the valve according to the application, and we opted to go with the Resilia valve, which is the valve that has a CE mark for transfemoral valve, transcatheter mitral valve replacement. This is once again from the application. This is the part of the left ventricle. This is the part of the left atrium. You can see that the marker of the Resilia would be slightly in the ventricle. We could go with 33 ml of dye, and this is the what we have to look after. You see the skirt is towards the pusher, and the other part is towards the distal end of the delivery catheter, which is opposite to what we know from the aortic valve. We went with the transeptal puncture. We went posterior, so we could have some height to accommodate all of the catheters. And one important point is that we do. This is the coplanar view, so we see the plane of the sewing ring in plane. This was right caudal, so we performed with an SL1 and BIK1 needle on this trajectory, so we could come in a good trajectory related to the plane of the mitral valve ring. There was not too much risk for alveolar T obstruction. You can see here it was almost 400 square millimeters. So we didn't have to do any modification of the valve. And this is, once we did the transeptal, this is a very high V wave of 48, as you can appreciate here. And this is, after the transeptal puncture, we went with an Agilis steerable catheter through the valve. You cannot see the valve. The valve is, this is the ring to the tricuspid valve. And this is the ring, which is you can barely see it to the mitral valve. Sorry, this is the tricuspid ring, and this is the mitral valve. So we went with a pigtail into the right ventricle. You can see the safari wire is upside down. This is the left ventricle, the left atrium. So in TAVI, it's the other way around. And then we put the extra small safari and as a body wire, and performed the septostomy with gradual increasing diameters of the balloons until we went with a 12 millimeters balloon to do the septostomy to accommodate the delivery system. We did the valve alignment as we do in TAVI. We did it in the IVC. And then we had some problems because we could not go. Maybe you can see here the plane of the sewing ring. We could not go through the valve. We kept pushing and pushing. Then we tried several things. We did some. This is the ring. We inflated a balloon and thought that the valve would glide into the left ventricle. Did not happen. You can see here, while pushing, everybody in the cath lab took his shot and kept pushing on the valve, but didn't want to go in the ventricle. Then we started talking about doing another transeptal punction, but we did the easiest thing. We switched to the other wire, and once we switched to the other wire, we removed the body wire, and then we went with 200 beats per minute with rapid pacing. We have to inflate very, very slowly, take our time. You see the markers in the right ventricle. The foreshortening comes from the atrium to the ventricle. A very good implantation. You see the final result, good function, no residual MR. Of course, I had to do, apart from the echo hemodynamic measurements, this is the LV to the PCW. You see there's no stenosis, and once again, the LV to the aorta. There was not obstruction at the left ventricular outflow tract. And this is the 1 month result. You see a very good functioning valve with trace transvalvular regurgitation, 1.8 square centimeters, the gradient of the valve. There's no significant gradient in the LVOT, as mentioned before, and this is the small iatrogenic ASD, which also kind of helps the patient unload from the left ventricle to the right ventricle. So the procedural steps are general anesthesia, intubation, TE, temporary pacemaker from the vein, transeptal puncture. We have to go high, to go posterior to be high. The Agilis steerable catheter, pigtail, 2 safari wires upside down, septostomy. The Edwards delivery system, as I showed, the logo faces down, unlike what happens in the TAVI. The inflow and outflow I just showed before, rapid pacing and very slow inflation, so we can accommodate and adjust the position of the valve. Thank you very much for your attention.
So nice. Any comments from the audience? Dr. Triadafilou, do you have something to comment on? Okay. All right. Nico, what do you say?
It's a great case and illustrates how stable can you be with this sort of prosthetic valves. Now, you think that if you change the transeptal in the original in a different position, it would be more easy to cross the valve. So if you would go a little lower, for example. But for the mitral valve, I don't think you have to be so posterior and high sometimes.
Yeah. I have no idea why we couldn't go through the sewing ring. I have no idea why this. But once we switched the wire, it just went straight forward. I have no idea why this.
I think the one of the safaris was small and the other extra small.
Yeah.
So maybe by changing this wires, you know,
the flexible part of the wire.
Yeah, maybe a little bit more.
Something like that.
Maybe, you know, change the trajectory a little bit. Nico, you have a comment?
Great case, Dr. Lodiadi, a beautiful result. Awesome case. To your point, I really liked your point during the transeptal puncture, how you mark the coplanar. Sometimes what I find helpful is that I put a pigtail in the non-coronary sinus of the aorta, so it's very visible on fluoroscopy in the bottom of the non-coronary sinus, and that also helps me orient, you know, during the transeptal puncture. That's something that I find helpful for my cases.
Excellent. So thanks, Vangeli. So we have Dr. Katsianos from Haie Hospital. The next case. All of the cases from Haie are interesting. Yes, but hopefully they will end up. This will not end up like having a separate procedure. You have to have someone be on call on this procedure as well, because now we run out of people doing on call in mitral clip.
You're becoming obsessed with on call.
Yes. You know, as a director, you have to pay special attention to that.
So, dear colleagues, thank you, Dr. Iakovou, and also thanks to the organizing committee for the kind invitation to participate at your great conference. I would like to present a case, severe degenerative MR. This is our heart team at Hagia Hospital. Our patient, 87-year-old male, BMI of 21.5, dyspnea near 3 to 4, known severe mitral regurgitation for several years. In the echo, LVEF of 73%, degenerative MR with ERO of 1.2 square centimeters, ECG chronic atrial fibrillation, and then normal coronary status from 2016. So we see on the day of admission, the X-ray and the labs of our patient with a BNP of 316 at this point. Comorbidities, hypertension, atrial fibrillation, prostate hypertrophy, and on the medication of the patient, we see also a high dose of diuretics. Our approach to those patients, we always consider factors such as which is the mechanism of the regurgitation, the severity, the jet number and location, the leaflet morphology, the leaflet length, and the mitral valve area. Our patient has a dilated left ventricle with an adequate ejection fraction. We see the dynamic heart model and the global longitudinal strain. Severe degenerative mitral regurgitation, as we said, and the quantification of the regurgitation with the ERO of 1.65 square centimeters. The tricuspid valve shows at that point a moderate regurgitation. We see here the commissural view with a severe MR. And the Live 3D multiscallop prolapse and flail in segments, especially at P3 and P2, with, as we said, the severe mitral regurgitation. We see the biplane analysis of the mitral leaflets in area A2, P2, and falling to the A3, P3 area. We see here the 3D, in the 3D nicely, as we said, the highly degenerative valve, and here also in the glass view. We have a big mitral valve area of 6.8 square centimeters, and as we use, and more often it's really helpful, the MPR analysis here in the medial A3, P3, and the central A2, P2. Additionally, the patient had a PFO. So the summary for echo findings, the mechanism, a degenerative multiscallop prolapse with flail, mainly the P3, P2 region, severe regurgitation, multiple jets, medial and central, indentation in P2, P3 segment, long redundant leaflets, and mitral valve area of 6.8 square centimeters by the 3D planimetry. The right heart catheterization elevated PA, not as much as expected, but as we said, the BNP was only 300 at that point. So we discussed in our heart team the case. We considered the surgical therapy, although in this patient we see a very high Euroscore 2. In this consideration, we thought if it would make sense to repair the tricuspid valve as well. Our heart team decision was to proceed with the TEER, since we were quite confident that we could help interventionally also our patient. So we have more than one devices likely to be needed. Our plan and strategy was starting from medial commissure. There was the need to secure the flail posterior segments. The valve area was good and would probably accommodate easily multiple devices. Of course, we would monitor the gradient, and we knew from the beginning that the elimination of the MR was not likely possible. So our strategy, starting from the medial commissure, and the plan was to implant 3 devices. At the beginning of the procedure, no thrombus in the LAA. Our transeptal puncture was not problematic. We see the very high V waves of our patient. Here is the initial positioning of our first device, the Pascal ACE, which was not commissural enough, so we positioned again in the medial commissure, and we see the clocking of the device counterclockwise. We followed the independent anterior clasping, independent posterior clasping, and then we optimized here, we see on the right side, the optimization of the anterior leaflet. We were confident about the clasping of the device, so we released here we see fluoroscopically the release of our first ACE device, and this is the outcome of after the release, which was quite acceptable at the area of the first device. Here's the glass view. Positioning of the second Pascal ACE device, also a counterclockwise rotation, and we see here the clasping of the device after we moved the second device closer to the first one. So I will move on. Good gradient after the release of the second device, positioning of the third device closer to the other two since we have color between the devices, and we assessed the situation and then were satisfied about the outcome and released our third device. We see here the fluoroscopic images. Good outcome regarding the hemodynamics, and this is the MR reduction after the procedure with a mild residual MR and a mean gradient of 2. And this is a 3D mitral valve orifice area of 2.1 square centimeters. These are the final glass views of the patient and the hospital course. The patient was discharged on day 3 post-procedure, and this was the final echo at discharge. Thank you very much.
This is a very tough case, an excellent outcome and the presentation. Well done. So it's, this illustrates the importance of the heart team. You know, we discussed, I suppose, this is a yellow to red zone case. So it's maybe we shouldn't have tried that. In the early learning phase. So Nico,
and there was a Barlow type valve. So I saw there's some products of the anterior parts as well, not only the posterior. So congratulations, excellent result.
Thank you very much.
So any other comments, Dr. Zarougiannis? Would you try this patient to clip it? There's a microphone over there, maybe.
It's better now? Yeah.
Yep.
Sure. The good thing with this patient is that the valve area was big enough to give us space to try three separate devices in order to achieve that result. But it was a great result. Yeah, I would certainly try it too.
Do you think there is any advantage of the Pascal over mitral clip in such case? In a Barlow type valve.
It is our experience is that in such cases we have to use devices with a firm clasping. Sorry. In such cases, our experience says that we have to use devices with firm clasping as a Pascal ACE. But as we mentioned before, also I think a mitral clip would also have a good outcome in such cases.
Thank you very much.
Thank you.
So the next case is by Dr. Hadzitofi from Onassis Hospital.
So, good evening again. Thank you very much for the opportunity. So, I bring a case from Onassis Hospital with a primary MR that we did perform about 3 weeks ago. So, it's about a 75-year-old male with recurrent cardiac decompensations and dyspnea NIHA 3. In his past medical history, he underwent a cabbage operation in 2016, and also aortic valve replacement with a serine 23 millimeters. In September, he had a pacemaker implantation due to AV block third grade, and for his dyspnea, we did a checkup, and the echoes showed us that there was a severe MR. In order to screen the patient, first we made a coronary angiography. As you see here in the video, we have an LCX problem, so that we did, before we do the screening for the MR, we underwent a PCI with the onyx true core 2.5 15 millimeters, as you see here, and here is the end angiographic result with a good blood flow. Afterwards, we did also, of course, a right heart catheterization. He has pulmonary hypertension from also pulmonary hypertension, and then we underwent a screening TOE. As we can see in the 4-chamber view, we have a prolapse from a posterior mitral valve leaflet with a grade Pisa zone and an eccentric jet that goes anterior. In the bicommissural view, that's the A2P2 segment. We see the leaflet and the leaflet, and I don't know if you can see it in the video. We can see here the ruptured quad that is going from the right ventricle to left ventricle, sorry, to the left atrium, with a great Pisa zone and the eccentric jet, as I told you before. Here we have the 3D reconstruction, also the MPR on the zone, and we can see the damaged, the ruptured leaflet in this A2P2 segment. And we are talking from a type 2 Carpentier damage, and as we see, we underwent this patient because he was relatively young, 75 years old, but he had primary garbage surgery and IV replacement, and also he was a little bit he was frail. So we discussed it in the heart team, and the heart surgeons said he was at very high surgical risk, so we did decide that TEER is the best option for this patient. We decided to go with a mitral clip, and our first option was an XTW because the posterior leaflet was large enough in order to capture it, successfully. About the procedure, of course, the patient got intubated, and afterwards we did the right femoral vein puncture under echo guidance. I leave it here again. And we went with the catheter in the right atrium. Under echo guidance, we did the transeptal puncture. As you see here, we measure always the distance from the mitral valve ring. In this case, it was 4.1 centimeter in order to have enough space to do the next with a guide. Here you see how we went through the transeptal, through the septum, and then a wire into the left pulmonary vein. Here under fluoroscopy, and here you see the echo result. Afterwards, we did through the wire. We went upwards with the guide, with the mitral clip guide, and through the guide, of course, we did deliver the XTW clip. After we went down to through the valve under 3D reconstruction, we tried to position the clip directly in the P2 flail, Of course, we control it also here in this picture underneath the valve after we dive in the left ventricle. Did the last orientation before we go upwards to the valve. As you can see in these two videos, how nicely both leaflets are in the clip, and then we did the clip closure. Before we undergo any other measurements, the first thing is after the clip closure to see the jet. How much color is there remaining? And as we see here, we have a very minor MR. So we did then the gradient, it was under 5, and we did our leaflets controlling, and as you can see here, I have to do it very slowly, how nicely both leaflets, it was here in this case, how nicely both leaflets go into the clip. So we decided to deplode the clip, and as you see here, it stays stable. We deliver here. That was the end result from the after the mitral clip. You can see that we have only a minor MR remaining, and the gradient was 5 millimeter Hg. And we decided to go out with a guide catheter because no second clip was needed. That is the end result in 3D MPR. We see that the damaged posterior leaflet area is completely grasped through the clip, and the result is really nice. And that is the result, that's the transthoracal echo before the patient was discharged. And that was for the day.
So thank you, Maria. I think the interesting point in this case is, you know, if you have a good imaging, then you have a better and a more smooth approach to the patient and maybe a better clinical result. Any other comments from the audience? Dr. Kalogeras, would you do something different, or in HEIA, would you use an ACE in this case or not?
No, it was a very good case. I think the XTW, that's a main advantage. I think it was the best decision for this case. It was a fantastic result at the end.
Good, excellent.
Congratulations for the result, great result, and for the presentation. I think also Pascal ACE would also be sufficient, but of course it was a great outcome with the mitral clip.
Good, so thank you, Maria. So we are approaching at the end of this session and also of this today conference. And last but not least is Dr. Zarogiannis from Euroclinic, recently arrived from Germany, right? From Düsseldorf. Yep, good.
Good evening, dear colleagues. I'd like to thank Dr. Iacovo for the kind invitation. I will be presenting today a case of an 86-year-old female patient with a severe degenerative mitral regurgitation successfully treated with TEER. The patient was admitted to our hospital's emergency department with dyspnea, NUHA 3, no prior history of cardiovascular disease, and her only comorbidity was a COPD Gold Stage 2. The ECG showed a normal sinus rhythm with preterminal T-wave inversion of the inferior leads. The chest X-ray showed cardiomegaly with minimal pleural infusion and no pulmonary infiltration. And the transthoracic echo showed mildly reduced left ventricular ejection fraction with signs of inferior hypokinesia and a severe eccentric mitral regurgitation. The following day, we performed a coronary angiography with no evidence of coronary artery disease. In order to better assess the pathology of the valve and to understand the mechanism of the regurgitation, we performed an TE, and we really confirmed that it is a severe eccentric mitral regurgitation with a three-dimensional regurgitant orifice area of 1.4 square centimeters with pulmonary vein systolic flow reversal. The underlying pathology was also complex, involving both the anterior and the posterior leaflet of the valve. And specifically, there was an anterior prolapse involving both A2 and A3 scallop with flail leaflet of A2 scallop and a posterior prolapse of P2. The flail gap was 4 millimeters and the flail width was also 4 millimeters. The mitral valve area was measured at 3.9 square centimeters with a mean pressure gradient of 2 millimeters of mercury. After completing the diagnostic workup, we calculated the Euroscore 2, which was 6%, indicating moderate perioperative risk, and we presented the case to our heart team meeting. Our surgeons were willing and expressed confidence to perform a minimally invasive repair, surgical repair of the valve, but the patient and the family declined any surgical intervention. So we had to evaluate the patient for transcatheter edge-to-edge repair. According to the latest consensus documents about suitability of anatomical suitability on TEER, our pathology here falls under the category of complex but still suitable for TEER. So we decided to proceed and plan our strategy. In every case, in planning device placement, we always aim to respect the pathology, the native anatomical commissures in order to avoid tension across segments after deployment of our devices. Given the anatomical complexity and the extensive regurgitant orifice area, we opted upfront for a two-device strategy with start medial. And that would be our initial plan, respecting the anatomical commissures of the valve. But we also had a concern, and that concern was that if we created with our two devices a manner of V-shaped configuration, we would also leave a central gap between the devices, possibly resulting in a significant residual regurgitation after deployment. So after internal discussion within the team, we decided to modify our plan and position our medial device slightly more clockwise than usual, thus allowing the second device being placed parallel and really close to the first one and minimize the gap. And that was the plan we proceeded with. So that's the first device, the placement of the first device medially. On the right top corner, you can see that it's slightly more clockwise placed. I have to mention that the aorta is at 6 o'clock. So we use the unhappy smile for imaging. And the deployment of the device was not very easy. Our first attempt was not satisfactory because, as you can see, the grasping of the pretty long anterior leaflet was not, we didn't get enough tissue of the leaflet, so we had residual jet coming through the device. So we released both leaflets and we optimized it, and we managed to grasp enough tissue of both leaflets. And that's the result after closing our device and before releasing it. So we have a nice leaflet insertion. On the right, you can see we have a stable tissue bridge and no jet coming medial to the device. We practically eliminated the medial jet. So we have space, and our gradient of 1.2 millimeters of mercury allows us to place a second device. So we release the first device, And we placed our second device, which was pretty easy because through the first device, both leaflets were better aligned to each other. So with the first attempt, we could grasp both leaflets, and that's our final result after releasing the second device as well. We have a nice tissue bridge. Both devices are placed really close and parallel to each other, and overall, we could reduce the severe regurgitation to only mild. Our mean pressure gradient was 2.4 millimeters of mercury, pulmonary vein signal normalized, and at the 3-month follow-up, the transthoracic echocardiography showed a stable device positioning and still a mild regurgitation. Thank you very much for your attention.
So this was a very, very difficult case, and excellent presentation. Congratulations. It's very interesting. First, we are distracted a little bit, maybe because the aorta is in 6 o'clock.
Yeah, our imager likes more the unhappy smile on the aorta, so we have 3 to 1.
This is a German thing, maybe.
It's your thing.
Okay. So, and the other, you placed the first clip more medially and more clockwise, let's say.
Yes.
But at the same time, did you respect perpendicularity, or it's
not totally?
Not totally.
So
this is something that we always try to do. I don't know. So Vangelis, so if we have been doing this case, so maybe.
No, excellent case. Congratulations. I think the end justifies the means. It was excellent. Sometimes you don't respect the line of cooptation. And like in this case, the main thing is to not have the valve distorted at the end, to not have an eccentric jet at the end. You didn't have that, so excellent case and excellent strategy.
Thank you very much.
Dr. Katsianos, do you have a comment on that? How would Hagia Hospital approach this case?
Congratulations, or I would say herzlichen Glückwunsch. Generally, a great result. Generally, we try to, we have learned that the outcome is not guaranteed better with a second or a third device. We try to place one device in the middle, trying the different clockings, and then we, of course, if the outcome is not satisfactory, then we proceed with the second device. But it was a great outcome.
Thank you. As I said, the regurgitant orifice area was pretty extensive, 1.4, so we thought even with one device we could practically split the jet in half, not really reducing the regurgitation in a satisfactory level.
Excellent. So, Nico, do you have a comment?
Yeah, so excellent case, very challenging anatomy, very severe MR. Yeah, I agree. Usually, it's hard to predict sometimes how what you're gonna end up with after the first clip. So sometimes, you may end up with mild MR in some way that it will be satisfactory for this 86-year-old patient. But the 2 clips work perfectly in this case, and I agree. Usually, as we get a little closer to the commissures, like more medial, more lateral, sometimes not being completely perpendicular, to our plane and being more like candid like this with the clips, maybe it retains the physiological coaptation more of the valve. So that was a very nice, a very nice technique, a very nice orientation there for the clips.
Thank you.
Good. So, excellent. Thank you. Οπότε νομίζω φτάσαμε στο τέλος αυτού του συνεδρίου. Θα ήθελα να ευχαριστήσω όλους όσους συμμετείχαν, είτε με την παρουσίαση, είτε και διαδικτυακά. Ειδικά ευχαριστώ τους τελευταίους που έχουν μείνει. Ήταν νομίζω ένα πολύ ενδιαφέρον συνέδριο. Για μας νομίζω μάθαμε πολλά. Είχαμε μια σειρά από live in a box, 24 διαφορετικά cases που έχουν προέρχονται από το Νάσιο, αλλά από νοσοκομεία από όλη την Ελλάδα και από το εξωτερικό, από ό,τι είδαμε. Είχαμε πολύ καλές παρουσιάσεις, state of the art lectures. Νομίζω πως γίναμε όλοι σοφότεροι και πήραμε διδάγματα, μπορούσαμε να τα χρησιμοποιήσουμε στην καλύτερη θεραπεία των ασθενών μας, γιατί αυτός είναι ο στόχος μας. Ευχαριστώ πάρα πολύ για την παρουσία σας και τη συμβολή σας στην επιτυχία του συνεδρίου. Ευχαριστώ πολύ.